Oh, good, good, good. Okay. Yeah. Thank you. Okay. Then I will finish. Yeah, good. Best.
Hello. A warm good morning to all of you. On behalf of the Organizing Committee 56th IOC and the Scientific Committee, I welcome once again all of you for this third day of the 56th Indian Orthodontic Conference. Um, Today we start the first session. I'd like to request the chairpersons for this session, Dr. Amit Nehete and Dr. Suryakant Pawar, but I think Dr. Suryakant Pawar is not able to join. So Dr. Amit Nehete, please. Um, I'd like to I'd like to invite the first speaker for this session, Dr. Jitendra Bakchandani. Please.
Uh, So good morning to one and all, and it's seriously, know, being the opening person for any scientific session takes few seconds to soak in. So good morning, Pune, and it feels wonderful to be in this city. Well, thank you, 56th IOC, for giving me this opportunity to be here. Thank you to the Pune Orthodontic Study Group and in collaboration with the Indian Orthodontic Society. And when I first read the theme for this IOC Pune, it read Marvins to Millennials. And I had to really get back to my vocabulary as to what Marvins and to Millennials is all about. So definitely it's a perfect blend of experience and knowledge, which has led through the generations till now, the timeline. Well, this is the 11 years challenge of my alumni, like we all were postgraduate batchmates. And this is the picture below is our, during our times of post-graduation. And this is when we met during the pre-COVID times at the Bhuvaneshwar conference. So this is the timeline changed and that is where we have ended up. Well, I always love to be an orthodontist, not just because I am an orthodontist, but it's wonderful to be in this profession. Why? Because hair treatment of any malocclusion has infinite number of plans, and every plan is right in its own way. And why do I say so is because when I look at these class 2 skeletal profiles, the skeletal jaw bases, it definitely becomes dicey at times to make a decision. Why? Because we have to choose from a wide array of treatment options available. So we have procedures available from growth modifications or growth modulation to camouflage, wherein we can extract few, make therapeutic extraction of few premolars, or in cases of complex class 2 profiles where orthognathic surgeries might be indicated. Well, as far as profiles with complex skeletal dysostosis is concerned, decision making definitely does is not that big a problem. But the biggest challenge we face are the wild goose chases when we have to choose between the growth modulation procedure or opt for a camouflage or just do some therapeutic extraction of premolars to solve the purpose. And to choose whether to extract or not to extract. Well, not all class 2 malocclusions, the decision making is that easy. Why? Because not the similar treatment plan will apply to these malocclusions. Have a look at this particular case on your screen. And this particular girl with a retrusive profile, and the case during my initial years after passing out of my post graduation, I opted for doing the extraction of upper first premolars. But I was not really very satisfied when I looked down 1.5 years down the lane. And I felt that I could not do justice to her smile. The buccal corridors were still quite wide and could not give her the kind of a smile and a face to the best of my satisfaction. But whenever I look up to this extraction versus non extraction debate, I feel in the present incarnation of the extraction debate, the dental stability seems to have taken a back seat. It's more, the treatment planning is more oriented towards looking at a more pleasant faces and good looking smiles. Well, down the timeline, growing children's with skeletal class 2 and retrusive profiles, an intraoral presentation, a classical presentation of a class 2 division 1, treated with something like a class 2 corrector, a functional jaw orthopedic appliance owing to his age in he was, and getting results somewhat like this. But more importantly, when we look at the profile of these growing children's, treated with class 2 correctors, I think we do justice to their skeletal profiles without making any therapeutic extraction of premolars. And their smiles, I think we do justice. And definitely, doing these early skeletal malocclusion corrections is definitely the basis or the foundation for a lifetime smile. So, when we come down to treatment planning of these class 2 malocclusions, definitely the age or the timing at which we are treating these children's and aesthetics, as far as the dental stability is concerned, all come into play together. Well, when we go through the systematic reviews and the literature available, currently the extraction of premolars are opting for uh, treatments like complex orthognathic surgeries have definitely taken a back seat, and more non-extraction protocols are preferred. Well, ladies and gentlemen, my topic for today is class 2 correctors, wherein the difficult roads often lead to beautiful destination. And in the light of the current literature, when we look at the evidence-based practice, we find doing a two-phase and one-phase treatment is like two sides of the same row. Well, the Cochrane reviews and the randomized control trials, they all suggest that there is a lack of evidence to prove that two-phase treatment or doing an early treatment has any benefit over one-phase treatment that commences later. But I need to put my point forward that all studies that say that there is an absence of evidence does not mean that the treatment is not effective. It's just that the evidence to support that particular treatment is definitely lacking. As a result, when you have to treat early, well, it is definitely the choice of the clinician and the patient's decision. And I was surprised to look at this randomized retrospective study results by University of Pacific to evaluate treatment changes done during early mixed dentition treatment. They indicated that approximately 42% of the patients who received early treatment, they definitely did not require a second phase of treatment. Well, that's Darshil Safari, like, Tare Zameen Par. And then he got his treatment done. And well, when we do these early treatments, some way we are definitely, you know, creating a very positive impact on the oral hygiene related question, quality of life of these individuals. And this girl on the screen also had a similar kind of problem. Why? Because when these children are growing, they have a lot of peer pressure. So the episodes of bullying in schools and all is happening, like, So when we treat them early, we definitely get them. We get a more of a pleasant skeletal profile and more uh, balanced, pleasant-looking faces. As far as treating them early, definitely also, we reduce the problem of these incisal trauma, which happens to these proclined anteriors during the early adolescence. And the studies did not suggest that any particular appliance was better in reducing the tooth prominence. And this is exactly the same problem this child had. I mean, he also suffered a trauma, fell, broke his incisor, came, treated him with a class 2 corrector. Definitely, it would reduce the problem of incisal trauma in the future. Well, definitely, somewhere we definitely have benefits of two-phase treatment. Well, it decreases the need to extract any permanent teeth in the future, avoid or reduce need for any kind of a complex oral the maxillofacial surgeries that would be required, has a very positive impact on the psychological factors. Elimination of phase 2, we might not require any complex fixed orthodontic treatment later. Greater stability, superior facial aesthetics, and correction of any harmful habits. But then it's like two sides of the same coin. Getting into two-phase treatment definitely is a longer overall treatment time, loss of compliance, greater risk due to prolonged treatment such as root resorption, white spot lesions, and definitely somewhere it does affect the pocket of the patient too. But times have changed. Now, going down the timeline, now appliances are more comfortable. They're more. There are many non-compliant class 2 correctors that are available. Can do the treatment in a shorter time, and there is more demand for aesthetics. So with the advent of fixed functional appliance, it has made class 2 correction a lot more easier, especially for those patients who are not compliant with myofunctional appliances. So we have come a long way as far as rigid fixed functional appliances are concerned, from herbs to mandibular protraction to mandibular anterior repositioning splints down to the flexible fixed functional appliances and the current era of hybrid fixed functional appliances. Well, fatigue resistant devices which are available in different sizes, but definitely we need to have a large inventory for that. A case treated with a class 2 corrector, a typical presentation of a class 2 division 1 treated with fatigue resistant devices, I think we do justice without doing any kind of extractions of premolars. And this is what we do to their faces. A very pleasant and a good looking profile. This particular girl, again, with a typical class 2 division 1 profile, treated non-extraction with a fixed functional appliance, and we have more of balanced and good occlusion. Well, I think if we are able to change or put forward such smiles which are more vibrant, exuberant, stupendous, and sparkling, we do justice to these class 2 skeletal profiles. Other fixed functional appliances like power scopes, advancing, which is very much in nowadays. It's a customized class 2 corrector. A child treated with an advancing makes life a lot more easier. You can do a class 2 correction along with leveling and aligning both at the same time. You need not wait till you come on to a 1925 SS and then do the kind of a biomechanical preparation. And I think we do justice to these profiles. Well, most of the changes which we achieve with these class 2 correctors, definitely most of the literatures do prove that the corrections are mostly dentoalveolar in comparison to skeletal. But then the thought of the day, what determines the success of a patient? Is it a satisfied patient who walks out of your operatory, or do we look at those typical cephalometric readings? Well, I guess if the facial change is achieved or marked and above all the cephalometric values and the patient walks out with the beaming smile, we are done with our job. And something that crosses my mind, do these results stay stable over a long period of time? Well, if I look at, my own treated cases for over 2 years, post-treatment, I find, results, there is a mild bit of a relapse, but then those relapses, I guess, is more dentoalveolar rather than skeletal in correction. Have a look at these patients, all treated with fixed functional appliances in post-treatment, and the changes what we have seen during their retention phase, we too found that the post-treatment relapse was more dental in nature in comparison to soft tissue. If you look at the percentage of relapse that happens, we find the dental relapse to be almost close to 21% as far as the molar relapse, the molar relationship relapse, and the overjet relapse that has happened. Well, the overbite definitely increases during the retention phase. So definitely, wherein I said that the corrections are more dentoalveolar in nature, definitely the relapse is in direct proportion. We have more of a dentoalveolar relapse in comparison to skeletal changes. Well, I definitely am a big fan of this gentleman, Kevin O'Brien, and I read a lot of his randomized controlled trials. And he said that, rather than fixed functional appliances, whatever momentum they are gaining, but class 2 elastics were definitely there in with the orthodontist, and they have always been a better modality of correction. Uh, have a look at this child treated with class 2 intermaxillary elastics. I think it's justified that he did not have to go with any something extraordinary class 2 corrector like a forces and an advancing. Well, when I look at a randomized control trial between any fixed functional appliance like forces and intermaxillary elastics, we find that the treatment time is the only thing that gets affected with a fixed functional appliance in comparison to intermaxillary elastics. As far as the biomechanical preparation is concerned, an intermaxillary elastic has more of a traction or a pull force, wherein there is a significant palatal tipping, extrusion of maxillary incisors, and clockwise rotation of the occlusal plane, along with the extrusion of mandibular incisors and extrusion of the mandibular buccal segment. While as in fixed function appliances, you have more of a push force because of which there is a palatal tipping and extrusion of maxillary incisors along with clockwise rotation of occlusal plane, intrusion of mandibular incisors with a significant change in jet and bite, and midline deviations and molar corrections are more significant. But then the biomechanical preparation definitely lies in the hands of an orthodontist. So an orthodontic treatment mechanic wherein the final result is definitely achieved by series of well-planned biomechanical intervention to create balanced, pleasing soft tissue profiles and to achieve a functionally normal, stable occlusion which definitely lasts for long. Well, an orthodontist should be very well versed with the biomechanical preparation, the appliance selection, achieving an overcorrected occlusion, and stick to the strict retention regimen. Well, a successful treatment is based on a sound knowledge of craniofacial biology, good clinical acumen for diagnosis and treatment planning, a proper execution of the treatment, in addition, that we should modify our treatment planning according to the needs of the individual. So our motto is the right appliance for the patient at the right time. The right time, right place, right person is the right combination for success. And this is the change as per the timeline. I have grown in all three dimensions of space past for over a decade. And these are my three lifelines on the screen. That is how Marvin's to millennials happened for me. So thank you. And I come from this city of Lucknow. And I give an official invitation to each one of you for the 26th IUSPG convention that is going to be organized by my institute, Sardar Patel Dental College, next year from 16 to 19 February, 2023. Thank you so much, everyone. Thank you.
Yeah, Dr. Jitendra, it was a wonderful presentation.
Thank you so much, sir.
Yeah. Any questions or doubts from the audience?
Thank you so
Yeah,
much.
thank
Thank you
you.
for a patient hearing.
Thank you so much, Dr. Jitain, for such a lucid presentation. I would now request the chairpersons, Dr. Amit, I think Dr. Suryakant has also come to kindly join him and felicitate the speaker with a certificate and a plaque. So welcome, Dr. Suryakant Pawar. The next speaker for the session is Dr. Purnima Jnaneshwar. She is a professor at SRM Dental College, Ramapuram, Chennai. Dr. Purnima Jnaneshwar, please.
Good morning, all. Good morning. Thank you, 56 IOC, for this wonderful opportunity. And thanks for everyone for making it today. Whoever has made it. Okay. I'm Dr. Purnima. I'm a professor in Department of Orthodontics, SRM Dental College, Ramapuram, Chennai. The topic for today's presentation would be mandibular changes with functional jaw orthopedics in class 2 malocclusion, with particular emphasis to Herbst and twin block, the two most commonly used appliances. Before we go into the diagnosis, treatment planning, and clinical intricacies of how to manage these appliances, let's see what succeeds in functional therapy. There are patient-related factors, and there are factors related to the appliance per se. Patient-related factors can be associated with the morphology of mandible. A small mandible, both in corpus and ramal length, seems to fare better with functional therapy. Patients with shorter lower anterior facial heights seem to fare better, and mandibles with acute gonial angle are associated with better stability of results, as are patients with large pre-treatment molar overbite. So with the small introduction, let's see what are the clinical steps. I've listed all the clinical steps, but in my opinion, there are only 3 steps that are very critical to any functional appliance therapy. The first is during the construction bite phase, we establish a sensory engram. The next critical step is we elicit as a clinician whether pterygoid response is achieved before we erupt the occlusion. The peripheral occlusion or establishment of the peripheral comparator is the third critical step. All these 3 clinical steps have to be followed diligently to make the functional raw orthopedic treatment a success. We all know the clinical and cephalometric indications for a functional case. Let me skip all the common indications. Let's focus on functional retrusion. It's not just a class 2 mandible or a retrognathic mandible, but a functionally retruded mandible is also a good indicator for functional appliance therapy. The patient needs to have an overjet of at least 6 millimeter for you to advance the mandible sagittally, and the patient should have a good horizontally growing or average growing tendency, not the other way around. Now, this patient had such similar clinical and cephalometric indications. She had a class 2 buccal occlusion with a convex profile and a good positive clinical VTO, and her overjet was 12 mm. Skeletally, she was a class 2-2. She had an A&B of 6 with a retruded mandible at 74 of SNB. Her Schwartz showed that her corpus length was much lesser than the anterior cranial base length. Now, in the growth status, we saw that she was in the CES3 stage, which is a transition stage. So she had 65% of growth left. Her ulnar sesamoid had not ossified, so she had a fair amount of growth left. Now, we know all the appliances, regardless of what the array of appliances we have, we use twin block because it's a clinically and patient comfort appliance. So, what are the indications? Twin block is indicated in early permanent dentition. If you have a functional intrusion, you can use a bionator. If you need to have an arch, you need to have developed arches, development of arches and expansion of arches, we resort to Frankel. And if there is a mild prognathic maxilla, we resort to activator. So regardless of all this, we use twin block because of patient compliance and clinicians' comfort. There has been a lot of debate on early and late treatment, but I found this paper really interesting. Franke et al., they studied bionator and activator in 2 age ranges, 2 treatment timings. First was the pubertal and the pubertal group. The second group was early treatment group. This early treatment group and pubertal group were compared with untreated controls. And what did they find? They found that there was a considerable increase in the length of the mandible and the ramal height and advancement of chin in the late treatment group when compared to the controls. When they compared late and early treatment groups, they found that there was increase in maxillomandibular differential in the late treatment group. So we now know that late treatment group is the ideal treatment timing of choice. But when is an early treatment indicated? It is indicated in patients who require a reduction of overjet to avoid trauma. or patient who require a reduction in the severity of malocclusion to avoid trauma. Now, bite registration is this critical step. We all know that there are two components. One is the sagittal advancement, the next is the vertical opening. So what we do is, regardless of what Clark says that till 10 mm of overjet, you can advance the mandible to a single step. But we follow the Roccabado's rule, that is 70% of the most protrusive part. This is the sagittal limit for the muscle's comfort zone. So as a clinician, we would have decided how much of mandibular advancement that needs to be given, and the vertical opening. Vertical opening for twin block is fixed, 2 mm of interincisal clearance, and the premolar and the molar opening of 4 mm and 2 mm respectively. So with this thought in mind, we have to train the patient. This forms the essence of functional appliance therapy, construction bite registration. Just establish a sensory engram. We inform the patient in the front of a mirror, ask the patient to bring the mandible forward to an extent that we have decided, and practice this umpteen number of times till such time that he is comfortable to do it without the help of a mirror. So sensory engram is a muscle memory. We create a muscle memory in such a way that patient becomes comfortable and confident to reproduce this without the help of the clinician, without any direction from the clinician. This is the most important step in functional bite registration. We'll see why in the next slide. And the third is sticks to the dimensions of the wax. Let's not go into that. We all know how about construction bite wax should be. Okay, what is the clinical significance of sensory engram? First is it's a muscle memory. It is a reproducible position. It is a repeatable position. Patient becomes confident after so many attempts. The second is we know the comfort zone of the patient, comfort zone of the muscle of the patient. We might have decided an 8 mm of advancement, but during the process of registering his sensory engram, patient comes to know that he is not comfortable with this 8 mm. We can always reduce it to 2 mm and find out what is his comfortable position and fix it there. And probably if the 6 mm advancement is done, if we require more, we can always do a stepwise advancement. The third is after establishing the comfort zone, patient becomes better confident, and establishing the sensory engram elicits better compliance from the patient. So after delivering the appliance, we all know we get a pterygoid response. If we have to elicit the pterygoid response as a clinician, if we don't elicit it, and if we start erupting the molars to establish the peripheral comparator, what happens is the patient develops a dual bite. So identifying the pterygoid response is very important. What happens to the muscles? Agarwal et al., they did a study very long time back. They studied EMG activity of muscle groups in various functional appliance therapy. They found out that twin block, a full-time wear appliance, elicits continuous contraction of pterygoid muscle. That is, contractility of pterygoid muscle was continuous with twin block when compared to activated bionitron and other appliances. So this is an advantage to twin block to achieve rapid correction of class 2 malocclusion. Now, what happens when you insert an appliance into the patient's mouth? We elicit a mechanical strain. How is it strain converted to a condylar growth? That creates a mechanical strain, which is mediated by a group of signaling pathways called Indian hedgehog. All this details I got from this wonderful set of articles by Rabi et al. They did a series of studies on rats in the year 2003, 4, and 5. So this Indian hedgehog signaling pathway, it increases the multiplication of mesenchymal cells and expression of SOX9 genes. We know these genes are related to chondrocyte differentiation and type 2 collagen formation, which ultimately increases the condylar growth. Now we know when we put a patient, an appliance into the mouth, we now know how a mechanical strain is converted to increase in the condylar growth. Excuse me. Now, what are the mandibular changes we saw? We saw an increase in the reduction in A and B angle, an increase in corpus and ramal length, as we expected. There was a mild amount of incisor proclination, a lower incisor proclination, which is expected with twin block and other appliances. Whether to do incisal capping or not should be decided by the clinician. Now, this study, the recent study states that there is no significant inhibitory effect of lower incisor proclination by incisal capping, but whether to do incisal capping or not is decided by the pre-treatment incisor inclination, lower incisor inclination that we have. It differs from patient to patient, and we can take a call when, as and when it is required. Uh, uh, at this stage, when the mandible is moved forward, we elicit a pterygoid response and start erupting the molars. This occlusion, peripheral occlusion, is called peripheral comparator. This peripheral comparator needs to be established before we go on to the next phase. Establishment of peripheral comparator, that is ideal cusp-fossa relationship. It's called an attractor mode. We all know that. This attractor mode is very important for the maintenance of the stability of correction. What are the changes we saw and we noticed in mandibular dimension? There is an increase in the corpus line and subsequent increase in the ramal line. Koza et al. Did a systematic review. They studied the efficacy of herbs, twin block, and an array of appliances. They introduced a parameter called coefficient of efficiency of functional appliance. What did they do? They divided the supplementary elongation of the mandible, actual supplementary elongation, by the number of months of active wear of the appliance. They found that herbs fared better. But I refute because we all know that herbs, the treatment time actually for herbs is less, right? It's a fixed functional device when compared to twin block. So number of months of active wear, but twin block is a close behind. I'm sure twin block has, in my opinion, twin block has more skeletal correction than fixed functional devices like herbs. These are the dental correction. We see that the, overjet correction, there is 27% of skeletal contribution. The same is for molar correction, but skeletal contribution to molar correction was more, according to this article by Kevin O'Brien. It was 41%. There is some amount of element of mandibular incisor proclination with all the appliances. It was the same with in this study also. Clark himself states that about 6 degrees of incisor inclination, increase in incisor inclination is allowable with twin block. Okay, TMJ changes, we all know that TMJ remodels, condyle fossa relationship relocates anteriorly. A recent study states that the condyle also increases in all its dimensions along with the anterior remodeling. These are the changes with twin block. Now, don't debond before you establish your peripheral comparator and settle your occlusion for better stability of results. Now, this case had a similar picture with respect to the, when you compare the previous case, that is, she also had an increased overjet, but her growth status was very different. She was in the deceleration stage. She was in CS4, her ulnar sesamoid had ossified, and at the MP3 stage, she was, her epiphysis had started to fuse with diaphysis. So she has only 25% of growth left, and we have to make use of whatever growth was left in her. So how do we decide? We've already discussed this. Twin block in the ascending growth, ascending phase of the pubertal spurt. If we catch a patient in the ascending phase, that is before CS3, we can give a removable functional device so that we rely on the patient's compliance to wear this device. To make use of the encompass the pubertal peak along with the treatment. Now, if the patient has reached the pubertal peak, if we see that the PHV is already attained, what we do is we give herbs to make use of the residual growth, whatever residual growth is left in the patient. In our department, we use banded herbs. The herbs is a first intermaxillary non-compliance appliance, and it is still successful. So, the bite registration for herbs is slightly different from, or any functional devices that makes use of a lab procedure is slightly different from removable device in that we have only a component of sagittal advancement that we decide. Again, we decide the sagittal advancement, and vertical opening is minimum or whatever is achieved by the sagittal advancement. We saw some skeletal changes with this patient too. There was an amount of corpus and mandibular ramal lengthening, and contrast to what the literature says, there was no increase in lower incisor inclination, no increase or lower incisors did not procline with herbs therapy. Herbs was studied with untreated control. With untreated control, herbs fared better, obviously, with greater posterior and superior repositioning and growth of the condyle. Now, this is the treatment progress. What do we see? Herbs and twin block. Though what the recent systematic review says, all through the literature, herbs has been found to have more dental and less skeletal correction. We all know that. Twin block has more skeletal correction than with any fixed functional device. So, if we have a patient in the ascending curve of the pubertal spurt, it is better to use a removable functional device like twin block to make use of the uh, pubertal peak. We have to wait for the pubertal peak before we, proceed with the functional phase. We can use the pubertal peak with the twin block treatment. There are two pertinent points with herbs that was noted. There was an upper element of upper arch distalization, and there was an increase in lower incisor inclination. We did not see in our case. Of course, twin block, as Kevin O'Brien states, twin block is less expensive, twin block is less prone to breakage than herbs, less chair side repair, and the transition from twin block to fixed appliances is smooth. These are the advantages of twin block. Some pertinent observations are, yes, as we already studied, as we already discussed, CS3, if it is CS3, then please give a twin block. Please remember these three mottos. We establish the sensory engram first, and we see when the pterygoid response is achieved. We elicit a pterygoid response as a clinician, and third, we establish a peripheral comparator. At least, when we erupt the molars, it need not be in good cusp-fossa interdigitation. In all the cases, we don't see a cusp-fossa relationship, perfect cusp-fossa relationship after the twin block phase. At least achieve that in the fixed appliance therapy to maintain the corrections achieved. These are my references. I thank my department, my HOD and D, Dr. Ravi, and all my senior and junior colleagues for having been a source of support for me. Thank you. I thank the chairpersons and the audience for patient listening. Thank you all.
Thank you for the wonderful presentation, Purnima madam. The presentation consisted of beautiful combination of basics of functional appliances, well-treated cases, and supported by evidence. So it was a wonderful treat in the morning to see this presentation. Thank you for the wonderful presentation. Any question from the audience?
Thank you so much, Dr. Purnima. And now request the chairpersons to kindly present a certificate of appreciation and plaque to our esteemed speaker. Thank you so much, Dr. Amit and Dr. Suryakant Pawar for chairing this session. May I now request Dr. Dilip Patel, sir, to kindly felicitate the chairpersons for this session. Thank you so much, sir. Thank you. Thank you.
Good morning, everyone. We are starting with our second session for today. We are right on time. And the chairperson for the second session is Dr. Mona Prabhakar. Ma'am, I will invite Dr. Mona Prabhakar, ma'am, to take a dais. The second chairperson is Dr. S. Dattana, who will be joining us soon. Dr. Mona Prabhakar ma'am, she's a professor, Department of Orthodontics, Faculty of Dental Science, SGT University, Gurgaon. We'll ask ma'am to take over.
Good morning, everyone. Thank you for this opportunity for chairing a session. I will like to introduce Dr. Ashwin Matthew George. He completed his MDS from Government Dental College, Chennai in 1996. He is currently a professor at Savita Dental College and also the chairman of IBO, Indian Board of Orthodontics. Dr. Ashwin.
Good morning, everyone. Respected chairperson, and Pune has been a place that makes good orthodontist. It's I don't know the genetic part of this place, and I see a lot of orthodontists in this place, which have really impressed me. But if I have to mention one person, who has really touched the entire Indian orthodontic fraternity, is the late Dr. Sable sir. His attitude towards life has touched me to a great extent, and I still remember when he came down to Chennai and I was just about finishing my post-graduation and entering clinics. Very basic facts in finishing and detailing. He said, the first thing you do is to keep your bonding cases in the morning session. I thought, what is this so important in a PG convention to lecture? But it made a lot of sense. He said the first thing in orthodontic finishing and detailing is bonding. And ladies and gentlemen, I still try and do that. Having said that, I'm now going into my presentation, and that's about facial asymmetry. The point about, or the difficulty about facial asymmetry is it's based on patient's perception. I've seen a lot of patients with a lot of asymmetry going on the roads, but they're really not bothered about treatment. But there are cases with so much of a subtle, small differences, and they are got so much of functional needs that more than the aesthetics, we have to look into function. Of course, aesthetic also plays a part, but their functional needs, from basic difficulty in chewing to how they smile. Okay, so this is a quote by none other than the editor of the JCO, who says that although any malocclusion is undoubtedly an aberration from normal development in all the three planes of space, that's sagittal, vertical, and transverse, none present so dramatic a problems as asymmetry does. So that's the complexity of treatment of asymmetry, because we really don't know where the problem exists. It's a balance between two sides. So are we going to treat the right side? Are we going to treat the left side? And that's why diagnosis for asymmetry is of prime importance. Now, this is what I was saying. The cause of this pointer doesn't work. Okay. I got to use this. Okay. This is what I was saying. There is in the development, there is an unknown cause which causes facial asymmetry. And that's where all the problem lies. We know all these factors: TMJ ankylosis, facial trauma, radiotherapy, dysplasia, tumors, and this is also another important commonly seen factor: unilateral condylar dysplasia. Okay? So now come into the diagnosis. Of course, basics, this is what I also consider very important: unrealistic expectations. Okay? Then there is a motivation factor. I told you, there's peer pressure, there's an internal motivation factor. Aesthetic facial evaluation is important, cephalometric evaluation. You have the panoramic evaluation with the sinus and the TMJ, occlusal evaluation, functional or static, which causes the asymmetry. Probably that is the most important diagnostic factor. whether it's a static problem or a functional problem. A functional problem is easier to treat orthodontically. A static problem is more difficult. You need to do combined surgery and orthodontics. And then, of course, muscular problem. I will show you a case where it was just a muscle, a dynamic change in the muscle tonicity that caused about such a great asymmetry, and a simple differential bonding corrected that asymmetry. So these are all the etiological factors which all of us have to pay a lot of attention before we come to a diagnosis and a treatment methodology. So I'm going to just run through the facial analysis we do. Before that, the cornerstones of any treatment is based on symmetry, morphology, and balance. And all these three are interconnected to get a normal facial balance. Okay, so the balance, all of us know we're supposed to get the normal ratios as far as the symmetry is concerned. The morphology, the bizygomatic widths is all, we have values for that, and how we try to analyze where the problem is based on symmetry, balance, and how do we check the asymmetry. Clinically is probably the best method to diagnose an asymmetry. Before you go into any radiographs, CBCT, look at the patient from different angles. Okay? You have a supracranial view, you have a Kant evaluation ice cream stick, and you have a submental view. Let me tell you, half of your diagnosis can be predicted correctly if you do these three views. Okay? And once you get a basic idea about the problem, you go into your radiographic analysis. You go into radiographic analysis with asymmetry, you really don't know where the problem is. You're going to get confused. Okay? So once you do that, you go into your radiographic analysis. We all know the standard analysis which we take is the Grumman's analysis. We have the mid-sagittal plane. And one thing which I've realized, if usually these planes are beyond our control, okay? It needs craniofacial assistance. But once the problem starts in this plane, automatically all the other planes change. Okay? So if you don't have a problem here, you might have a problem here. Okay, but if this plane changes, then everything changes. So that's one way of diagnosing where you're going to start your treatment. Okay? So again, nasal width. We have now methods to correct this without surgery with our Marpe and all that skeletal expansion. Now, maxillary width asymmetry is easier to correct. I told you we have expansion devices now up to the age of 25, 28. Studies say you can do about maxillary expansion to bring about some asymmetric correction. But the problem is here. With the mandibular width causing the asymmetry is the cause, I think it's a very difficult proposition to correct because it invariably needs a surgical intervention. Of course, when all these things change, your intermolar and your intercuspid relationship change. Okay, so these are all the analysis which we normally do, but nowadays with all the 3D CBCTs and 3D imaging, life becomes much simpler. You know, these are the days when back in the 1996, 2000, we didn't have CBCT. And let me tell you, it takes a little bit of effort to get your diagnosis right doing these analysis because there's a lot of superimposition on the PSF, and unless you get a good X-ray, you're really going to not figure out where your asymmetry is. Okay, so now two-dimensional, it's got its own problems, but always my system of work is before I look into a CBCT, I look at the pano. I make my probably 60 to 70% of my decision based on 2D radiographs. Let me tell you, it makes a lot of practical sense. Once I get a picture of the 2D radiograph, then I zoom in into the 3D with that idea of my 2D. You straight away go into your 3D imaging, you're sort of confused. So look into the 2D nicely, the old system. Once you get a basic picture of the 2D, then go into your 3D. It makes you don't go back reverse, okay? So, of course, these are the advantages and disadvantages of the 2D diagnostic methods. If you're looking at radiation and all that, 2D is better, but always, with today's technology, always facial asymmetry, especially skeletal, please take a CBCT. You're really not going to get anywhere close to a perfect diagnosis without a CBCT. And now, with all the surgical splints and your stereolithography of superimposing soft tissue over hard tissue, it is not the right method of going without a CBCT or a 3D way of analysis. So, what are the disadvantages? All of you now, we have gotten to a stage where most of us know how to read a CBCT. So, the small initial training is needed for those who really not learned how to read a CBCT, but it's a very simple procedure. 2 or 3 CBCTs you see down the line, you probably mastered the technique of how to read a CBCT. Okay, so with this basic knowledge, I'm going to go ahead with my case presentations. So my topic is termed facial asymmetry complexity simplified. I'm a simple person. I like to simplify my life. I like to simplify my treatment. I like to give my patients the easiest solution to go about with whatever problem they have. Okay, so I've divided it into dental asymmetry management and skeletal asymmetry management. When I say dental asymmetry, simple stuff, mini implants all of us use these days, arch wire expansion. When I say arch wire expansion, it can significantly correct an asymmetry. I'm showing you a case. Differential bonding is when you have muscular problems and we have a cant of the occlusal plane caused by soft tissue factors. And then, I suppose, as far as maxilla is concerned, you have the Marpe appliance. This is a more complex way of treatment. I'm showing you one case which we did without any 3D software or CBCT, and this case we did with a 3D imaging. So I'm going to run through this case. Now, the chief complaint of this patient was not aesthetics, it was not protrusion. I'm honest with it. Patient came, I'm not able to chew properly. Okay? And the cause of that was this crossbite. Okay? Total buccal crossbite. And how do you know which arch to treat? And the simplest way of diagnosing is just check the marginal discrepancy. So I've realized in this arch, it's better to bring about buccal the lower posteriors, because except for this one premolar which is blocked out, there's not much of a marginal discrepancy in the upper arch. But whenever you're treating such crossbites, try and pay attention that you put your mechanics in both the upper and the lower arches. Okay? So this is the facial. You see the chin deviating? That's the asymmetry. Patient was really not concerned about this. Let me tell you, perception. Only problem was unable to chew. But for an orthodontist, this is important. Okay, but I told you it varies from patient to patient. This patient was not bothered about all this. So, skeletal class 2, upper and lower anterior proclination, convex profile, and the problem was here. Okay, so that caused the deviation. And this is something which we really cannot treat. Okay, so don't be bothered about this. As long as we get good intercuspation, it's going to, sort of remodel or whatever, adapt itself. Now, timing for correction of any malocclusion. First is transverse. Second is vertical. Third is anterior posterior. Now, I always like to correct transverse asymmetry. Even if, what I'm trying to say is, even if I have to do an extraction to correct the proclination, I will first correct the transverse, and then I will do my extractions. Because the very fact that you have to know how the asymmetry is corrected is better without your extraction protocol. Okay? So we went and put mini implants and always section the wire whenever you're doing asymmetrical corrections dentally, okay? And don't fill the slot, okay? I usually put an undersized rectangular wire and do whatever mechanics I want to bring about the correction of the crossbite. In this case, it was simple implants. I did both in the upper and lower arches. Most important thing is to relieve your bite. So, sometimes we have to, band these canines to solder our nans with a bite plane. All these things involves a little work. Section the arch wire here, undersize the wire here so that you have free tipping. If you put a 1925 and you want to correct a crossbite like this, it's very difficult to have free movement. So, don't put a round wire here. If you're using a 22 slot, put a 1622 or a 1725 sectional arch wire. So this is how we corrected the crossbite. Take all your precautions as far as, excess tipping is concerned. Nans and lingual arch. After that, I started the retraction. In this case, we didn't need extraction because we were already having spacing. So don't combine transverse expansion symmetry with another movement. Finish the transverse and then get back into your other corrections. Blue bites are always available to maintain the correction as far as relieving the bite, and this is what happened. We corrected the facial asymmetry and we sort of finished the case. Post-treatment, see the proclination corrected, and this is how we finished. Asymmetry corrected. Okay, this is the same mechanics. Patient inability to chew was advised surgical correction. But when we did the diagnosis, we realized it was only a dental problem. But what that dental problem actually caused was a severe deficiency of the mandibular width over here, a skeletal problem. And so that is why most of the oral surgeons said that they will do a segmental osteotomy here and bring this whole segment outside. Complex surgical procedure, a dental surgeon removed the lower sevens in this case because the patient was just not able to eat. But I tried. I said, okay, let's put mini implants and see whether this thing can be corrected and what happens to the bone over here. You see the dip in the bone here? And so we went with implants and just see the correction here. Slow mechanics. Another important point, if you want to grow bone, you need to do very slow, very light forces, same implant mechanics. And who said bone, this patient is 21 when I treated, who says bone does not grow with orthodontic treatment when you follow the principle of the slow physiological bone deposition? And you see the difference? This is the patient. And he's a happy patient. Okay, so now coming to arch wire expansion. Simple mechanics. These are all this dental treatment. Again, a crossbite. And you see the extent of the crossbite, the asymmetry in the arch. So whenever you're doing a dental expansion to correct an asymmetry, with arch wire expansion, the tip is, if the problem is in the lower arch, start the lower arch first. Because you need to know how much of expansion. You start expanding or aligning in both upper and lower arches, you're nowhere in between. Okay? So start with where the arch needs expansion. So I started with the lower arch. Okay? Of course, you have your, after you start getting the teeth out, corrected, then you have a reference point to how much your maxilla has to go. So then after that, we started, and this is how we corrected it. See the changes. Non-extraction protocol, just with archwire expansion, not even Damon. Okay, slow movements. Use the upper archwire on the lower archwire on the upper. Now, concept of differential bonding. Photo, okay, when without smile, but see, when she smiles, what happens? So we did all her diagnosis. This patient actually didn't know the problem she had, okay? But once we told her, oh my, she became very, very conscious about the smile, okay? So when we did all our analysis, we realized the problem was just a muscular imbalance, okay? But just see the asymmetry here. If you look at the gingival zenith, it's really going down here. Dental problem, I told you, this is a dental. You can make out with your gingival zenith if you want to make out simply whether it's a skeletal problem or a dental problem. Just look at the gingival zenith. If one side is high, one side is low, then it's a dental problem for sure. No problems with the condyles, so it's a dental problem. Mild cant, I would say a very mild cant, probably because of the occlusal mismanagement or the occlusal differential between the right side and the left side. We went about with differential bonding, see how lower or incisal are these brackets compared to the other side. And just see the change it has, the function of the muscle adaptation getting better. I told you, I corrected the asymmetry. Then I extracted. Only after I corrected the asymmetry, I extracted. Okay, and then I corrected the proclination. Don't mix extraction before correcting the transverse. So you see the gingival zeniths matching up here compared to the here. And see her smile. Just differential bonding, nothing else. Quite a severe case. Diagnosis. Okay? Now, of course, we have artificial methods. I am not a very big fan of that. Basically, it's facial paralysis, which we get with Botox. I don't know how long it lasts, but just for your information, patients also get treated with for asymmetry with all these newer methods, which I really don't want to mention. Okay. Transverse correction with in the maxilla, possible these days with our Marpe. Okay. All these cases would have been a surgical. If you take your Walla Ridge measurements, all skeletal, but not very severe. Okay. So we have Marpe these days. If you have a stent, you know precisely where to put your screws. And just see the expansion we got, non-extraction. You take your CBCTs to see what the split is. I'm just running through all this, and this is how we finished. Profile is straightened, patient is happy. So that was so far as dental problems were concerned. If you go recap, it was using implants, using expansion, using differential bonding, and now we get into the more complex system of how you manage true skeletal asymmetry. And again, that comes under severe scrutiny of your diagnosis. So this was a case, patient came to me saying his chief complaint was whenever he smiles, one side of the lip is higher than the other side. Nothing else, okay? He looks into the mirror, this is what he sees. Very subtle. You look at him, you won't notice it. But for the patient, that was his major concern. So when we look into the panel, this was a stage where we didn't have CBCT, so I had to do the regular OPGs. And then when I looked into the OPG, what I found was the difference in the ramal length. Hardly 4 millimeters. But that caused a significant changes in this profile. So again, we did the PSF 75 millimeters, 72 millimeters. I'm going to run through retrognathic mandible, A and B of 8 degrees. Now, the concept of doing sagittal and transverse before sagittal need not be applied in surgical cases because anyway you need to decompensate. You understood? So I extracted because my main transverse correction was surgical. So I started with the decompensation first. So that's the crossbite. And we had a different treatment plan altogether. So how we corrected the facial asymmetry is what was interesting in this case. Skeletal class 2 was corrected with a bilateral sagittal split osteotomy. And I'm going to run through this. I'm running out of time. CRCO discrepancy has to be always analyzed before we do a surgical procedure whenever there is an asymmetry. So we did that. He was on a deprogramming splint. We went about extractions, all four to decompensate. We got an overjet to bring the mandible forward. And how did we do this? So we found out that one side of the ramus was shorter than the other side. So we decided to take a piece of bone from the iliac crest of around about 3 millimeters to 4 millimeters in width or height, and we sort of augmented and pushed it inside the body of the mandible. We did this because we had to anyway create a split over here for the sagittal split osteotomy, and in this way, we increased the height or the deficient height of the mandible on one side. See this? We interposed a bone here to correct the asymmetry. Now, I could have done another method. I could have shaved the lower border of the other side. But I didn't do it because already the facial height was less. So that's the decision you have to take. Okay? You have problems on both the sides. And which side to treat is our decision. That's where the key is. See the cant correction. Mandibular, I told you, we have no way of expanding the mandible. Surgical. Splint. See the cant. 5 years post retention. He's totally changed. He was psychologically very down when he first started. Today, he's a happy man. You see the bone is all settled down here. This is actually the graft area. And he's happy. I have another 2 minutes. He's so doing well. He works with AirAsia, and whenever I fly AirAsia, he upgrades me to the business class. I recently went abroad to Israel and Egypt and this thing. The best feeling is when you have your wife around and somebody calls your name and says, you're upgraded. The pride is with your wife more than with the patient. No, but he's a happy patient. That's my wife. And so this is my last case. I'm going to run through. I'm running short of time. These organizers are very strict in time. I would like to respect their work. So this is computerized. Mandibular shift, mandibular asymmetry. And that's the asymmetry. Again, we did all these. First look into facial profile, then look into 2D, then look into 3D radiographs. We did all this, and then we did this. Digital models, because of superimposing facial photographs, stereo lithography files, superimposition of the facial photographs onto the skeletal structures, makes life so simple, especially when you have a mandibular asymmetry correction. It's very difficult to make a splint without a 3D generated model when you're correcting asymmetry. Very, very difficult. You know, it's next to impossible. So we went about with that. So we decided on a bilateral split osteotomy, and whenever we do surgery for very maximum this thing, I always like to split maxilla and mandible. I don't generally like to, do one arch fully. I get a better occlusion, I get more stability. So I did a little bit of maxillary advancement also. We did the 3D splints. And whenever you're doing these 3D splints, you really don't need an intermediate splint. We did an intermediate splint, but we really don't need, even though I did both the jaws. So we had a setback of 5 millimeters, asymmetry setback 5 millimeters on the right side, setback of 3 millimeters on the left side. And this is how we supposed to. Asymmetry corrected. We're doing the final finishing now. Yeah, I'm done, I'm done, I'm done. We did digital smile analysis. These are all the softwares available these days. Make use of them if you have an opportunity. So, complexity of management, asymmetry, diagnosis. Patient's perception. That's probably the most important thing. I told you, there were some patients who were really not bothered about their asymmetry, but they were somebody. I don't know what you're going to make out, but the next statement will tell you what it really means. Beauty is rather a light that plays over the symmetry of things than the symmetry itself. Ponder about this statement. I have no time to explain that. This is our team at Savita, where I work. And thank you very much.
Thank you, Dr. Ashwin, for the insightful presentation and the simple clinical tips, diagnostic tips that you gave for otherwise baffling problem in orthodontics.
I request, we have been joined by Colonel Dr. Dattana. Thank you, sir. I request Colonel Dattana and Ma'am, Mona Ma'am, to felicitate Dr. Ashwin Josh. Yeah, Dr. Colonel Dattana is currently heading the professor and heading the division at AFMC Pune. I request Colonel Dattana to introduce our next speaker.
Good morning, everyone. It's my proud privilege to introduce my own teacher from BDS days, Dr. Ritu Dugul. I'm sure she doesn't require any introduction, but to fulfill the formalities, I will read few lines for her. Dr. Ritu Dugul is the chief of the Center of Dental Education and Research and professor and head Division of Orthodontics and Dentofacial Deformities at the prestigious All India Institute of Dental Science at New Delhi. She has been a guide and mentor to many postgrad research and PhD postdoctorate students. Her acumen in research and communication skill is par excellence. I'll just cut short without getting in between the audience and the ma'am. May I request ma'am to please. Thank you, ma'am.
Thank you very much for such a lovely introduction. A very warm welcome to all of you in a beautiful city of Pune with lovely weather around. Of course, it was raining very heavily. Am I audible? Do I need to take another mic or is it okay? At the onset, I would like to thank the organizing team, the scientific team. I can see only Dr. Gauri here, and I'm sorry, I do not know the names for most of them. Yeah, so no, but the organizing chairperson. No, the names are endless. So at the onset, I would like to thank everybody who has invited me to be part of this. Now, today I'm going to talk about the functional appliance. Functional appliance is very close to my heart Everybody knows that in my introduction also, everybody says that she has great affinity, or I would say my choice is for non-extraction treatment plan. Yes, functional appliance, it is not only me, I think everybody's choice. The students also look forward to do cases with functional appliance. It is the best appliance, or it is the choice appliance which every examiner likes to give and likes to examine the postgraduate during exam, the 2 days exam program. Even in our syllabus, we are taught so much about functional appliance. And it really gives good results if handled properly. Even children, once they see the results with the functional appliance, they are excited. So it is the everybody's choice, I would say. But unfortunately, we all are giving these appliances and are treating our patients with few myths we have in our mind and the literature which we searched a long back. And if you go back to the old literature and if you come to the evidence-based literature now, there is a lot of myths which are converting into facts. So when I thought, what should I present here? I looked for some literature. I thought this is the best thing. You will not find any pictures, any cases, pre and post cases in my presentation today, except that I will be updating, or I will be talking about the areas which we need to take care and how the evidence-based orthodontics has brought change in the functional appliance therapy. So bear with me, it is all like a review. When you write a thesis, we know that we skip the pages of the review. Any examiner who is evaluating a thesis would also not like to read the review. But ladies and gentlemen, my dear students, my colleagues, the discussion part is always written with the reference of the review, what we gather. So this is what I know. It is going to be a little boring for most of you, but that's the fact. We cannot ignore these facts. So my half an hour journey would be only literature, and maybe when we go back from here, we have few facts in our mind. So please bear with me. Thank you so much. So this is the place where I come from, All India Institute of Medical Sciences. That's the uh, building of AIMS, Delhi, and this is the center where I work. I see a lot of Emsonians here, my old colleagues, students, and the current postgraduates also. So I am proud that, and I'm thankful that you came here, although you must have heard functional appliances so many times, but this will be a little different. So thank you for being here. So before we start with this, I would say that we would like to know very briefly what functional appliances are. Don't think that this is an undergraduate class, but yes, just 2-3 slides which will tell us that what functional appliance is. And this is the definition which everybody has remembered so far. It says that the variety of appliances which are designed to alter the arrangements of various muscle groups that influences the function and the position of the mandible in order to transmit forces to dentition and the basal bone by altering the mandibular position sagittally and vertically, resulting in an orthodontic and orthopedic changes. So this is a very, even in undergraduate books, and all PGs know about this, that what functional appliances bring about. So this is the old definition as given by Bishara. But now we know that there is a variety of appliances also available, and the choice is vast for us depending on the correction what we desire and the correct diagnosis what we make for the case which we select to be treated. So using particular appliances and it involves the various correct diagnosis based on the case selection, the practical steps, the various clinical steps which we all follow. So this depends on the operator and the institutional choice. Like most of the institutions are following twin block. Many of the down in south, they follow fixed functional appliances. So it depends on the operator's choice and the institutional training as well. So since the longest time, these appliances have been in use, and to achieve good modifications, growth modifications, class 2 corrections in relation to overjet reduction, and to bring about the harmonious balance soft tissue changes. The crucial lesson that we have learned so far when we were doing our post-graduation, that going through the scientific knowledge and honing through the practical experience, we were only learning about the functional examinations, how to register a bite, how to fabricate an appliance, and the appliance delivery and what to follow up after the appliance. So this is all we were trained about, and we were only looking at the literature which were giving us knowledge on these 4 parameters. But friends, we know that this information, what we gathered, have been advocated to have the following positive outcomes. That is, it gives a positive psycho-social impact. That is, the self-esteem of the patient is improved. There is a reduction in the trauma to the procline incisors, which we say if we start early, there are chances that the trauma would be less on the front teeth. And of course, by doing a phase 2 therapy, the cost effectiveness is also is there, because it reduces the burden for both the orthodontist and for the patient to go for the fixed biomechanics. But as I said earlier, now with the, however, in the modern era of modern orthodontics, there is a paradigm shift, and all the treatment plans are based on evidence-based orthodontics. Among these are individual perception, clinical competencies. If you want, I can take a color mic. Class 2 correction continues to grow with technical advances. There are many more newer advancements in the term of appliances. We only knew about activator, bionator, Frankel. When I post-graduated, these were the only appliances available, and we could search literature for them. Now, as the literature, if you review the literature, there is more number of appliances which are in I would say the research area, which have been there have been RCTs going on, and that leads to more of evidence-based orthodontics now. Among the scientific publication, this approach us to give a better available information, and based on the individual clinical competency, as I said, and the need of the patient, we are now finding out solutions for which kind of appliance to be given. So now let us begin our journey to unravel the persistent myths which we have versus the facts by supporting few evidence in literature. The common belief is the most common belief. These are the 8 areas which I would be covering. The first and the foremost is the timing. When I entered this hall, there was a presentation going on the functional appliance, and everybody is sitting in the hall, including me, believes the sooner is the better. So what is the literature? We'll find out. What is the mode of action? How these functional appliances work? In the basic books, the mode of action has been described very beautifully, but exactly how the functional appliances are working does the mandible only translate forward? Is that the only way how it brings about change? What are the treatment effects? Mainly we think that there are more of skeletal effects if we start early. Few appliances are chosen because they bring about more skeletal than the dental effect. They have a positive effect. Whether they have a positive effect on airway and what is the role in obstructive sleep apnea, that is also one of the area which is now being explored. What is the role of class 2 elastics? I am a strong believer that if you master your technique, any technique can bring about changes. So stating that the class 2 elastics are not effective and the fixed functional appliances are better, And over the fixed functional appliances, the removable functional appliances are still better. That one has to actually find out what is the answer to it. The dental effects are reduced by capping the lower incisors. The most of the students who are sitting here, the postgraduate students, you must have heard your instructors or your supervisor saying, you did not cap your lower incisors, that is why there is flaring of incisors. So what exactly does the literature say about capping of lower incisors? Now the appliance, the timing of the appliance, for how many hours the appliance has to be worn. If the appliance work, we orthodontists are in a habit of taking the credit that we have done wonders. If it doesn't work, we always have the answer, we did not get good compliance from the patient. So patient is always blamed for not wearing the appliance. Till I search for the literature, even till today, the postgraduates who are sitting here and they are working with me in the clinics, I always insist, wear them for 24 hours. Wear them during the time of eating. You are not getting results because you are not eating for 24 hours. Is it a myth or a fact? This, I think, when we read the literature, we come to know the importance of full-time wear or what is the importance of time. The last, which common belief regarding functional appliances are the patient compliance, which is always poor with removable functional appliances. That is why we select, no, we'll put a fixed functional appliance because we do not have good compliance. So how the difference between a fixed and a removable? So the selection of the appliance is another area where we have few beliefs with us. So this is what my role is. Now the literature search starts. So bear with me. Now, first of all, we take the first um, area, that is the timing. The timing of the therapy. The fundamental concept in dentofacial orthopedics has been that there is a greatest effect of functional appliances when it occurs, when the peak of the mandible, the growth is included in the treatment period. So this everybody knows that when to start, and this remains a fact that in boys, especially, the growth spurts in the length of the mandible is less in the maxilla than in the mandible, but follows a cephalocordial gradient. Whereas in girls, the girls' juvenile acceleration in the growth occurs 1 or 2 years before adolescent growth spurts. So the fact remains the same as it's stated by Besati et al., that the best time is to give a functional appliances is the peak in the pubertal growth, which corresponds to the C3 and the C4 stages. Thus, this becomes an ideal time for using a functional appliance. So there is no second thought about it, that we all like to give the functional appliance during C3 and C4. Now, what is a fact? If you go back to literature, in this Cochrane review, which was done earlier, this is the reference of 2018, but same authors did a Cochrane review in 2012, and they concluded that the early orthodontic treatment for children with prominent upper teeth, it is more effective in reducing the incidence of trauma. As I said, that there was a need of doing early treatments because of the self-esteem in the patient, to improve the psychological impact of the child, so boost the self-esteem of the patient. And the growing child, when the result was reviewed and revisited, the conclusion changes that the changes which are seen in the growing child at C3, although they were favorable and in a favorable growth pattern, and the results which they saw were stable when they treated the cases in C3, that means when the growth spurt was in the C3 stages. And the stability was analyzed, the results which they treated in C3 were more stable as compared to the cases which were treated later on. So this is a Cochrane review. Now, another regarding the timing, that the treatment effect of removable functional appliances when they were treated in prepubertal growth and pubertal growth. This is just a table which tells us the skeletal changes with individual variations to the treatment responsive in the pubertal patients. Now, this states that the skeletal effects seen during the pubertal growth spurts were much more than the same patients where the changes were evaluated in the prepubertal growth. So there is the increase in the total mandibular length and the ramus when the children were treated in the pubertal growth rather than the sample which were treated in the prepubertal growth. So the timing is, again, these are all facts. When to give, the peak time is the prepubertal. Now, another interesting study, it's an observational study, which tells us the effect of orthodontic functional appliances in relation to, again, the maturation cervical vertebrae in class 2. This also was done as a longitudinal study with a sample size of 235 patients. They used a center bite jumping appliance, and the duration of the use of the appliance was 1 year. They also concluded that there is a proclination of the mandibular incisors was found in all the cases, whether the cases were treated in CS1, CS2, or CS5. That means the type of changes which they encountered, whether you start early or you start late, is going to be the same. So this is a fact? So we are getting confused with the literature. The results which they are showing in literature are varied. Whether it is more stable, but the kind of the changes seen are more similar. So the conclusion here regarding the timings, maybe I would be summarizing a little later. I now go to the next step, that is what is the mode of action. Many of us might still be in a dilemma regarding the mode of the action because there is a full chapter. How does it work? We only say that the mandible gets translated and it comes downward and forward. There are multiple areas how the functional appliance work. However, in recently, there is an entire structural and functional effect which has been documented in literature to the postural changes which a functional appliance brings about in the mandible, and it seems to be a neuromuscular component as well. It is not only the advancement of the mandible, the neuromuscular component which gets activated brings about the remodeling changes in the base of the glenoid fossa, which along with the translation, so it is the effect that what we see if we are forwarding the posture by 7 mm, the kind of the change what we see is 50% condylar growth, and the displacement of the glenoid fossa remodeling contributes equal. So it is not only the translation of the mandible forward, but remodeling of the glenoid fossa as well. And one more finding which came out by this study was that there is a decreased postural activity of the superior and inferior heads of the lateral pterygoid muscle, masseter, and the anterior digastric muscles. So what does this say? So the fact remains that there are following cascades of events taking place at the microscopic level and various cellular and molecular changes taking place to finally bring about the condyle glenoid fossa remodeling. So this is a complex structure which every postgraduates learn, and they have to learn that how the condylar growth is occurring. It is not only the translation of the mandible, but it is the gene, it is the microscopic and the molecular changes which are occurring at both the areas. So I'm not going into detail. Now, another evidence, this study was done and is a follow-up from our own center, which also stated that we studied the neuromuscular adaptation of the patients who were treated with fixed functional appliances. It's a 2 years follow-up study. This also stated that there is a neuromuscular adaptation which was documented after 6 months. The activity, the EMG activity of the muscles came down at 1 month, 3 months, but it got stabilized, it came back to the same after 6 months, and it is still after 2 years follow-up, the activity came back to normal, which was the pre-treatment activity for that patient. So similar studies have been carried out, which states that what is the neuromuscular adaptation of the muscles takes place. Another similar and a recent study which was found that it also supports that the functional appliance leads to mild atrophy of the masseter muscle, possibly because of the altered functional activity. And these functional appliance therapy is thus associated with an adaptation of the masticatory muscles. So the concept of functional matrix theory here works. So the change which is brought about is a complex system. It is the neuromuscular adaptation more of the masticatory muscles which brings about the change in the mandibular position. Similarly, in recent study, it was also found that when the TMJ was evaluated by taking MRIs, it was also found that the functional appliance should be regarded as an exercise device that lead to the neuromuscular changes by facilitating muscle adaptation and activating various brain regions. So another supporting study which supports that it is more of a neuromuscular adaptation which brings about change in the mandibular position. So we all know that now we are into acceleration of the tooth movement. Similarly, few researchers thought that can we activate the changes at the condyle by using laser therapy. So I could see few areas where people have even thought of accelerating the change at the glenoid fossa or at the condyle by the effect of low laser therapy on the condylar growth in children treated with functional appliance. This is just a preliminary study which states that like any other laser therapy, low laser seems to have a synergistic impact on the skeletal and the dental outcomes of twin block patients who were given this therapy for 9 months. But the evidence was not very strong, and they recommended that more studies are needed on this. This is just a preliminary study with limited sample size. So this is not a very strong evidence to state that laser therapy does increase or it stimulates. More research needs to be done on this. Now, another area, we know that how the mode of action takes place. Now, the effect, which I listed out, now, where are the effects seen with the fixed function or fixed or removable functional appliances? It is still a very pertinent question in our mind. What changes does the functional appliance actually produce? So these have been documented, and sum total that there are some skeletal and dentoalveolar changes, such as it accelerates the mandibular growth, it restricts the maxillary growth, there is a backward tipping of maxillary incisors and forward tipping of mandibular incisors, and the entire mandibular dentition sometimes. There is a differential eruption. You can level the curve of Spee by allowing the eruption of the posteriors and by tipping the occlusal plane. So these are the broad areas where the functional appliances bring about changes. So let us see what evidence do we have in support of this. So a study which I came across, these are all systematic reviews. The systematic reviews are now, this systematic reviews which was suggested that the renewable function appliance in short term, which was compared with normal growing patients, if no treatment was given, showed that there is a minimal skeletal effect with renewable functional appliances and of negligible clinical importance when the natural growth was taken into account. That means when it was compared with untreated individuals. So what dilemma we have that even if we treat the changes what are seen, if we would have left the patient untreated, whether the results would have been same. So yes, the fact by this systematic review is that few cases, if you leave untreated, would also show a similar kind of results. The only conclusion by giving a functional appliances was that only the rate of the growth, not its quantity, seems to have been modified. So the possibility is that the short-term increase, what was seen in the mandible, that is the growth seen. However, the effect of the long-term skeletal treatment are weak and insignificant. So what do I mean by this? Maybe this graph is more clear to explain. That this graph shows us that there is a temporary acceleration of the faster growth which occurs during functional therapy, but it slows down the growth thereafter, ultimately brings the mandible back to the size that would have been expected without the treatment also. Thus, we can see from this graph that any functional appliance would brings about only the temporary acceleration in the treatment, and the results what we get would be not seen after that what is already I would say genetically determined for that patient. So the effect that we are growing mandible is again a myth in our mind. It is already genetically predetermined by for the child, which when to do is the choice of the operator. So now there are a number of articles seen in the literature which shows the effect of the functional appliance on the airway. There are multiple articles which show that there is an improvement in the pharyngeal airway passage. These are few articles which are in support and states that the airway improves. So this improvement of pharyngeal airway passages is with the use of the functional appliance therapy. Now the fact is, of late in the International Journal of Pediatric Otolaryngology 2017, a meta-analysis, it states that the functional appliances significantly increase the dimension of the oropharynx only, and it has no effect on nasopharynx and hypopharynx, and have no effect on the hyoid bone position as well. Only the soft tissue length also decreases by just by 2.0 mm, and the soft palate changes or its inclination decreases by 5 degree. So the evidence also is being supported recently by another systematic review by Ansuya, and they also supported that only the pharyngeal airway dimensions, although they improve significantly, but this is mainly on the oropharyngeal airway passage, which is very prominent rather than and when they compared the fixed functional appliances with removable functional appliances, the removable functional appliances results were more in terms of fixed functional appliances. And the change in the hyoid bone distance, it was more prominent in horizontal direction rather than in the vertical direction. So these regarding the airway, now there is a collaborated by another authors in the latest meta-analysis published in European Journal of Orthodontics in 2021. And this evidence is also pertaining to the increase in the oral and the naropharyngeal airway and the anterior posterior position of the hyoid bone, which is supposed to be a weak evidence when they state for the hyoid bone position. Now, further challenges which arises is in front of all the orthodontists is which appliance we have to choose, because there are variety of appliances, removable versus fixed appliances, and whether we should go for removable, fixed, or whether to use class 2 elastics, fixed functional appliances. So dilemma still remains which appliance is the best. Now let us see what does the literature have to say. As we all can see in this table, most authors are of the consensus that all the functional appliances produces 30 to 40% of the orthopedic appliance, and the rest 60 to 70% are the dentoalveolar effects. So the kind of changes which we are seeing, whether removable or functional, are more of dentoalveolar in nature. Now, again, this fact is supported in the recent evidence. Also states that there is a little difference in dental and skeletal effect whether we choose a fixed or a removable functional appliance. Most of the overjet correction are dentoalveolar in nature, and that too with a very small component of skeletal change, that is by 1 or 2 millimeter. So if we have to conclude regarding the selection, we would say that the literature says that more skeletal contribution seen is by removable functional appliance over fixed functional appliance. There is more skeletal contribution with rigid fixed functional appliance over flexible fixed functional appliance. And if the removable appliance works more on the mandible, the fixed appliance shows more changes on the maxilla. So if we are concluding by the literature, this is what we, in summary, we would conclude. Now, if we see the correction which has been seen with the class 2 elastics, the class 2 elastics correction is primarily mainly dentoalveolar changes, and the results with fixed functional appliances are similar in long terms of class 2 elastics if these cases are followed up. So choosing a class 2 over fixed functional is not a bad option. Only thing is you have to know your biomechanics well. The similar kind of changes can be brought about with class 2 elastics as well. So the fact that what kind of appliance or whether the fixed functional or class 2, here the changes in the profile, the attractiveness of the patient, the reduction in the convexity of the face is the same whether you use class 2 over a fixed functional appliance. This is just a tabular form of comparing how class 2 elastics works and a fixed functional appliance works. We know that when we are giving any elastic, it is like an intermediate action, or the force is not continuous, and the elastic exerts tractions. So we have to judge where we want to take what kind of tooth movement, and the kind of changes which elastics brings about is the extrusion of molars and extrusion of the upper incisors as well. So the selection of the patient has to be appropriate. Mostly these kind of changes are going to be seen and they are inevitable. So the choice of the patient has to be dependent on if you are looking at the changes in the occlusal plane, that is the rotation, what you see should be downward and backward movement of the mandible. So if your patient gets benefited by class 2, please opt for class 2 elastics, whereas the fixed functional appliances, it gives a continuous kind of force, but it has a push mechanism. So we normally see that there is some intrusion of the maxillary molars and there is a intrusion in the mandibular incisors as well because of the push mechanism. And the occlusal plane is maintained. So here, as an operator, you have to see where your patient is favorable and unfavorable. As far as the evidence says, both brings about a similar kind of skeletal and dental effect. Now, there was when I searched the literature, there was a comparison of Frankel 2 with a modified twin block appliances, which we all tend to give in an early mixed dentition, that we say that we will modify or we will try to increase the arch width of the jaws. That is the phase 1, if the patient comes to us early. But in literature, they found that the patients who were treated within the age group of 11 to 14 years, the class 2 division 1, whether it was treated with FR2 or twin block appliances, showed a similar results. There is another comparison, that is RCT done with the advanced sync, which also shows that there is more of twin block had more dentoalveolar effect rather than the advanced sync. So the appliance design, whether to go for an acrylic capping, role of skeletal anchorage, single step versus stepwise advancement, the literature is full and we are still confused that what kind of biomechanics one has to follow. The only literature I could say that the incisal capping has no role and the kind of results, we still feel that the incisors inclination remains the same, or it whether we cap the incisors or we don't cap the incisors, there is a proclination. So we have to take a call that what incisal capping is helping us to do. Now, to whether to go for the anchored, skeletally anchored fixed functional appliances, again, the literature says that use of mini plate implants effectively increases the mandibular length in short term. And the graph, if you see that this is the first, shows the overjet correction with only forces, and the next group is overjet correction with forces with mini plate. Mostly the changes which are seen are dental only. But the percentage of dental changes when you take the help of mini plates reduces. But the overall effect remains the same. The effect on the dental proclination in the incisors reduces when we take a anchor from the mini plate appliances. This is just how the net effect would be the mandibular advancement with forces and the mandibular advancement with forces with mini plate. So more changes in the mandible if it is supported by the mini plate anchored. Even in literature, you will find more literature when even the bone anchored with fixed functional appliances has been advocated and compared with tags. They also say that superior skeletal effects are seen and reduce the inclination of lower incisors in short term. But these are all short term results. However, evidence is shown to be moderate to high risk of bias. Now, another myth which remains with us, whether to use a stepwise advancement or single step. There are a few literatures. I'm just scrolling through. I think I'm only left with 2 minutes. Although the magnitude of difference in the clinical practice where we use stepwise advancement might be more appropriate because it produces a greater skeletal change and less of dental compensations with single step. So the single step is definitely showing more dental changes as compared to stepwise. So there has been more now literature on the wear protocol. Like I said, for how many hours the patient should wear. The literature now, this is also telling us where the research has been taking us. It is the time and how much person is wearing and when to wear. When the two groups were given a similar kind of appliance, and one was asked to wear for 24 hours and the other was asked to wear only for a limited time, it showed a similar kind of results. So the timing of wearing a twin block also now varies. We are not dependent on that the patient has to wear it for 24 hours. Even from 6 to 8 hours can give us a similar kind of results. And this is what the literature facts tells us now. So this is another gray area where the research is needed. The duration of the time, which is also seen very recently in literature. Another thing, that what is the review of intervals when your patient should be recalled? Like we have a protocol calling the patient after 1 week, then 10 days, asking them to give monthly visits because of giving a motivation or to seeing whether the patient is wearing. So there are many areas where the research is going on. So the only conclusion that when we call the patients early, we are only doing them, or we are only re-emphasizing the treatment. But all this don't work. It is only the self-motivation of the patient. If he's motivated, you are going to see the results. There has to be only supervised. The orthodontist needs to be supporting them by giving the information. So the quality of life with the appliances when compared with other kind of functional appliances where Invisaligner sheets were added with bite blocks also gave us similar results, that the design of the patient, the choice of the material would not make any difference. It is how the patient is well motivated to wear that appliance. Even with Invisalign teen with mandibular advancement, patient's perception was the same, that they are giving pain, they don't work, the bite blocks are higher, they trouble us. So that the literature also now is comparing on Invisalign bite blocks with conventional twin blocks, but the results remains the same. It is the patient's motivation. So my last conclusion slide, I will just
भी
go
बहुत
through.
बिस्मिल
When to start is sooner we start better. Now, again, the conclusion is that C3, C4 stages are the best. Mandibular grows by translating. No, it grows by condyle glenoid fossa remodeling. Mostly skeletal changes are produced. No, it is a sum total of skeletal as well as dental. Dentoalveolar class 2 elastics are more effective. No, both are effectively similar as far as the results are seen. Removable functional appliances are more effective. No, both are equally effective in literature. Dental effects are reduced by incisal capping. No significant difference was found. And monthly recalls and full-time wear is essential. No, only 6 to 8 hours and 6 weeks recall is equally effective. Patient compliance is always poor with removable functional appliance. No, it is a multifactorial process with orthodontists playing a very crucial role in motivating their patients. So, my dear friends and students, there is a lot of scope, future scope, which always needs to be answered. It is regarding the high quality evidence, more longitudinal and 3D studies with longer samples, larger sample size, effect of lasers, as I said, in evaluating the condylar remodeling, adaptation of temporomandibular joint and neuromuscular effect, RCTs in long term of stability, and for future clarity in wear time, duration, recall appointment, and recent advances. So thank you very much for patient listening.
Thank you, ma'am, for the wonderful presentation. I'm sure the audience are much wiser with the quantum of evidence which has been displayed in the presentation. Thank you, ma'am.
I request the chairperson to felicitate ma'am. I request Manarikar sir to felicitate our chairperson, Dr. Mona Prabhakar ma'am, and Colonel Dr. Dattana.
Thank you so much, Dr. Manirekar, sir. I would now like to invite the organizing secretary, 26th Indian Orthodontic Society National Postgraduate Student Convention, to give a small promotion for the event. Dr. Raj Kumar Jaiswal.
Thanks a lot, dear sir. Respected seniors, dear juniors, colleagues and friends, a very good morning. First of all, I would like to congratulate the team IOC Pune for hosting such a magnificent event effortlessly. And also thank them to allow us to give us a video presentation for a forthcoming convention at Lucknow. So we'll start off with the video presentation. Kindly have the video, please.
किया तबाह तो दिल्ली ने भी बहुत बिस्मिल मगर खुदा की कसम लखनऊ ने लूट लिया अरे भाई ज़रा मुस्कुराइए, आप लखनऊ आने वाले हैं।
Not play, play. Thanks a lot. And I hope you give us opportunity to come down to Lucknow and host us. Thanks a lot. Thank you.
Thank you so much, Dr. Rajkumar Jaiswal. Now it's time for the third main oration of the Indian Orthodontic Society, Dr. V. Surendra Shetty oration, for which I invite our respected President-elect Sir, Dr. Balwinder Singh Thakkar, to kindly chair the session. Thank you.
Dr. Malaram Manohar. The speaker has a distinguished career as a professor in orthodontics and dentofacial orthopedics at the College of Dental Sciences, Davangere, where she has served as the head of the department for the term of 5 years before retiring in June 2022. She runs her own specialty practice at Calicut since 1988. She completed her master's from College of Dental Surgery, KMC Manipal, in 1987 and has 34 years of clinical experience in orthodontics. She has to her credit an impressive list of publications and presentations, both nationally and internationally. She was a special invitee to the Kenyan Dental Association at Nairobi, where she spoke on dental implications of android enlargement. As an active life member of Indian Orthodontic Society, she has served the society in the capacity of executive committee member and as a vice president. She is the director of Indian Board of Orthodontics and has held honorary post of Calicut Orthodontic Study Group and Indian Dental Association Malabar branch. She is the recipient of Clinical Innovation Award at the 8th EPOC held in Delhi in the year 2012. Her commitment to the subject of orthodontics has had a participating in slew of study groups and workshops at zonal, regional, national, and international levels. Traveling and photography are her favorite hobbies, which we normally see in all the media conventions. So I'm here to have the privilege to welcome Dr. Mala Ram Manohar, ma'am. Off to you, please.
Very good morning to a very good morning to one and all. I hope I'm audible. Today, it is with great pride and honor that I am presenting this oration in front of you because Dr. Surendra Shetty is my teacher. Sorry. This basically is a very nice view of the Bryce Canyon in Utah. I got a picture of it in the beginning, early morning. It is a sunrise, and it was a very cloudy morning, and I got just a few minutes to capture this. So I thought I will share this with you. This second picture, I purposely have put it because it represents camouflage. If you look at the bighorn sheep over there, if you look at the bighorn sheep over there, they are very nicely camouflaged. And in my mind, camouflage is very difficult. So I usually try to find a more simplistic solution than camouflage in my treatment plans. So today we are going to look at some complex malocclusions and see how we can most simply treat them. Okay, it's fine. Okay. So Dr. Surendra Shetty is my teacher. And right from the beginning, as when I was a dental student, growing up in the small town of Mangalore, I knew about this only orthodontist in Mangalore, Dr. Surendra Shetty. And in my third year, when I was studying, I had the opportunity to listen to him because he came to my college in Manipal and gave us a lecture in cephalometrics. So that was the first time I saw him. So in fact, I don't know whether he knows I was in that class, but because of that, I consider myself his first student of orthodontics. So today it is a double honor for me to be presenting this oration because yesterday my teacher was honored with the Lifetime Achievement Award. And I'm really pleased. Congratulations, sir. A great achievement and truly deserved. So, Dr. Surendra Shetty is a very unique personality. He does not try to clone his students. He just allows them to grow into their own personalities. But the bottom line is achievement of perfection and excellence. At this point of time, I would be failing in my duty if I did not acknowledge the role of God's Davangere in my progress. Because Dr. Subbareddy, the director at that time, called me there and he gave me the opportunity to work there. Dr. Kalha created a very good department over there, and so that also helped me a lot. And all my colleagues and my postgraduate students who have been my support. Growing up in this doing my post-graduation, when I started my journey as a young orthodontist, we were trained in the Beg philosophy in Manipal. And we had limited opportunities. But at the same time, we have learned how to be thinking orthodontists because we had to do with the simplest appliance, we had to do what we could with the simplest appliance. This was a 14-year-old male patient who came to me, this was one of my first patients who came to me with mild crowding and proclination. He was treated with the extraction of 4 first bicuspids using the WEG appliance. 10 months into treatment, the spaces were all closed and the third stage was started. A true example of the efficiency of light orthodontic forces. 16 months into treatment and the appliance was debonded with very good facial aesthetics and ideal occlusion. 2 years into retention, he still had very good facial profile, a very good balance, and still an ideal occlusion. I want you to notice that there are no fixed retainers here. Just upper and lower beg retainers were used. This was his comparison. Even with the removable functional appliances that we used at that time, we got very good results and we managed to give our patients very good aesthetics and functional occlusions. I would request you not to photograph my patients. Excuse me, because these are all, most of them are my private practice patients. Please don't photograph them. Thank you. But now, today, we live in that part of the world which throws at us the most complex malocclusions. And today, we do not treat malocclusions just for aesthetics. We have to keep function and stability in mind. In fact, today, aesthetics is being disregarded in the treatment of patients with sleep apnea. So in my mind, when I see a complex skeletal malocclusion, my treatment plan would be a surgical treatment plan. But today, surgical treatment plans are being frowned upon. And everyone thinks that they are too complicated. But it need not be so. So let us just dispel that myth with today. Let me start with this type of malocclusion, which is called or popularly called the birth phase deformity. Usually, it is because of the traumatic injuries to the TMJ in the growing phase. They normally presented with severe mandibular retrusion, with limited mouth opening, and a compromised airway, severe profile convexity, difficulty in chewing, and an increased overjet. This is a 14-year-old female patient who came to us with a complaint of a small chin. This is what she looked like. She gave us a history of fall, a trauma at 6 years of age, with leading to TMJ ankylosis, following which an arthroplasty was performed. The chin-throat angle was 180 degrees. Intraorally, she presented with a class 2 Div1 type of malocclusion with an overjet of 13 millimeters and an open bite of 1 millimeter. Her A and B was 18 degrees and her mandibular plane was very high at 45 degrees. Upper and lower airways both were compromised. Her upper dentition was normally placed, but if you see the lower dentition, it is extremely protrusive at 15 millimeters and 43 degrees. She had a bilateral absence of the condyles with asymmetry, underdeveloped rami, and a decreased disc space. So we decided to treat her with surgery. Now, a BSSO of 11 millimeters with counterclockwise rotation and an anterior sliding genioplasty of 8 millimeters. To decompensate, we decided to go non-extraction because in spite of the increased inclination and proclination of the lower incisors, the overjet was already 13 millimeters, and retracting them would further increase the overjet, and it would be impossible even surgically to bring the jaw forward to that extent. So we level and aligned her and prepared her for surgery. You can see that the open bite is pretty evident now. This is what she looked just pre-surgically. All the necessary procedures were done and the splint was fabricated. BSSO was performed. This was the improvement on the table. And this was the immediate post-surgical occlusion that we achieved. Her airway improved by, upper airway improved by 2 millimeters and the lower airway improved by 10 millimeters. This was the facial improvement we got. This was the occlusion we finally managed to achieve. We managed to give her a very functional ideal occlusion, and this was her facial improvement. Of course, she is still convex, but we gave her a good chin projection and very good chin-throat angle. This was the second case, a very similar case, 13-year-old female patient who was also treated with 10 millimeters of mandibular advancement and 6 millimeters of augmentation genioplasty. We managed to treat this patient also to a reasonably good occlusion and facial profile. This was another patient who was also treated with mandibular advancement and advancement genioplasty. Now, when we analyzed all these three cases, you will see that there was significant improvement. The A and B increased by 10 degrees. The mandible came forward 16 millimeters, and the airway improved by about 8.5 millimeters. And we took just around 2 years to treat all these patients. So there is sufficient evidence that mandibular advancement brings about improvement in OSA. There is a significant increase in the pharyngeal airway space with mandibular advancement. The retropalatal, the retrolingual, and the intermaxillary dimensions increase, and the tongue proportions reduce. The airway changes are also positive with counterclockwise rotation of the maxillomandibular complex and is useful in high-angle patients. Besides mandibular advancement, genioglossus advancement is also beneficial to OSA patients. Genioglossal advancement is just a rectangular osteotomy of the chin which brings the genial tubercles forward. However, the horizontal augmentation genioplasty that we perform has the additional advantage of improved aesthetics along with bringing the genial tubercles forward. So there is agreement that there is significant pharyngeal airway increase post-operatively after mandibular advancement with or without maxillary advancement in the short term. However, there is disagreement in the long-term retention of this increase. Some studies have found that the increase to be retained long-term in cases which had reduced airway preoperatively. Single jaw mandibular advancement osteotomies have led to better airway increases than single jaw maxillary advances. And recently, it has been found that the oxygen saturation, the mean airway volume, and the smallest cross sectional area all significantly improve with mandibular advancement. Airway considerations are becoming extremely important today, and as an orthodontist, we probably are the first to diagnose a potential airway problem and prevent it from becoming a full-blown OSA in children. OSA in children has the potential risk of memory loss, poor academic performance, ADD-like behavior, and cardiac complications. Although polysomnography is treated as the gold standard for diagnosing OSA, it is labor intensive, time consuming, and expensive. The overnight pulse oximetry is a highly effective diagnostic tool for moderate to severe OSA patients. In this respect, we studied 3 primary screening tools to predict the risk of OSA in children: the 8-item If Sleepy questionnaire, radiological evidence, and an overnight at-home pulse oximetry were evaluated. The significant correlation was found between all 3 diagnostic tools. The questionnaire and pulse oximetry were found to have the maximum correlation. So we recommended that subjects with positive correlation of any 2 of the 3 diagnostic aids may be investigated further. In this respect, the role of the twin block appliance in the effect of airway in growing children needs to be highlighted. We studied 25 subjects in the age group of 10 to 14 years from the start of the treatment to the end of the fixed phase. Upper and lower airway dimensions following the functional phase increased significantly. The upper airway increase was stable even up till the end of the fixed phase, whereas the lower airway increase was not. As Gina et al. Pointed out, that the treated patients had improved soft tissue dimensions and inclinations, pushing the tongue away from the soft tissue, thereby sustaining the upper airway changes. The lower airway decrease could be attributed to an increase in the size of the tongue in response to the twin block treatment. However, the lower airway relapse was well within acceptable limits, and the benefits of the treatment were not lost. In this respect, I would like to show you this case. This is a young 13-year-old patient who came to us with a complaint of forwardly placed upper teeth. She also had reduced lower facial height, an acute nasolabial angle, and a convex profile. Intraorally, she appeared to be class 2 div 1 malocclusion with an overjet of 10 millimeters and an overbite of 6 millimeters. She had a low mandibular plane angle. Her A and B was 5. Her upper incisor was excessively proclined at 41. This is very significant. And the lower were retroclined. Normally, even the lowers are proclined, but in this case, the lowers are retroclined at 19 degrees. And she had lower facial height. She was in the 3rd stage of CVMI. Her VTO was positive. And so we decided to give her a twin block appliance with a classical advancement of 6 millimeters and an opening of 4 millimeters. She responded very well to the functional appliance treatment, and her mandibular angle opened up to 22 degrees, A and B reduced to 1. Her upper and lower incisor inclination became almost normal, and her upper airway increased by 4 millimeters, and the lower airway increased by 8 millimeters. She had significant improvement of the airway, and the fixed appliance treatment followed, and we gave her a very good occlusion and very balanced facial profile. Even at 2 years post-retention, she retained the facial improvement and the occlusion was very well settled. This was her comparison. This was the case that had all the positives for a functional appliance treatment, and she responded very well. This was a patient who came to us at 10 years of age, and this was his occlusion, a class 2 div 1 malocclusion. So since he was 10 years of age, we decided to put him on a twin block appliance. But we never saw the patient after we delivered the appliance. And then at 16 years, this is how he reported to us back. There was absolutely no change. And when we inquired, we found that he had not worn the appliance at all. So there was a big compliance issue over here. And because of the compliance issue, we didn't want to take any further risk. Though there was some growth left, we did not, his BTO was positive. Though there was some growth left, we didn't want to take the risk of testing his compliance again. His ANB was 7, the mandibular deficiency was about 13 millimeters, and there was a low mandibular plane angle. So we decided to go in with a surgery first approach, mainly because I was concerned about his compliance. I was not even sure if we do a conventional surgery, whether he will follow through with the treatment and come back. So we just wanted to bring the mandible forward. So we did a mandibular advancement of 8 millimeters and followed a non-extraction pattern of compensation. So the surgery was done, and this was his improvement post-surgically, very good improvement. This is 2 weeks into treatment, we placed the wires. The treatment progressed, and this is how we debonded the patient. This was his improvement. So the A and B increased from 7 to, it went down to 2 millimeters, and the entire total treatment time was only around 11 months. So this is something that you can do. And there was 8 millimeters of improvement in the airway. So this is something that you can do when you have patients whose compliance is really questionable. This was his improvement, how he progressed. We got a very good occlusion. Yes. Now, let us look at some vertical dysplasias. Vertical dysplasias are extremely difficult to treat and retain. Most of them have a hereditary etiology. The musculature is also involved. The relapse potential is also high. So, and very often these are the normal characteristics they present with: severe mandibular deficiency, reduced mandibular plane angle, reduced LAFH, increased gonial angle prominence, class 2 malocclusions, traumatic occlusions, gingival impingement, and a square face. So this was a 15-year-old male patient who came to us with irregular front teeth. This is how he presented. And he had a mandibular plane angle of just 8.5 degrees. The lower facial height was also very much reduced, and an ANB of 6 degrees. There was considerable amount of vertical maxillary deficiency also, and he had a retroposition and a retrognathic mandible with counterclockwise rotation. Upper and lower airway both were compromised, and there was severe retroclination of upper and lower incisors with an interincisal angle of 170 degrees. So we went ahead with a surgical treatment plan, surgical advancement of the mandible with bilateral gonial angle reduction and a vertical augmentation genioplasty. We prepared the patient for surgery. SS Australian wires were used to open the bite, and then we decompensated him to a class 2 div 1 malocclusion with an overjet of 10 millimeters. Subsequent, this was how he looked at just before surgery. So the surgical plan was to advance the mandible by 10 millimeters. The envelope of discrepancy says you can advance the mandible up to 10 millimeters. So we usually try to restrict ourselves to that. We don't really want to push the envelope too much. Gonial angle reduction and a vertical genioplasty or augmentation genioplasty of 9 millimeters. the VTO was positive, but please note the gonial angle prominence when the mandible is advanced. So you have to reduce the angle along with the BSSO. So this is how the BSSO was done, and the segments that we get with the BSSO, these segments that we get with the BSSO are used as grafts during the vertical augmentation genioplasty to make it more stable. So this was the improvement. The mandibular plane angle increased by 19 degrees, and this was the correction that we achieved. This was the immediate post surgical occlusion, and this is how we managed to finish the occlusion with an ideal overjet, ideal overbite, and a class 1 molar and canine relationship. This is how the skeletal tissue progressed. This is his improvement comparison, the intraoral comparison, and this is how the patient. This was the second patient, a similar patient with almost similar intraoral appearance also. Even his FMA was very low. A and B was also 6 degrees. But this patient had a mild facial asymmetry because of the increased gonial angle projection on the right side. So we decided to go in with a mandibular advancement of 7.5 millimeters, asymmetric angle reduction, and a vertical augmentation genioplasty of almost 15 millimeters. That might sound excessive, but when you have placed grafts, it is pretty stable. So this is how we prepared him for surgery. Note the asymmetric angle reduction, and this is how the patient progressed. This is the superimpositions. We managed to get both the right and left sides of the ramus to be perfectly symmetrical. The intraorally, the patient finished like this, and this was the extraoral improvement. And this is how the patient finished. So both these patients were treated in a span of about 24 to 30 months, which is not too long. And the mandibular plane increased by about 15 degrees. The lower facial height increased by about 14 degrees. The interincisal angle was normal at 135 degrees, and there was significant improvement in the airway. However, we did not address the maxillary vertical deficiency. Why? Now, the reason behind this was these two cases were treated around 2010. And at that point of time, I was not very confident about the stability of the maxillary downgrafting. So that was one reason why we did not plan this. Secondly, I was just trying to keep the surgical intervention as minimal as possible by sticking to a one jaw surgery. I didn't want to overdo it. Now, so far I have shown you patients who are definitely surgical patients. They cannot be treated any other way. Now I'm going to show you two patients who can be treated any other way. If you put it for discussion, you can have many treatment plans for these patients. But I chose to include an element of surgery in these patients because I thought that would be most beneficial for these patients. It's left to you to decide which is right, whether it was right or wrong. So this 20-year-old male patient came to us with irregularly placed teeth, and looking at his lower incisors, it is very obvious that it is a class 3 malocclusion. So he had an ANB of -2 degrees, and we decided to set his mandible back by around 6 millimeters. The dental VTO told us that there was increased space requirement in the upper arch, but not so much in the lower arch. So we went ahead with extractions in the upper arch, and we decompensated him to a -6 millimeters of negative overjet. Now, at the time, just pre-surgically, it was very obvious that we needed to re-evaluate the surgical plan. Because if you look at the chin point of this patient, it is very normal. You really don't need to set the mandible back. At the same time, the malar deficiency is very pronounced. So he needs surgery for malar augmentation, and the lower lip is very protrusive because of the negative overjet. So what did we do? We decided to go in for a subapical lower anterior osteotomy with malar augmentation. Of course, anyone can argue that you could have treated this patient with buccal shelf implants, but we did not do that at that time. So, and anyway, since he was going in for surgery for the malar augmentation, we decided to do a subapical osteotomy. So this was the procedure that was performed. You can note that there is a very evident osteotomy cut that you can see on the OPG, where just the lower anterior region with an on-table extraction of first premolars was done, and the anterior region was just set back. So this was the improvement that we got. I was very impressed by the improvement, and relatively the surgery was very simple, but it is a borderline class 3 case where you could try something like this. So we managed to give him a class 1 occlusion, and what I noticed is that all the dental parameters were normalized. And I feel that because the dental parameters were normalized, the stability will definitely be very good in these cases. And in addition to that, we managed to keep the post-surgical orthodontics at around 7 months, which is quite reasonable in conventional orthodontic surgeries. So this is how he progressed, and this is the occlusion we gave him. Now, the second patient is a 21-year-old female patient who came to us with a class 2 skeletal pattern with a bimaxillary proclination. Now, her upper incisors were proclined by 4 millimeters and lower incisors were proclined by 6 millimeters. So we had no choice but to go in for 4-4 extraction and reduce the proclination. However, the concern was that the upper and lower alveolar troughs were very narrow, and the roots were almost touching the cortices. So bringing about so much of retraction would have been difficult. So that is why we added an element of surgery. We did a corticotomy with grafts, and we progressed with the retraction. And if you can see, we have managed to retract the entire upper arch in a span of 4.5 months. Very good facial profile reduction, and we managed to keep the roots within the cancellous bone without any root resorption. And because of the surgery, we got an effective retraction of the incisors without any significant anchor loss. Otherwise, we would have had a lot. We could have done this with the implants. But without implants, it would have been difficult. So this is how the patient progressed. We managed to give the patient very good facial aesthetics. And we managed to finish the treatment in 10.5 months. That is the most important thing. So this is why I added the surgeries in these patients. Now let us go to one of my most favorite topics and something I'm most passionate about, and something that embodies the essence of complex malocclusions, easy solutions. So there were a series of case reports on surgery first approach between 2009 and 2013, which actually sparked off the interest in this modality of treatment. So the advantages were reduced treatment time, immediate resolution of the facial deformity, and rapid tooth movement post-surgery. Relapse also was found to be well within clinical limits, and the stability compared to the conventional surgery was also acceptable in terms of facial aesthetics and occlusion. The effects of surgery first on the quality of life compared to conventional surgery was far better at every stage. Obviously, because the patient does not become more worse before you do this surgery. Now, when you look at the indications of the surgery first, all these indications were just put forward by some clinicians. And now the reasons why these indications were put forward was they are all directed towards a shorter post-surgical orthodontic phase. So that is why they say that you need well-aligned arches, you need minimal crowding, minimal curve of speed. But that doesn't mean that you cannot treat other patients with this surgery. It's just that if you follow these indications, you will have a very short treatment plan. Otherwise, your treatment plan is likely to increase, just like how Dr. Sugawara showed us, moderate and severe, end up having long treatment plans. But in addition to that, if aesthetics is of the primary importance to the patient and the orthodontist, then surgery first is the treatment of choice. Just as in sleep disordered breathing, surgery first is the treatment of choice because you want to resolve the functional problem first. So that is the only reason why these indications and contraindications are given. And it is very interesting to note that in 2010, when Dr. Sugawara enlisted these advantages and disadvantages, he gave us 7 advantages and only 1 disadvantage. But at the same time, in 2021, when Choi and Lee gave us the advantages and disadvantages, the 7 advantages remained almost the same. But the disadvantages increased to about 8 in number. That is because as we grow, as we do more work, we become more wise and we realize what mistakes are possible. However, the shortened treatment time, the improvement in aesthetics and stability can always be guaranteed. However, a precise treatment plan is extremely important because you have to give the patient a very good transitional occlusion, because that is going to ensure that the patient is comfortable, there is early stability, and then there is a high level of patient and orthodontist satisfaction also. In addition to that, the experience level and the coordination between the orthodontist and the oral surgeon is extremely important. You must have noticed that even Dr. Sugawara, he has his own oral surgeon who does all his surgeries. Now, this is a 17-year-old female patient who came to us with vertical maxillary excess. Now, this is a clinical scenario where the results due to the overgrowth of the maxilla. There is excess exposure of the upper incisors at rest along with a gummy smile. There is consequent rotation of the mandible in the clockwise manner, and of course is also associated with a retrognathic mandible. There is a short upper lip, increased gingival exposure, excessive lip incompetency, increased lower facial height, and increased mandibular plane angle. There is reduced malar prominence, and the mandibular prominence is also reduced. However, this patient presented with a nice class 1 molar and canine relationship with very well aligned arches. So my first thought was ideal patient for surgery first. Skeletally also, she was class 1. She was not class 2. There was a normal anterior-posterior extent of the maxilla and the mandible. The problem was essentially vertical. There was extrusion of the maxillary teeth and of the skeletal base also. So because of that, she had a high mandibular plane angle and an increased lower facial height. So of course, we decided to treat her with surgery first approach. And the maxilla was supposed for impaction only of the maxilla 7 millimeters anteriorly and 5 millimeters posteriorly. You have to note here that if you do not do a posterior maxillary impaction, there is no way you can get auto-rotation of the mandible. So that is very important. And in addition to that, we added about 5 millimeters of vertical reduction and AP augmentation genioplasty. So we prepared the patient for surgery. We just band and bond the upper and lower arches, and we do not put any wires. This is the Eric Lou protocol that we follow. And just stainless steel ligatures are lace backed. So the mock surgery was done. The patient was, surgery went as scheduled. And this is the improvement that we got. Now, what happens? The auto-rotation of the mandible associated with that impaction was initially advocated by Schindel, Bell, and Fish. Steinhauser demonstrated that the amount of mandibular auto-rotation correlates with the extent of the maxillary impaction. The auto-rotation of the mandible results in shortening of the elevator muscles. As a result, there is no active or passive distracting forces acting on the maxilla, making this one of the most stable orthognathic procedures. You can appreciate the vertical augmentation. Genioplasty, there's a step which will eventually remodel. So 2 weeks into surgery, we place the initial wires. 6 weeks into surgery, this is what the patient looks after the edema has all resolved. So follow, what are the changes that happen? Following intrusion of the maxilla, straight up, the lip and the base of the nose, along with the pronasal nasal, move superiorly and forward. The nasolabial angle also decreases with the because the columella moves up at SSN more than what the pronasal movement is. And the upper lip moves anteriorly because it is far more better supported by the upper incisors subsequent to the intrusion. All the osseous mandibular structures auto-rotate in an axis, arc about an axis. According to Schindel and others, the soft tissue points like the inferior labial sulcus and the soft tissue pogonion rotated in the same arc in a 1-to-1 ratio with the B point and the pogonian point. The lower lip moves superiorly and forwards, allowing it to approximate the upper incisors. So the treatment progressed and we can manage to give her there was very little work to be done as far as the post orthodontic phase was concerned. This was her appearance at Debond, and we managed to give her a very good pogonion point. The reduced to pogonion came forward to -4. The LAFH reduced, the mandibular plane reduced, the LAFH reduced considerably. There was this little bit of widening of the alar base, but it was within acceptable limits, and a mild supratip depression also was seen. Now, there is how much of rotation takes place. So Nattestad predicted that an average of 5 millimeters of maxillary impaction would lead to 2 millimeters of horizontal advancement and 1.2 millimeters of vertical chin reduction. The horizontal movement of pogonion point was almost in a 1-to-1 ratio to the vertical movement of ANS, suggesting that this ratio could be used as a prediction of the horizontal chin position. Bell-Fish and Epker also described a 1-to-1 ratio between the lower face shortening and the mandibular autorotation. However, there is no agreement on at what is the axis of rotation of the mandible. Schindel is believed that the center of the condyle was the axis of rotation for the mandible. However, Nattestad et al. Said that the mastoid process was the center of rotation, whereas Wang et al. Said that it was located 2.5 millimeters behind and 19.6 millimeters below the center of the condyle. The total treatment time was 1 year, and this was the surgical superimposition. In terms of stability, very good stability has been predicted with maxillary impaction post-surgery. Sarver studied the post-operative soft tissue at 12 months and 5 years and found there was no difference between the two, suggesting that the treatment results that retain at the end of 1 year are likely to retain up to 5 years. And the latest study was done by Arnett et al. In 2022, and they found that the orthognathic surgical correction of skeletal open bite following maxillary impaction surgery is clinically safe and stable in the long run. This is my last case, and this is a case of vertical maxillary deficiency and short face syndrome. This is a 14-year-old patient who came to us with complaint of proclined upper anteriors. Now, this patient had all the classical features of short face syndrome. Convex profile, posterior diversion, mandibular protrusion, but competent lips, deep mentolabial sulcus, acute nasolabial angle, and a reduced lower facial height. Her lower thirds did not follow the rule of thirds, and there was only 40% upper incisor exposure on smile. Intraorally, she presented as a class 2 Div 1 malocclusion. That is why we could take her up for surgery first. She had an overjet of 9 millimeters and an overbite of 2 millimeters. She was in CVMI 6. The occlusion, her occlusion was of a hereditary nature, with the father exhibiting the same type of occlusion. She had very low anterior facial height, low mandibular plane angle, and excessively proclined upper anteriors at 51 degrees. The problem with these vertical maxillary deficiencies are that these deep bite cases are usually accompanied by a strong chin in an otherwise deficient mandible, complicating the treatment. So the surgical options are mandibular advancement with a chin setback, or a mandibular rotation with an advancement, or a bimaxillary rotation osteotomy with mandibular advancement. So we decided to go in for a surgery first approach with a maxillary inferior repositioning of 10 millimeters anteriorly and a mandibular advancement of 6 millimeters with an augmentation genioplasty. It may look as a real overkill to you, but since her problem was so severe, we were really over engineering the entire surgical procedure here. So we prepared her for surgery, and 2 splints were prepared, one for maxillary inferior repositioning and one for the BSSO. So the maxillary osteotomy was done and a graft was placed, and followed by the BSSO and an augmentation genioplasty. Again, a graft was placed even here. So this is what she looked immediately post-surgical. This was her occlusion, and all her parameters improved. All the vertical and anterior-posterior parameters normalized after the surgery, and the intraoral treatment progressed. This is what she looked at D-bond. This was her occlusion at D-bond. This is how she progressed. This was her comparison, and this was her superimposition. We got very good vertical correction, and the total treatment time was only 9.5 months. So previous reports regarding the down fracture of the maxilla have not been very encouraging. But that is because most of these surgeries were performed with a wire stabilization. But now, with the use of the rigid fixation, the bone grafts, that the relapse has become very low, because there is an increased osteogenesis which occurs, providing a matrix for the new bone to form, and by increasing the mechanical stability of the surgical site. The Perez et al. Found that the overall vertical stability after downgraft was good, with just 80% of the cases showing relapse of 2 millimeters or less. And there was no difference in the vertical stability of the maxilla, whether a single segment osteotomy was done or a multiple segment osteotomy was done. And also the amount of maxillary down fracture and the occlusal plane rotation also did not matter. So the clockwise stability, the stability of clockwise rotation of the entire maxillomandibular complex was discussed and found to be of good stability by Reneke and Camello. In conclusion, I would like to say that a patient-centric approach must be adopted. Aesthetics is important, but function and airway cannot be neglected. Interdisciplinary approach is the way forward, and a surgical intervention leads to a more holistic resolution of these skeletal malocclusions. The most dental and skeletal parameters, all the dental and skeletal parameters move close to normal, and that is what helps in increasing the stability of these cases. And of course, treatment time is also effectively reduced. Thank you very much for a patient hearing.
Thank you so much. Please.
Yeah. At this point, I would just like to thank our IOS president, Dr. Sri Krishna Chalasani, Secretary, Dr. Sri Devi Padmanabhan, and the entire team, Dr. Balvinder, for giving me this opportunity. I am truly humbled. Thank you very much. And thank you very much for the introduction.
Thank you so much, ma'am, for a great presentation. In fact, it was complex malocclusions, easy solutions. It was truly right because you had all the kind of cases and very well finished. And indeed, this is an oration, so we don't have any questions. But I'm sure there will be audience who would have many questions because there are a variety of cases that can be asked personally to ma'am. And it's an honor for a student to present oration in front of sir. So congratulations for the same.
Thank you.
Thank you.
Thank you.
Thank you so much, sir. I would now request our President-elect, Dr. Balvinder Singh Thakkar, sir, to kindly award a plaque of appreciation and certificate to Dr. Mala Ram Manohar. Thank you so much, sir. Thank you so much, ma'am. I would now request the scientific convener, Dr. Gauri Vichare, to kindly felicitate the chairman for the session, Dr. Balvinder Singh Thakkar. Thank you so much, sir. Thank you so much, ma'am.
For the for the next session, it's an international keynote lecture by Dr. Kim. I request Dr. Bhuma Vashi ma'am to chair the session. Dr. Bhuma Vashi is a senior orthodontist, IBO diplomate, and currently practicing in Mumbai. I request Bhuma Vashi ma'am to introduce our speaker. Thank you.
Good noon to one and all. Dr. Kim has done his Doctor of Dental Medicine, MS and Certificate in Orthodontics in 1999, Kyung Hee University School of Dentistry. And his PhD from Seoul National University School of Dentistry, Seoul, Korea. Dr. Kim held various academic appointments since 2003 till 2017 at Korea, Vietnam, and USA. Dr. Kim served at various administrative posts at various hospitals in South Korea and Vietnam from 2015 to 2021. He has more than 100 publications and international PubMed Index journal, and he has co-authored 3 international textbooks. Dr. Kim has contributed 15 chapters in various textbooks and more than 80 IP registered, 30 more patents issued in Korea, United States, Europe, and China. Dr. Kim is a renowned presenter and orator all over the world. He is lead guest editor of special issue in Census Journal. His article was selected as a cover article in the American Journal of Orthodontics and Dentofacial Orthopedics, April 2021. And he has been awarded Research and Industry Prize from Ministry of Food and Drug Safety, Korea. He received E.H. Engel Research Prize as well. He is currently professor and head Department of Orthodontics, Kyung Hee University School of Dentistry, Seoul, Korea. And welcome to you, sir,
Thank you.
to our country. And
Okay.
we welcome you and we are eager to learn from you, sir.
Thank you.
Over to you.
Okay. Mm. Thank you. Thank you. Okay, I will use full screen, and it's quite an honor to be here with you again. I firstly attended the IOC 2011 in Khajuraho, and this is second visit. First of all, except for the facial photo, you are welcome to take any other photos because it will be quite helpful for your daily practice. Today's topic is the new term biocreative strategy, especially for the failed orthodontic cases. Yes, I'm from the Gyeonggi University. Gyeonggi University campus is the most beautiful campus in Korea. I'm Song Kim from South Korea. However, you'd better call me as Sunny. Three main achievements I have. The firstly, even though I'm quite young, in 2015, I was selected as one of 100 authors of Asia Duo. I published and as the moderator mentioned, one of my research articles about biocreative strategy was selected as the Edward Hartley Angle Research Award Prize winner. And finally, this is today. My research article and clinical article about biocreative strategy was more than 160 articles published. Yes, this is the Sunny. This is contemporary orthodontics, and this is your textbook. I used this textbook for a long time. This is a legend. However, the stream is being moved to digital orthodontics. The Conbeam CT assisted digital orthodontics, intraoral scanning assisted digital orthodontics, and 3D printed or direct printed aligner orthodontics. The same in the TED or TSED orthodontics. I really appreciate my brothers, the Professor Jae Park and Professor Ravinanda. They gave me a chance to contribute as chapter authors both of these books. Yes, variety, majority of borderline cases can be treated with TSED or TED. Yes, this overcame the scope, the limitation of conventional orthodontics without orthodontic surgery under general anesthesia. Like this. However, when we use the mini screws in my daily practice, the new complications we are experiencing, the posterior open bite, anterior deep bite, sometimes the anterior occlusion plane canting. Another big brother was my teacher, Dr. Burston, when we took a photo together as the main speaker in the International Bali Symposium. He was passed away. However, this is his last presentation in Yonsei University. And that day, he passed away. He emphasized complex T-cell biomechanics. And what is the suggested solution from Dr. Burston? Yes, it was not the TED-assisted orthodontics, but the TED-independent orthodontics. If then, every reaction can be disappeared. Yes, he emphasized, it is the future of TED orthodontics. The biocreative orthodontics for the permanent dentition from the 1998, we already did. We used the rotational resistance of mini screws. It made us treat like this, only using one size stainless steel wire and 2 mini implants. And any kind of brackets you can use, and some elastics. Biocreative orthodontic strategy, the BOS or BOS, were developed from 1979 and mainly for the young patient treatment using innovative removable appliances. It's for the simplifying the biomechanics. It minimizes the hardware and muscle and TMJ function and occlusion harmony we want to try. In my dental hospital, in addition to Department of Orthodontics, we have Biocreative Orthodontic Center. I'm the director of this center. This is the failed teeth-set orthodontic cases. However, in this presentation, I will mainly explain and share information about vertically failed teeth-set orthodontic case. And this part I will share next time because of limited time. Let's move the failed case 1. 26 years female patient. Her facial harmony was not bad. However, she felt difficulty to chew. What happened? She already received 3 more years orthodontic treatment by other doctors. However, except for the splint, she cannot chew. What happened? She has a transverse problem, she has a teeth axis problem, and she has vertical problem. What will you do for this patient? You will remove whole brackets? You will perform orthodontic jaw surgery? Why we do reorthodontic treatment? This is the purpose of reorthodontic treatments. As an orthodontist, I'm so proud of giving a chance to patients to be improved function and aesthetics. Yes, the same as physical and rehabilitation medicine. This is the orthodontics. This is the orthodontics. Both for failed orthodontic cases, I want to introduce you the BOSS pentagon. This is the logo of Biocreative. What is this? This is management umbrella from bioprogressive technique. In the Biocreative, we use a tripod. The anterior occlusion and both the posterior occlusion should be harmonious, like the tripod. In addition to that, occlusion and muscle and TMJ should be harmonious. This makes the pentagon. And we have 10 key principles. I will show you later. For the young patient, for the diagnosis, for the treatment objective, for the treatment planning, we have 10 key principles and we use this for our daily practice. This is take action principle. In the take action principles, for the failed case correction, the tripod principle is most important. Please check this. during the normal eruption period, in the 6 years, the young guys erupt upper and lower anteriors. At the same time, the first molar erupt. Once the upper and lower anteriors, once the posterior molar, first molar occlude, then other tooth followed the way. This is the tripod principle. If the tripod condition is collapsed or damaged, malocclusion occurred. Please check this. This patient's class 2 retrognathing mandible. She was treated by my teacher, Professor Zhang, other professor, other faculty, other doctors treated this patient, and she was transferred to my teacher. What happened? They used class 2 function appliance, achieved relatively good overbite only in the anteriors. However, this patient is quite young. What happened? Occlusal collapse, tripod collapse. Because this young patient's the joint condition is growing. Therefore, this kinds of malocclusion the patient can endure. Yes, this patient showed tripod collapse. We should correct the collapsed tripod. This is a key principle. Let's check up. The upper occlusion plane is maintained, and the patient already showed severe upper anterior root resorption. Then we should not try to change the arch form because the occlusion plane is flat. Then main target is lowered. Midline correction, key relation correction in a limited time. We should do what we did for this patient. Yes, we used the same brackets, but we used the 2 mini plates. 1 month, please check up upper anteriors, no main arch wire, lower areas, only 16 by 22 stainless steel arch wire for maintaining the vertical dimension of anteriors. The segment approach here, segment approach here, segment approach here, but 1 month we applied 2 mini plate in the retromolar pad and writing the molars. 6 months, once the writing and tripod correction we achieved, we removed this mini plate and we transposed to this area for the anterior canting correction. Still, writing and distalizing in the left side. The wire 16 by 22 stainless steel wire and upper area now 16 by 22 stainless steel wire. 10 months, what happened? Once we achieved sufficient writing and tripod condition, we cut the wire. Even though the patient showed shallow overjet and overbite and a little bit crossbite in the posteriors, what happened? No problem. Once she achieved tripod, we wanted to make physiologically stable occlusion and settling. The final treatment period was 30 months. And this was published to the American Journal of Orthodontics as a case report. Initial 10 months, 12 months. Vertical control as the target approach and no more wires except for the 16 by 22 stainless steel wires. This is 12 months change. And this is a 7 years retention. Maybe it will be published to the AJDO clinical companion. Yes, even though she showed excessive root resorption in the upper anteriors, maintained, because we did not do many things for the upper whole dentitions. And once summarized and once corrected, it is well maintained. The tripod correction is the main weapons for your failed case correction. 7 years retention. Therefore, for the failed orthodontic cases, I firstly emphasize collapsed tripod correction, please. This is the checklist of BOS. Firstly, when we do diagnosis and consider the patient and parents' eagerness, and we should check up the alveolar bone boundary. The second, what is the target? The target is only tooth. Target is tooth and bone and soft tissue, such as tongue or lip muscle or things like that, or airway. And then treatment to selection. Which kind of skeletal anchorage we will choose? Or no skeletal anchorage is okay? Okay. And then target tooth bone movement we do. And then finishing and detailing as a conventional manner. But currently, the same checklist during the diagnosis, during the target decision, during the target to super movement, during the finishing and detailing, any stage we should consider which kind of treatment tool should be selected. Therefore, this is BOS 5 Essential Checklist version 2.1. As a treatment tool in the biocreative strategy for the permanent dentition correction, this kind of appliance is the main weapon. You can make it the lingual retractor. You can make it this kind of a palatal side expander, because any kind of minuscules which is 1.6 millimeter and 8 millimeter long, you can use for your patient palatal side, 3 per side, 3 per side, and you can manufacture, fabricate it easily. And this is the night-tie combined stainless steel section retractor. And for the roller mini plate, I prefer to using the C-tube plates, the plate with the tube, and the BRC technique. I will explain more about BRC technique. This is the related research articles and clinical explanation articles. Please type Sung-Hoon Kim orthodontics. Then you can find any other information about these kinds of treatments. About the PRC technique, recently, so many articles are published because this was developed at 2005. For the 17 years old, for the 17 years, we tried to clarify the actual treatment effect or limitation or shortcomings. And finally, we achieved. Now, I will move the explanation, the different explanation, the new term in TSED orthodontics. The term is Tweed Merrifield Alexander Jung, the TWIMEC. Firstly, the TWIMEC system is composed of TWIMEC analysis. It is simply best. That means we use the Tweed Merrifield triangle. We use with Alexander's the intermolar or intercanine width and Professor Jung's palatal plane as main reference plane. This was mainly for screening simply when we do check up the lateral cephalogram, or PA cephalogram. So many great analysis you use. However, in your daily practice, we have not many time. Then, if we use, instead of FH plane, if we use palatal plane as main reference plane, it's quite simple to evaluate. And orthodontist and oromaxillofacial surgeon mainly control under the palatal plane. That's the reason we prefer to make the palatal plane as main reference plane. And if we check up the palatal plane condition and if we control the palatal plane position, then we can check up and we can easily differentiate the retroending mandible or not. In the TWIMEC analysis, because next three cases was treated by TWIMEC analysis and TWIMEC system. The chin angle is quite important, quite interesting measurement because this is for the lower aesthetic condition evaluation. And we can decide the extraction or non-extraction in terms with chin angle. This means the S curvature of lower lip line. The chin angle, in cases of a large angle, this is the chin angle, the infradentale and pogonion to nasion perpendicular palatal plane, the angle, and large IMPA. We prefer to extract all first premolar or second premolar. However, in cases of large chin angle but quite normal IMPA and retronetic mandible, instead of extraction only or non-extraction treatment, we prefer to perform anterior segmental osteotomy. It improves the facial harmony like this. All the anterior segmental osteotomy in my department, we perform on the local anesthesia, not the general anesthesia. And TWIMEC PA cephalometry analysis, even though we do not know well about the measurement, however, you can check up the asymmetry or not, basal bone width and interalveolar bone width relationship or axis canting or not easily. We are also gathering information, and I really hope some AI, some digital CBCT imaging company will show you in 2023, next year, I hope. Now the second, this is about the bracket prescription. My friend, Dr. Ajit Kalia, we discussed shortly about the future of orthodontics. Wow, the bracket orthodontics will be disappear? I do not think so, because bracket is one of the great tools. The aligner is one of the great tools. This not the competitive things. This is collaborative things. We can mix it, or we can use aligner firstly. We can use bracket firstly. Therefore, I thought more about what will be the best bracket prescription in the mini screw orthodontics, in the mini plate orthodontics. That's why we developed this TWIMEC prescription 6 years ago. The Dr. Ross, I respect him a lot, and his 1987, the essay was quite great impression to me. Then a special set of overcorrection brackets is the answers for the streetwise appliances. One prescription, pitch all concepts I respect. In the Ross prescription systems, the main characteristics is that the upper and lower, especially lower posteriors, showed large crown lingual torque, and canine shows less torque or minus torque. This is good for the guidances, and this is good for the molar writing. How about the MBT prescription? The MBT prescriptions, lower anterior torque, I prepared. Because when we do apply the direct anchorage, the -6 degree of lower anterior torque and good lower premolar torque is quite good for the skeletal anchorage related treatments. And they are quite good for the sliding mechanics. How about the smile prescription? Quite not familiar with you, but this was developed by Dr. Jacrisen. Especially during the finishing and detailing stage, the upper premolar should be zero torque for the smile arc maintaining. Yes, mainly for the skeletal anchorage related orthodontics. Because the skeletal anchorage orthodontics has different biomechanics, we prefer to use the Ross, MBT, and SMILE prescription combinations. This is the TWIMEC. TWIMEC is not new. However, TWIMEC tried to emphasize the strength of each bracket prescription in the contemporary orthodontics. The upper anteriors and upper and lower molars, I prefer to using Ross prescription. Effective anterior torque control, because this is less anterior torque than MBT. And effective molar writing. How about row anteriors, row canine, and premolars? Effective torque control during vertical dimension problem correction, MBT. How about upper canines and upper premolars? Reasonable canine tip, because the Ross prescription tip is quite wide, quite large. However, the SMILE prescription is the same as the Andrews, and then great for the SMILE arc. So happily, maybe this year or next year, some companies started to distribute this kind of prescription. But any other global companies are welcome to distribute these kinds of prescription, because even though Sony developed these kinds of bracket prescription, no royalty, no royalty. Any other profit? No. I really want as many companies as possible distribute these kinds of prescription with cheap price. This is my really my hope. Okay, now the failed orthodontic cases treated by TWIMEC system. Failed case 2. This patient 60 years ago finished her treatment after 4 premolar extraction. However, immediately after the treatment, she felt difficult to chew, and gummy smile was not corrected, and protrusion still remained. What happened? Maybe you can check up. What's the problem with this patient? Space, already the space, molar, anterior, I do not know. Yeah, please check up the tripod. Her tripod has some problem. As a diagnosis, we did TWIMEC analysis, only 19 landmark simple evaluation. The palatal plane to upper incisor relatively upright. Mandibular plane is already hyperdivergent. And low acid angle means chin angle. For the class 1 or 2 female patients, about 14 to 15 degrees normal. However, she is too large. However, we cannot extract more. The patient shows extremely thin alveolus in the upper and lower, and upper anterior is already unrighted and extruded. Whole dentition. Checklist 2. What is the target? Yes, whole dentition. However, we should differentiate. What area is the first target? What area is the second target? What area is the third target? Please think. The first target. Fortunately, even though she showed collapsed tripod, however, her skeletal condition was symmetrical. But she felt quite difficult chew in the left area. Please check up the frontal view of convimsity. Right, left, the condition, medially tipped condition. At the same time, lingually tipped condition is different in the right and left side. This is the main problem. How can you solve it? The patient showed transverse index, the 연세 transverse index between the basal bone widths between the upper and lower minus 3.2. Usually when we check this, we recommend maxillary expansion is needed for your patients. However, these patients showed extremely different but severe lingually tipped lowers. Therefore, this should not be solved by upper expansion. Different mechanics we should choose. Yes, the target decision, let's summarize. The first target is upper posterior because it should be distalizing with intrusion. Because this patient showed hyperdivergent pattern. And then the second target for the upper dentition, anteriors. Anteriors should be intrusive retraction. And root should be more moved like this. And how about the lower dentition? Yes, lower whole dentition. Different writing should be done. And auto rotation we want to do. Therefore, for the upper treatment tool, we decided to apply the palatal plate skeletal anchorage. If you have any other alternatives, you can try. You can apply the palatal side meniscus for these patients. However, in these cases, so many pneumatized area condition, therefore we decided to apply modified palatal plate anchorage and then distalizing actively. Angle Orthodontist 2018 research article compared buccally retraction and palatally retraction. Buccal meniscus showed average 2.0 millimeter with 7.2 degree tipping. However, this kind of palatal plate assisted distalizing showed 4.2 millimeter distalizing with only 2 degree tipping. That's why I choose this as a treatment tool for the whole dentition distalizing with intrusion. And then what we should do for upper anterior dentition at the same time. We wanted to use the rotational resistance of skeletal anchorage. However, the patient showed us the thin alveolus or thin sinus wall. As an alternative to this approach, you can apply infrazygomatic screws you have. However, I prefer to use this. Small pieces of mini plate easily bended and only 1.5 millimeter diameter and 4 millimeter long screw means about 2 millimeter penetration to the bone. The root can be bypassed. You can check up 2009 AJ Audio article published by Sunny. Sorry. Type 1, Sung-Hoon Kim, no type Sunny. Type 1 and type 2 token control is our approach. For these patients, we applied modified 3-piece intrusion technique by Dr. Burston. This article was published by Egyptian orthodontists in 2019. This was the type 2 torque control of anteriors. We compared the long rebum lingual approach, and finally we found these kinds of intrusion and retraction with ovary arch wire showed more bodily retraction with more effective intrusion. Yes, we applied 19 by 25 stainless steel wire with accentuated curve of speed, and we applied the wire to the whole of skeleton anchorage. And then anteriors, we ligated and retract. What happened? After 9 months, at the same time, the distalizing happened, and at the same time, we applied additional wires. 9 months, the tooth moved like this pattern. And the third target, what will you do? Different writing should be needed. Professor Alexander, he is also the clinical adjunct professor of my department. He taught us in his 20th discipline in the Alexander textbook, principle number 5, goals for stability, molar writing. Molar writing is quite important. For the molar writing, Tweed Merrifield, Robert Turkett, and Charles Burston did like this. How about this? I am sure if this doctor were to learn from Dr. Ojima, then he did not treat like this manner. After poor premolar extraction, for several years, the space closure and the patient were back to Korea, and we checked. Therefore, instead of applying the conventional treatment mechanics, we applied the vertical dimension control method only by 4 mini implants and 1 brass wire connector and wire and weighting. And then once the molars unrighted differently and we protracted the whole molars axis. And Professor Young Kim is the developer of Meow. We modified this Meow technique. without necessity of intermaxillary elastics. This is modified meow. The name is Biocreative Reverse Curve System, BRC. Let's check up. For the BRC, we prefer to using 17 by 25 reverse curve of spin night tie with toe-in band and one mini plate with tube, the C tube, one brass wire connector, and only posterior brackets. Any kinds of bracket you can use. However, I recommend you to use Ross type bracket. And then we apply. Sometimes, if we wanna right and distalizing, then no cinch. However, if we wanna root thrusting only, then please cinch. And for preventing from flaring or preventing from extrusion of the premolar, we recommend you to use bonded lingual arch. This is the BRC. Once we apply the BRC and waiting, different writing, we achieved. Because every reaction from the right side, the left side, every tooth can be disappeared, can be observed by skeletal anchorage. Let's check up the biomechanics. This is conventional BRC. Once the initial system, writing and reaction, other force. However, every reaction is observed by the C tube. And finally, writing and intrusion. And then, now, writing occurred. Okay, scientific evidence is right there. 2021 Korean Journal of Orthodontics cephalometric research articles showed us second molar, writing and intrusion. First molar, writing and a slight extrusion. This means occlusal plane change. Therefore, to these patients, we applied BRC technique. And then we waited 1 month, 5 months, 16 months. In the 16 months, once we unrighted, we applied open coil spring. And 24 months, finishing and detailing. What happened? Yeah. Gradually unwriting, without intermaxillary elastics. However, firstly, you already knew differently lingual tipping. They showed what happened. From the 24.2 to 20 degree, facial harmony improved. What happened? Upper incisor root thrusting occurred. Intrusive distalizing achieved. How about mandibular plane angle? Auto rotation we achieved. This is the treatments between pre-treatment and post-treatment unwriting. However, you do not know how much the lingually tipped molars solved. This is 25 months treatment period, and we achieved like this. Please check up the patients. Firstly, quite difficult to chew. And in my department and my center, we prefer to using biometrical evaluation for the patient like this. Became the improved the chewing, and this is between the pre-treatment and post-treatment change. Let's check up the axis. Gradually better. Please check up the Y transverse index. Even though we did not expand the maxillar, Y transverse index in the normal range. And the most important thing, how's the axis? Upper, similar. How the axis lower? 108.6 to 102.5. How about left side? 125.9 to 105.5. This is the BRC. We do not do anything about the precise control because already we programmed, we applied. Please wait. Try not to change many things. Please wait. The body responds. We solved this patient problem much better. Retention 1 year, 3-year retention is quite well maintained. Because I did not prepare the patient photo because she is really like my condition. Last 3 years, she ate so much because she felt quite comfortable to chew food. Therefore, I think she does not want her face, show her face to you. Yeah. Okay, I will be hurry up because about BRC, the lower I-type C tube is main weapons. It is risky or not. We evaluated from 194 mini plate anchoring screws in these areas. And we check up the root proximity or root penetration. There's no root penetration, only under the 20% of root proximity, however, no root contact, no root penetration. We finally found. Please check up placement method. In this low anterior symphysis, you do not worry about nerve and blood vessels. Once local anesthesia, vertical incision, 5 mm to 7 mm by yourself, and then when we do apply the 1.5 mm and 4 mm long screws, at the same time, we do place with plate positioned by screws. And then first screw we placed and check up the position. Second screw placed and suture. That's all. It's good. Okay, this is the final cases. So many failed orthodontic cases are referred to my center. However, these patients will be quite meaningful for your treatments because this patient already performed 3 orthodontic jaw surgery, both the jaw surgery, resurgery, because of malfracture during the healing period, difficult to chew. When she was transferred to my center, she felt quite painful to chew. And please check up. Class 2 anterior open bite. The upper incisor axis is not bad. Palatal plane angle, hyperdivergent. Because of her surgery history, I will not mention about chin angle. 20 degree, however, the change is not meaningful. Please check up. Some tooth was damaged by screws. Previously, the patient showed a little bit asymmetry. And to jaw surgery, during the healing period, they found the ramus area was fractured, green stick fractured. Therefore, they performed the surgery 2 more times. However, inflammation, infection, so many kinds of fibrotic change, so many kinds of post-discharge. And then patient visited my university. Please check up this area. No fixation, only fibrotic change. This area and this area. What we do for these patients. Let's consider the target decision and treatment to selection. what we can do for this patient? Additional orthodontic jaw surgery? I do not think so. These patients, if we do check up the transverse relationship, and if we find, oh, vertical problem is main problem, then we can solve it. And the first target was this, non-picked ramus area. Therefore, she needs biocreative strategy with TMX system. Structural collapse, functional collapse should be solved. Fortunately, she did not show transverse discrepancy. Therefore, my oromaxillofacial surgeon, the chairman, performed plate removal surgery, screw removal surgery, and refixation surgery. After removal, the fibrous tissue or inflammation tissue, the totally. And now, the target decision for the orthodontic treatments. What we should do? Yes, distalizing with the intrusion. The same to the second case. Upper anteriors, no intrusion, only retraction or a little bit tipping, we will accept. Because the bone condition is quite terrible. And thirdly, lower totally tooth condition should be improved by unwriting, and especially for the intrusion. No more occlusal adjustment. The previous doctors occlusal adjustment a lot. Therefore, target decision we did. Auto rotation we want to do, or treatment retraction. However, this is only the ideal concept. The actual concept, let's check up. What is the target? Yes, upper and upper both the posteriors should be distalizing, but we should check up the actual condition. This is the left area. Even though she received so many surgery, however, alveolar bone were distal to the second molar, there is a bone. But how's the right side? fibrotic change in the most of the area. But we explained the condition. We will try to do our best to distalizing. And we trust the body, the nature, the cell. Therefore, treatment to selection, because the patient feels difficult to open her mouth. Therefore, small pieces of cross-type mini plate, C plate, we applied. And the palatal bolt was low. We applied this. And distalizing continuously. This is the total distalizing process. Distalizing at the same time upper anterior retraction. No more posterior, upper posterior skeletal anchorage. Because so many times of orthodontic surgery, the patient's gum condition, vestibular gum condition is like the wallet, so difficult to apply. The skeletal anchorage were inside. Therefore, we had no choice except for applying mid-palatal suture. Apply. Please check up. During the heavy pulse application for the distalizing, and we used this first molar as anchorage. And lower, please check up BRC, and additional. We applied meow directly and lifting. 90 months treatment change, 90 months without any other intermaxillary elastics because the joint condition was terrible. Please check up. Yeah, we decided on writing the molars differently. The patient posterior condition is like this, still inflammation. However, orthodontic treatment should be done. Yes, we applied BRC, but different BRC. This patient should be unrighted, the molars, second molar and first molar, totally unrighted and intruded. Therefore, we evaluated recently three-dimensional effect of BRC. I will use 4.4 minutes totally. Unwriting, we found second molar showed intrusion during the unwriting. Rest of the tooth showed a little bit extrusion. Therefore, in this patient, different BRC technique. In the normal divergent or hypodivergent patient, you can only lift the reverse curve. However, in the hyperdivergent patient, you can apply stop and you can twist it and you can apply the resin, flowable resin. That's all. Once you do the twisted technique, every tooth unrighted and intrusion force. We applied twisted technique. 19 months intrusive distalizing and unwriting with intrusion. This is first molar. Second molar showed more intrusion. And finishing and detailing, at this time, light intermaxillary elastic we did. Please check up. Unwriting successfully finished. And treatment was finished well. Auto rotation and axis was changed about 9 degrees. Yes, C-plate and BRC combined biocreative strategy with the TWIMAX system made it possible. Because during the unwriting, in the TWIMAX system, I prefer to using RAS prescription because MBT prescription has less lingual talk. 25 months. 25 months. Much better. It will be improved because I trust the human beings. Yes, these patients finally fixated. This make happens. What happens? Oh, Sonny's treatment, even though Sonny is 100 authors or things like that, the finishing is quite terrible. What happens? We did our best. In the left side, totally bodily distalizing like this. In the right side, intrusion successfully, however, distalizing like this. This is my limitation. This is the orthodontic treatment limitation. However, this cannot be achieved by orthodontic jaw surgery. 1 year retention. Okay, conclusion. Re-orthodontic treatment or reverse treatment, we should consider about the human beings, about the cell, about the tooth movement or the bone biology. And I want to inform you, I want to emphasize, this is not the orthodontic treatment only, biocreative, physical, and rehabilitation orthodontics. Innovative treatment philosophy make it possible to come over the failed orthodontic cases, especially by less hardware or target approach and take action. Frankly speaking, I do not prefer to using these kinds of hybrid type expander because first molar is not the anchorage tooth, it's the tooth which should be moved. Therefore, I prefer to using this kinds of custom-made expander. You can make in your clinic. And in my university nowadays, in the extremely narrow maxillary cases, we do use this kind of expander, true bone expander. This expander related clinical research is performed by my university and Stanford University and St. Louis University is now. I'm sure next year you can get the actual so fresh information from Sony. And 5 essential checklist is quite important for solving the failed orthodontic cases. Innovative treatment prescription and innovative skeleton anchorage make it possible. Yes, orthodontic failure cases, you can finish, you can successfully treat if you do consider tripod correction, if you do consider target approach, if you do consider not the tool-oriented treatment, but the patient-oriented treatment, you can solve every patient. Thank you.
Thank you for the fabulous presentation.
Thank you.
The presentation from the heart and the head, the balance of the compassionate heart, and a wonderful mechanics thought through. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you.
I request Bhumavashi ma'am to felicitate Dr. Kim. Thank you. Thank you, Bhuma ma'am. I will request Dr. Mala ma'am to felicitate our chairperson for today, Dr. Bhuma ma'am. So we are starting with the next session for today, and the chairperson for this session is Dr. Rajaganesh Gautam, who is the vice chairman of Indian Board of Orthodontics and in private practice in Pune, and Dr. Ravindra Manarikar sir, who is a principal, Rural Dental College, Loni, Pravra Institute of Medical Sciences, Pravra. I'll request the chairperson to start the session.
Good afternoon. The first speaker for this session is Dr. Sarojini Joseph. Dr. Sarojini Joseph completed her graduate and postgraduate studies from the Madras Dental College in the year 1980 and 1984 respectively. She has about 22 years of teaching experience with the Rajiv Gandhi University of Health Sciences, managing cleft care and education of cleft children from 1990 under the New Face Charitable Trust that supports the treatment for facial deformities, facial trauma, facial burns, and education of these patients where necessary. She is interested in understanding the basics in orthodontics and the teaching of the same to develop a better outcome of treatment for the patient. Dr. Sarojini Joseph.
The outset, thank the organizers of this conference for this invitation. I'm actually humbled because I really don't know whether I deserve this at all. But, and there have been giant speakers before me, but I will try to do my best. The topic that I'm going to talk, that I've tried to understand and study, is the biomechanics of general orthodontics and apply it to the numerous cleft lip and palate patients and other patients who come to us for facial rehabilitation. I come from the St. John's National Academy of Health Sciences. It's a tertiary hospital, and from the trust, we are able to give that same treatment to those who can afford and can't afford. The content of this lecture, first, there will be a preamble, and then we will talk about the biomechanical principles in non-surgical management of secondary deformities with case studies. In the preamble, I would like to tell you what is a primary deformity in cleft lip and palate, what is a secondary deformity in cleft lip and palate, and what is a guideline to decide non-surgical over surgical treatment in secondary deformity correction. What is a primary deformity? The deformity the child is born with is a primary deformity before any surgical correction. These are some of the casts after lip, during nasoalveolar molding and before palate correction. These are the immediate post-surgical results. You can see there's a lot of scar tissue involved, but somehow with care of the scar in our center, we get a fairly good facial appearance, but we have a palate that is constricted, needing differential expansion. This is a unilateral cleft lip with the 8 and 12-year follow-up of a secondary deformity for you to understand. You can see that the arch is constricted. This is a 12-year follow-up after the alveolar bone graft surgery. Still the arch is constricted. Why do we get secondary deformities? The scarring from the first surgery determines the detrimental effect on the dentofacial region. The midfacial growth potential may be weakened, and this contributes to midfacial deformity. What is secondary deformity correction? What have you and I got to do with this? Because we get, after primary closure of the cleft lip and palate, maxillary hypoplasia, nasal deformities, and upper lip distortions. You get transverse cross bites, mid-face retrusion, and a range of dental irregularities. And the outcome, what affects the patient? Speech, mastication, and aesthetics. Often the general orthodontists do find patients who seek treatment for secondary deformity in their practice. Cleft care providers like Smile Train, etc., now do require orthodontists to be capable of undertaking the care of these patients. Hence, it is an added skill for our young generation today, not when we first started off, today, to be able to manage these patients. So let us see some examples of secondary deformity, cases needing surgical intervention and cases needing non-surgical intervention. For this, we studied a visual tool for skeletal-based diagnosis. We want to give maximum information to the patient on day one when they come to the clinic. We don't want to say, go and take a CEF, go and take a scan. We want to spend enough time with them and tell them, give them the maximum information about what problem that they have. So we use this Gonzalez-Ulloa analysis, which is a quantitative principle in cosmetic surgery of the face. We took the same principle and applied it for our use. So the artists were the first to study the dimensions of the face because they had to draw it, obviously. Then plastic surgeons like Farkas, Gonzalez-Ulloa, maxillofacial surgeons like Bell, they also did a lot of study on facial measurements and made norms. And there were anthropologists who also studied the changes in the facial axis. That is when from beast to man, you can see the profile getting more straight. And as Dr. Jayant also told us, as the jaws also receded, they were also getting a lot of airway problems. So what is this Gonzalo-Ulloa plane? It is just two imaginary lines. It is the Frankfurt horizontal and a perpendicular to the Frankfurt horizontal from the nasion. It's really simple. And from here we can get some idea of the skull, the angle of the facial plane, the size of each segment, and protraction or retraction of each constituent segment of the face. So the subnasal lies over this line or within 0 to 0.5. The upper and lower lip usually touch this line, and the pogonion also sits on this line. Here are the various permutation and combinations that you can, diagnose. And again, I'm trying to emphasize that it is a quantitative principle for the study of the human profile. So integration of the profile must be corrected when the face has reached its full development only. This is a tip that the author gives in this article. So we also had some long-term studies. So this was a child that we monitored from birth. At 16 years, we were wondering, should we do surgery or can we camouflage? But look at her at 18 years. She became a definite surgery case, right? And this is what happened to her after we finished the maxillary advancement. So we have to be very sure of what we are doing and do it. This is a case which needed a bijaw surgery. Again, if you apply this Gonzalez-Ulloa plane, we can know that there is mid-face retrusion and mandibular protrusion. This is a pre-surgical assessment, and this is what we got after surgery. I work for 4 plastic surgeons. This was from a different center, and they did not address the asymmetry, but still the aesthetics improvement was there. This is for a maxillary advancement. You can see where the upper lip lies, and you can see that this is the occlusion, and you can see this is the improvement after maxillary advancement. So we also do a lot of work with the clefts of the palate, Pierre-Robin syndrome. So this is a Pierre-Robin syndrome. We get a lot of deep bite in Pierre-Robin syndrome. Not so much of mid-face retrusion because of a maxillomandibular differential. And this is what happens even post-orthodontics. Though we get a good occlusion, the chin is deficient, even though there's a maxillary retrognathism at birth, but it sort of catches up and we get a deficient chin. This is the occlusion that we could finish. And these are our own long-term non-surgical cases whom we have followed up from birth. And we can see that, the face is in balance and there is no need for any surgery. This is the occlusion. This is the frontal. So, an understanding of facial proportions and aesthetics is essential in order to achieve satisfactory results. This is the most important aspect of planning, more than cephalometry and trying to achieve a class 1 occlusion. Now let us go to the actual lecture. The biomechanical principles with case studies for problems recurring in non-surgical secondary deformity cases with the clinical solutions. So these are the biomechanical concepts to be covered: maxillary expansion, one appliance with 30 years experience, palatal root movement of maxillary incisors to camouflage borderline class 3 incisor relationship using Burstone's root talking auxiliary, and the deep bite presenting in cleft cases. Here I like to thank Dr. Nandini, who is in the audience today, and also a dear friend of mine. She brought an awesome person to the conference in Goa, Kuangul Choi, and he told us there that he had written this textbook with Dr. Burstone. So we immediately bought the textbook, and in that textbook, he very clearly says, like what pharmaceutical agents is to allopathy, force is to orthodontics. And then I started re-looking at everything, how I did it. And I started measuring the force. And I said, if we can determine what gives us success, why are we going back and forth on anything? You know, we can predict. And I made a conscious attempt to try to study this force system and try to study this book. So I'll just like to say a few words about the incisors in bilateral and unilateral cleft lip and palate. In unilateral cleft lip and palate, the incisor next to the cleft area somehow survives, and there is literature to say. But in the bilateral, the premaxillary segment is very malformed, the incisors are malformed, and usually we are not able to salvage these incisors, and we need some prosthetic rehabilitation. So it is good to have a good prosthodontist in your team. So let's talk about maxillary expansion. I have used the quad helix. It's a one expansion appliance for 30 years. Why? Why am I using the quad helix? There is no palatal bone in the cleft palate. So there, you don't need any heavy force generating appliances. The differential expansion is possible with quad helix. Molar widths are usually closer to normal, and usually expansion in the premolar and canine is indicated. Here is a stereolithographic model. You can see that there is no there is no palatal bone, so there's no resistance to expansion. You can, treat it like dentoalveolar expansion. And the only reason where we use, fixed heavy generating force expansion screw is when we want to do maxillary advancement and we need a good splinting of the maxilla. Activation of quad helix. This is the pliers that we use. We activate first the bridge, then the horizontal arms, and then we check it on a graph sheet. Shakona's article tells us about 8 millimeters of activation gives 420 grams of force. It's very important for us to get the arms parallel to the original position after activation. This is how we activate it. We don't do any activation intraoral, all extraoral activation only. And we only do 2 activations. The first we activate it, put it in the mouth. After 8 weeks, we take it out. If the activation is not enough, then we activate it and then we just keep it in the mouth and 6 weeks and continue with the rest of the orthodontic treatment. We've also modified the quad helix for crossbite and for proclination. These are the results that we have got. There is the correction of the anterior crossbite and the posterior crossbite on the left side. And sometimes, this is very important, especially for postgraduate students, that when at the time that we are going to do the maxillary advancement, we find that we have overexpanded, because we can't make this out because the maxilla is retruded. We can't make this out in the mouth. So then what is the solution? I used to use transpalatal elastics, but recently I was showing Dr. Sadav Shetty, this is how I do, this correction. He was very kind and he said, Sarojini, the tongue may not be very comfortable, right? So just leave it alone for one appointment or two, or do a toe in bend distal to the canine and you will get it. So I would like to share it with you. So this is a case study of a young adult with secondary deformities who came for improvement of his smile. His father had been to a senior orthodontist and said that only a prosthetic correction is possible, only obturator will be possible. That's what they said. But I begged him and I said, please give me one chance. And then these are the casts, because I did this sometime in late, like 98, 97, when I started learning the PA appliance with Dr. Shetty. So I gave him a quad helix and I got some expansion. And then after that, you can see this is the expansion potential of the quad helix. The force is a pushing force and you get some buckle tipping of the teeth because the force is palatal to the center of resistance of the teeth. So then after the expansion, the plastic surgeon put a epithelial flap, buccal mucosa epithelial flap, corrected the deformity. And then we went in for a denture because we didn't want any fixed processes because the flap had to be cleaned. So that is why we went in for a denture, which acted like a retainer also. And this is what we got for him. And then the icing of the cake is when he had got the Cupid's bow reconstructed and also had a hair transplant. And he's married, happily married now. The 18-year-old female patient referred for treatment. Also, her mid-face looked okay. If you notice, all these patients have a good maxilla. So it's a cleft on a good maxilla, if you notice, right? And then we did the expansion, and we held the expansion with the quad helix because during the crown cutting, we will get a lot of relapse. So we overexpanded and kept it like that. And then, she was not sure what was happening. She's not very happy. But then we gave her the bridge, and then she was happy. And what did you do? You gave a little support to the, ala bases, and you gave some lip fullness. That's all we did. So this is her pre and post treatment appearance. We also got her to study her BCom and computers, and she's now employed in Tamil Nadu government service. Her parents were estate workers in the Nilgiris. This is Burstone's root talking auxiliary. It is a camouflage treatment for a class 3 patient with a class 3 incisor relationship probably with an established anterior functional shift. So we went in for extractions, premolars in 3 quadrants because on the left quadrant, the lateral incisor was missing. And we used Burstone root talking auxiliary to correct incisor position and anterior crossbite after alignment. So this is the patient, extraoral views. This is the intraoral view. This is the OPG. This is the CEF. These are some of the numbers. And you can see there's a little inter-incisal angle is increased because of lower incisor proclination. And that is the one reason why we can treat this with mechanics. And there was attrition on the 2-2. So probably that was where the initial contact point was. And there's also a skewered, on the left lower segment, the arch is slightly skewered. Probably it could have been an established functional shift. And then when it came to this stage, we used a Burstone's root talking auxiliary. And then we found that we got a better incisor inclination and we are correcting. So what is the theoretical basis for the Burstone's root talking auxiliary? If you want to move only the root posteriorly, you have to get a center of rotation at the incisal edge, and you have to pass a force superior to the CR of the tooth. It is not anatomically possible to do this. So we have to find a force system to replace the force system at the force system at the bracket to replace the force system at the root. So what is Newtonian's concept of equivalence? When a force and moment are added, the center of rotation is controlled, and bodily movements and root movements can be facilitated. So in 1980, Burstone used holographic studies, and he established the ratio between magnitude of couple, the moment of the force, and the moment of the couple. And he applied it and told us about the different centers of rotation. So over here, you can see this is the center of the rotation. This is where you have to apply the force. And this is the moment to force ratio you have to achieve to get this root movement. So Charles Burstone, he used anterior segment, which is a 0 to 1 inch into 0 to 1 inch in his article of AJO PO 1966. And he used an incisor root spring. Again, it was a stainless steel wire, 0 to 1 inch into 0 to 8. And he worked at that time on an edgewise appliance. So this is how the root spring works. So what did Newton says? When you add the force and moment, I'm repeating it for the sake of the postgraduate students, the center of rotation is controlled. And according to Newton's laws of equivalence, you can calculate the force system precisely. There's no guessing. You can calculate it, you can write it down, and you can be a winner. It's so simple. So what is moment of a couple? Again, for postgraduate students, the rotational effect felt at a bracket by the arch wire with no displacement. A force system creating a rotational effect will determine the root control. So let us see, let us understand how this happens. So Burstone used 2000 grams per millimeter force for 2 incisors, 3000 for 4 incisors, and he used about 75 to 150 grams of force to deflect the ends of the torquing spring to the level of the stabilizing posterior segment was his guideline. Let us see what we used. We used a root spring now. We are in better days. We used 1725 TMA wire, anchorage wire of 1925. The palatal reinforcement, there was already a quad helix. And the force we used was 37.5 grams per side. So 75 grams totally. Considering the biology of the bone of a cleft maxilla, we have to be very careful. And we used an MBT slot of 022 into 028. So this is a design of the root spring. The guideline for activation will depend on the amount of force needed to generate the required moment in the bracket. So we need a long moment arm to get the 12 to 1 ratio. And what is a moment? A tendency of a body to rotate around an axis or point perpendicular to any given plane. So these are some of the situations where we use moments in orthodontics. And we must know that force that act on a point and forces that act on multiple points are called concurrent forces and non-concurrent forces. So the class 1 elastic is a concurrent force. Burstone's root torquing auxiliary can be a non-concurrent force. So let us, I've kind of broken this diagram again because this angle, and when you latch it at this distance, it gives this amount of force bilaterally. And the calculation is like this. The moment of a couple is the force into this distance, and the moment of a force is the force that is felt, this force that is felt at the bracket, but the distance is very negligible, so we don't have any calculation for that. So, and that way we get a 12:1 ratio, and we achieve this kind of moment. So this is again a repetition. So see, this is for the postgraduate students. See how the wire rotates in the bracket. That's very important. And it is the torsional characteristics of the wire in the bracket that allows us to do that. And this is governed by Hooke's law. So this is what happens. The whole ensemble is in place. And this is a movement that we get. Right? We also get an extrusive movement here. That is why we have to make this posterior arch wire in this design so that we don't get any extrusive force. So again, a repetition. You can see just observe the inclination of the incisor here and in the next slide, right? As soon as we finish getting the proper overjet, we removed all the upper brackets and rebonded everything so that we get a good finish to this case. And this is how we finished before, and this is just the decision before debonding. And then you can see the cephalometric, you can see the cephalogram, and you can see that there's a good, nice incisor and facial plane relationship. We have improved the interincisal angle. And this is the post-orthodontic OPG. And I just wanted to tell you that we did ask the plastic surgeon whether they can put a bone graft here and upright this canine, but he had some polyps in the sinus and a little bit of infection. So the plastic surgeon said it was better to leave it like that. And this is his post-orthodontic result. We did not do anything to the incisor because he's having his lip revision. After the lip is revised, we will look at the final aesthetic build-up for the patient. And the retainer is a big retainer. Let's go to the deep bite correction. We are going to show you some Pierre-Robin sequence case. The Pierre-Robin sequence has micronathia, glossoptosis, and airway obstruction, and frequently cleft of the palate. So here was a patient who had cleft of the palate, and you can see the maxillary mandibular differential, which gives you deep bite. Deep bite is only a symptom. Cleft repair constricts the maxilla. The crowding that can be expected is more severe than mild or moderate, and the maxillomandibular discrepancy results in deep bite. So this is the pre-treatment photo. And in deep bite correction, we have to remember two basic principles. You can correct deep bite with true intrusion, or you can correct deep bite with pseudo intrusion. In true intrusion, the CR moves, intrudes the tooth, and the CR moves apically. In pseudo intrusion, the tooth rotates around the CR. How does that happen? What is the explanation for that? Before I go to that, we must never try to use a continuous wire for this deep bite correction, because though we get a little aligning, we don't get the expected change in the occlusal plane. The deep bite continues to remain. So let us see bite opening with one couple system. The key to success involves good force control, force magnitude, force constancy, a point contact, point of force application, and force direction. In addition, one should take advantage of segmental leveling and understand special anchorage consideration. These are the forces that are recommended for central incisors, all four incisors, and canine and incisors. I want to give a little time to this slide because it is very important, because our number of activations depend on this slide. So we have something called force constancy. So for two incisors here, we use 40 grams, and we used activation distance of 5 mm, and you get a force constancy of 8 gram per millimeter. What does this 8 gram per millimeter mean? It means that for every 1 millimeter intrusion, we are going to lose 8 grams of force. So then in the first month, from 40 grams, it becomes 32 grams. And in the second month, from 32 grams, it reduces further. So we don't need to be activating every month. We can activate once in 2 months. And the advantage here is when you use these light forces, you will not get apical resorption. So it is always good to have good anchorage, support. And the point of force application here is anterior to the center of resistance. That's why we get a counterclockwise moment and we get a labial proclination. So this is what we did for the patient. We used braided wire in the 1112 slot and a TMA wire. And this is the appliance. If I was to do this case again, I would probably also put in an implant, midline implant, and get a little, not only pseudo intrusion, get a little bit of true intrusion as well. this is how we finished the case. And this is another 16-year-old operated unilateral cleft lip and palate who was treated with orthodontics, came to us because she was unhappy with her smile. We used the same mechanics and we were able to give this finish. Dr. Burstone is our God. He gave us everything. I pray to him every day. But I was happy as a postgraduate student. This is me. This is Dr. Burstone. He visited our department in 1982. This is my professor, Dr. Rangachari. Every day I pray to him and for him also because he taught us how to read. Because every day I read a lot because all I saw him doing in the department was reading and studying and telling us what to read and how to read. So I think that is a big gift to read. And these are the interactions with Dr. Burstone. This is my mentor, Dr. Solomon. He was a prosthodontist and he was a friend till the end, and he was a prosthodontist. And when he asked me what department, what specialty would you like to take? I said, I like to take prosthodontist because I like you so much. He said, no, Sarojini, don't work with old people. Please work with young children. Please. I'm really grateful to him. And I was trained in Beg. I'm a mother of 2 children. I had a husband who was in OT all the time, and I did not know any orthodontics after I had 2 children. So I went to Dr. Sadashiv Shetty, and I studied for more than 10 to 12 years. And in 1980, he was a final year MDS student. I was a final year BDS student. My classmates went to him, learned how to bend Adam's clasp, and came and taught it to us. He cleared all our doubts even then. So he is my role model in orthodontics. And I also want to thank Vijay Joseph, who's the lead surgeon, and whose excellent surgical repair that you have seen. It sort of determines team quality. You know, and he's very patient. He puts up with me. I'm also happen to be married to him. So, and very good patient care. And he has an ability to smile no matter what. And recently he's become a very good chef. So I'm also very happy. I would like to thank Dr. Kabir Mulchandani, Mr. Kabir Mulchandani, who is our chief donor to our trust. He really believes in us. I mean, he just donates so generously. And we are able to do all this work only because of him. This is one of my students who was so dear to me, and he also, from the last 22 years, he's been coming every month and working with me in the cleft clinic, you know, and earlier without any remuneration. And I have to thank my team. We were having some sushi and some California roll after one of the presentations I did. I hope they will study well and they will go and have sushi with Dr. Sugubara and Dr. Unje one day. And they will do well, and I thank them because I am very, I'm not so good with technology, and they helped me to put this presentation together, and I'm really thankful to them. And as I say thank you to you, I want to say this is a Danish proverb, again from the book of Dr. Charles Burstone and Kuangal Choi, the clinical basis of orthodontics, biomechanics of orthodontics. There are no shortcuts. and every shortcut is a long road. So if we study and if we learn how to do things right, I'm sure we can be winners. Thank you.
Thank you, Dr. Sarojini. It was a wonderful presentation. I mean, we could see a compassion and commitment to the cleft patients. Dr. Raj Ganesh has been telling me that you do a lot of charity work, so please give her a big hand. Actually, cleft patients need this. Unless you are committed, you can't really treat cleft patients so well. And some of the tips that she has given, I must tell our PG students that they are most applicable to all cases, not just cleft cases. So you have to understand. And when she said that you could use a TAD, probably what she has achieved without TAD is what is important. That is very important. And we must understand these simple mechanics as we can read, have a lot of complications by using excessive forces. So minimal forces and these steps. Thank you, ma'am. We have a little time if anybody in the audience has any questions. If there are no questions, we would request.
Thank you, ma'am. I request the chairperson to felicitate Sarojini Yusuf, ma'am. Uh, we are getting over this session, and I request, thank you, Dr. Raj Ganesh and Manarika sir. I request Dr. Silju Matthew sir he's in the audience to felicitate the chairpersons. Thank you. Thank you, sir. We are starting with the next session, and the chairperson for the next session is Dr. Anand Ambekar and Dr. Virendra Vadher. Okay. Dr. Anand Ambekar presently is working as a consultant orthodontist in at Yogeshwari Orthodontic Clinic, as well as working as a professor and a PG guide at MIDSR Dental College, Latur, Maharashtra. Welcome, sir. I think Dr. Virendra Vadher is not present here. I request Dr. Anand, sir, to start the session. Okay. Sir, 1 minute. Sir is making some arrangements.
A very happy afternoon to one and all. The first speaker for this session is Dr. Maitreeshwar Vyas, sir. He did his BDS and MDS from Government Dental College, Nagpur in 1992 and 1996, respectively. He is a former professor and head of the department at various dental colleges, and he has guided more than 20 PD students. He has been into the private practice in Nagpur since 1996. Welcome, sir. Over to you, sir.
Tips and tricks of clinical photography. This presentation or this lecture or this discussion, whatever you say, comes to you with special reference to the extraoral photographs, intraoral photographs, photographs of radiographs, and a tabletop photograph. They will be discussed with special emphasis on creativity, quality, and framing. 20 tips will be delivered. Many of you might be aware of some of them, but I guarantee that each one of you will have at least one tip which is new, and you will have a take-home message. Pay attention. Tip number 1. Whenever you are taking a profile photograph, a facial photograph of a patient, there is always a need to take or to draw an outline of the patient, the profile outline. Maybe you are superimposing it on a cephalogram, or maybe just you are using a photographic analysis. Whenever you are taking that, take one photograph with a flash, immediately afterward, disable the flash, and with the same setting, take another photograph, and you have this result. One with flash, one without flash, immediately afterward, and you have a fill out outline photograph of a profile. So if this tip number 1 interests you, then pay attention to 19 more. But before that, I need to thank the organizers and the scientific committee of this 56th Indian Orthodontic Conference for giving me this platform. Thank you very much. And my special thanks goes to one of the key members of this organization, my friend, Dr. Sonali Deshmukh. I think because of her, I'm here. I also want to thank and tell you that my journey as a clinical photographer or as a photographer, because now those people who know me, they know that I have taken photography as a parallel profession. Not only orthodontics, I am doing photography also, because before you could realize, I realized that Invisalign might disturb my orthodontics. So I shifted the gear and did something for my earning. So anyway, if those who are youngsters, for them, I want to tell that nearly 50 to 60% of my income, total income, comes from photography. That doesn't mean that I am earning more from photography, but maybe I am earning less in orthodontics, whatever. I also want to thank that. I also want to tell you that my transformation from orthodontics to photography was not basically because of my passion, but it was a compulsion of maintaining the clinical records. I studied, I practiced, I faltered, and I developed the art of photography while I was indulged in my practice of orthodontics. Learning photography was a great experience, and in many ways, it not only made me disciplined in my clinical approach, but also honed up my skill as a clinician. So it was a great journey. And I remember that in 1996, when I passed my MDS, in 1997, January, there was a workshop on pre-adjusted age-wise appliance by Dr. M.K. Prakash. And one sentence, I did not remember what he taught me in that, but I remember one sentence that if you want to stand here, then you must have a clinical photographic records. That struck me. I purchased my first manual film camera. And then I started my journey. Digitization came in 2000. I shifted to digital camera and digital lenses. That time, I'm grateful. And yesterday, I was fortunate to attend his lecture, and I took this particular photograph of Dr. Ashok Karad. He told me that if you want to take your photography, clinical photography to any level, you must go for a micro lens. And then he came to Varda for some lecture, and that time I interacted with him, and he was very kind enough to share his knowledge about photography with me. And he told me that if you want to take this to a grand level, a world level, then you must have to have a proper equipment. I asked him about 105 millimeter Nikkor micro lens, and he said, yes, you must purchase it. I said, it is, sir, it is 25,000. That time it was too much for me. He said that this 25,000 you invest today, it will give you 100,000 times more than that. And he was right. Still today in my practice, I'm using that lens. And maybe it was my lifetime investment. I have conducted many courses, lectured, won many photographic award. Yesterday only I won a local photographic award in Amravati. My friends, Dr. Hantodkar and Dr. Ranjit Kamble knows about it. Unfortunately, I could not incorporate that photograph here. Maybe if the time permits, 23 minutes are there. Okay, so if the time permits, I will show you some of my wildlife photographs if you are interested. So I wish to thank this gentleman, Dr. Ashok Karad. I don't know whether he is here in the gathering, but wherever he is, my regards to him. Thank you very much, sir, for this kind suggestion. So that brings us to tip number 2. The tip number 2, when I told you about the profile photograph, take one photograph with flash, without flash, and get that result, do not do it in post-processing. Do it right that time. It will improve your photographic perception. At the same time, you will have a better result. Whenever you are taking a facial photograph, I must tell you that today also, I am pained to see that in many conferences, in many presentations, the background is something very distracting. Sometimes it is more colorful and vibrant than the subject itself. Use a plain white background. That is number 1. But when you use a plain white background, what happens? That this particular thing, the shadow comes on one side. There is a shadow on one side. When you use a plain white background, the shadow is black in color. So that blackness is visible more. So whenever you are, what is happening? Yes. So when you take that photograph, just a minute, I think I have something has gone wrong. Anyway, because this is a video and I'm running it. So when you take a photograph, there will be a shadow. Invariably, there will be a shadow. To get rid of this shadow, just you illuminate the background. When you are using a screen that is an X-ray viewer, just illuminate the background, take the photograph with the same setting, and you see this is the result. The shadow is nullified. So this is tip number 2. So these are small tips. If you are interested in something big, then I think you may not be uh, in a proper hall. Then tip number 3. Now look at this photograph. The photograph which I took in tip number 2 with the illuminated background. But still I want to improve this. Still I want to improve this. If you look carefully, because the flash is fired from one side, there is an uneven exposure on the left and the right side of the patient. And this particular thing will create an illusion of an asymmetry in the face. Wherever the light is more, that looks bigger. Wherever the light is less, it looks smaller. Photographers, the fashion photographers especially, they use to this particular phenomenon to their advantage. If the patient, the subject is slightly thick, then they use more shadows to make it slim, appear slim. So that is the thing. So now this particular thing has an uneven exposure, especially if you see this temple area. Concentrate on that. So in that particular situation, what you need to do, you have to give 2 lights, one from this side, one from that side. But camera doesn't have 2 flash. And I don't want you to invest in 2 flashes. Rather, bring your another assistant. Let her hold the reflector, a small thermocol sheet. That thermocol will act as a reflector, and now you see this photograph. The first photograph is with white background, not illuminated. The second photograph is with white background and illumination, and the third photograph is with white background, illumination, and the reflector. If you look carefully, all these 3 photographs, between the second and third photograph, you will realize that the symmetry or asymmetry, whatever is there in the facial appearance, will be truly represented when the light is falling from both the sides. So with that, I have to keep tab on the timing also. So with that, we come to the tip number 4. Avoid red eyes. Red eye is a phenomenon which is created in the facial photographs because of bounce back of the flash. So use a facility in the camera which is known as red eye reduction facility. What it basically does is it fires a tiny pre-flash just before the main flash, and that would compel the patient to constrict the irises, and that avoids the bounce back of the flash, and thus you avoid a red eye. So that was tip number 4. Tip number 5. Whenever you are shooting a close-up of a smile, I do not recommend cropping. Go close to the subject and shoot. But when you go close to the subject, your flash is also going close to the subject. And flash, that proximity of the flash with the facial appearance, facial structure or the subject will create an overexposed image. So that overexposed image will not look good. Thus, highlights are blown out. Do you know that you can reduce the flash compensation or flash exposure? Do it. In your camera, go to the menu and control your flash. Instead of full power, make it half or maybe 1/4. And this will avoid any overblown highlight in your image. If still you are interested, pay attention for 15 more. Number 6, when there is a bounce back of flash from the saliva, that also creates such distraction. Just before you are taking an intraoral photograph, wipe off the saliva with the help of a tweezer and a simple cotton. And you get such neat and clean image. Look at these two images side by side, one with saliva, one without saliva, only just using one small cotton piece and a tweezer. Simple tips. Number 7. How many of you have realized that in intraoral photography, there is a blown out highlight? The saliva is shining, your metal is shining, or maybe some, if you have some prosthesis or zirconia or something like that, that is also shining. So there is a reflection. To avoid that reflection, cover your ring flash if you are using. And if you are not using, use it. Cover that ring flash with the help of a tracing paper, which we use for cephalometric tracing. This particular thing will avoid that flashy effect. Look at these two images. I was not using it, but when during a course of preparing a online course for Udemy, which I will be telling you later in this, because I have to advertise something, photography also gives me some money. So look at these two photographs. I do not know whether you will be able to appreciate this is pre-treatment and post-treatment. What happened that post-treatment I am now since last 3-4 years I'm using with that diffuser or tracing paper. So you can see that this is now the prosthetic work has to be done on the central incisors. So you can see the salivary reflection, and the salivary reflection is nullified in other thing. So use these simple things, but give you a good result. Then how many of you have felt that when you put a single AA battery, single use AA battery in your ring flash, it gives more power. The flash is bombarded to its full capacity, and that gives reflection of saliva and the metal prosthesis if they are. Instead of that, because single use batteries are basically, they degrade over the time. They degrade with the use, and they provide less and less and less and less power. Instead, use a rechargeable batteries. They are meant to have all or none phenomenon. They will have a consistent effect on the flash throughout their use. Once they are down, they are down. Then it's time to recharge. This also will avoid an electronic waste. Use it. Tip number 9. Look at these two images. Number A, number B. I think it's a video. Yes. But there is nothing in this video. This is tip number. Look at this. Median diastema. You will be able to appreciate more in photograph number B, just because the tongue is retracted. Ask the patient to retract the tongue whenever you are taking intraoral photographs. But sometimes there are many patients, including myself, many people who cannot just control their tongue. For them, there is another tip. And that is use contrasters. I'll tell you a simple tip of preparing a contraster, and this is very useful. All of you, all students, all clinicians can use it. Your assistant, your receptionist, your chairside assistant, whenever he is free, because now aligners are coming, so you will get more and more free time. Okay, because someone was telling me that aligners will ruin orthodontics. Well, yeah, have you, sir, Miss R, sir, when was the last time you went to stitch your shirt to the tailor? 10 years. That means this is Invisalign. This is Invisalign. Tailors are gone. You have to understand, this is the mathematics, how the world runs. Okay, so you have to accept something. You have to prepare yourself. That's why I shift to photography or shift to any other things. But okay, so this is very, very important. This is in within 5 rupees or 10 rupees, you can prepare one contraster. It's a disposable contraster, very good result. And take this. Take a black art paper, cut 1 square inch, and these are wooden sticks. Apply a Fevicol over it. Stick it on one side, and your contraster is ready. Prepare 2, 3, 400, whatever amount of patients you have. Take one photograph without contraster. This is another photograph with the contraster which I prepared just now, and these are the results. Simple, and this is disposable. Rather than purchasing a contraster which is of 1000 or 2000 or 3000, which is not disposable also. Very simple. And you can prepare it with different sizes. If suppose the patient's oral cavity or there is a child, so you can just cut it. Just cut it. Prepare a bigger size, you can cut it. So it is custom made. So that was tip number 10. Oh, tip number 11. I have to be little fast because 9 minutes are there. So whenever you are taking a patient photograph, you have to train yourself, but at the same time, you have to train your assistant also to hold the cheek retractors. If the cheek retractors are not holded properly, then what will happen? That the image which is symmetrical to start with looks asymmetrical. It gives an asymmetrical appearance if the labial phenomenon is pulled on this side or that side. Or whenever you are taking an occlusal photograph, ask the patient to retract the tongue symmetrically rather than asymmetrically. Otherwise, it gives a symmetrical appearance to an otherwise symmetrical picture. Tip number 12. I'm going slightly fast because I have to match this timing also. Tip number 12. Fog on a mirror is basically because of what? It's a temperature difference between the oral cavity and the room temperature. So oral cavity temperature and the mirror temperature should be nearly equal. If they are, then fog will be nullified. What I am using in my clinic is this thermal pad, which is available in 200, 250 rupees. Whenever patient is not there, I keep it on back of my chair and relax. And you get rid of the fog. Get rid of the fog. So both the things can be done. Tip number 13. Whenever you are using a scale for the, this is a pathologic specimen, but even if you are using some orthodontic models or any prosthetic thing, the same thing applies. Scale it properly. Do not put the scale on the top of the specimen or on the side. Keep it beneath. It looks like as if you are underlining the specimen or that prosthesis, and thus overemphasizing its importance. Emphasize your subject with the help of your photograph. Do not use the scales like this, especially those tinted with that Natras scale and do not use flash for tabletop photography. Tip number 14. This is very important. This is very, very important. If there is some medical legal trouble, then this is very important. Adjust the time and date inside your camera, because whatever time and date you have adjusted, the same will be embedded in the image. I remember I don't have time to tell the story, so I'm not telling you that story. So, but there was one review which was coming, JIOS, there was one paper submitted. The author claimed that the treatment is over in 13 months. I usually have this digging nature, that issue with me. There is some worm there sometime somewhere in the body. So that particular thing. So I checked the EXIF information and I could see that the difference between the time of the pre-treatment and post-treatment was 28 months. I wrote to the editor that this is the fraud. I consider it fraud. Without reading anything, you should reject it. I don't know what happened later on. Okay. So time zone and date you must, because this will be sometimes if you are stuck in any medical legal issues, some troubles, then this is very important. This will be very important. So do that. And number in the same line, I think this is a video, so I must run it. So time zone and date, you adjust it. I think you can give me some 30 seconds, 40 seconds more, I think people are interested. It is my belief. Otherwise, okay, another way for medical legal issues, always shoot one copy, at least one copy in RAW. Always shoot, because RAW images are like your digital negative. They are negative images. They cannot be altered, and they are considered authentic for authentic documentation in medical legal cases. Your JPEG images are not considered authentic, only raw images. So even if you are not, you do not want it, you keep one copy with you. Sometimes it should not happen with you, but if it happens, then this will be to your rescue. The number 15, always, always take a consent. Even if the patient is known to you, 5 minutes. Palpitations increases. Okay, so there is a photographic release form. There is a photographic release form, which I will be telling you in tip number 19. Pay attention to 19 because 19 is more important for me. These tips are of no use. Get it signed by the patient or the parent. Don't think that patient is known to me, parent is known to me, because that patient tomorrow may become orthodontist and sit here. And if you show the photograph, he or she may take objection. Otherwise you need to blind the eyes, which does not look aesthetic. We are from an aesthetic branch. Make it more aesthetic. Then there is a template you prepare. This is one template. If some students, they want to know or they want this ready-made template, because sometimes students doesn't want to learn, but they want it. Okay, so if you want it, you tell me, you write to me, I will send you a ready-made template. Just you have to put your photographs there and the template is ready. This is prepared in Adobe Photoshop. The precondition is you must have an Adobe Photoshop. So this is the template. So this template, whenever I take the photograph of patient, I give it to the patient by WhatsApp, by email, by Facebook Messenger. All three to the one patient. And invariably this particular thing are shown after the treatment is over. Again, I give it to the patient and that is shown to at least few people. That generates my orthodontic income through photography. I purchased camera, that photographic equipment through orthodontics. That now photography is generating an orthodontic income. So that was tip number 16. Now in the same line, I need to, just a minute. I need to show you one thing. This is a PDF file. Nowadays, I am giving this PDF file. So if you want, someone wants this also, I can give you the template for the PDF. Okay, so this is how I prepare a PDF file of a patient. Okay, so let me show you a case record of so and so before treatment. I write in a patient's, not pre-treatment, before treatment, facial photograph, dental photograph, after treatment, facial photograph, after treatment, dental photographs, facial photographs before and after in the one page, and dental photograph before, after treatment in one page. This is my clinic address. What are the things which we do scientifically? We claim that we do scientifically. And then what are the facilities available in my clinic? And I wish that this is for your personal use and please write your feedback. So all information about my clinic is there in the PDF. So if patient wants to show someone, then they ready-made have my address. Okay? So this is how I do my marketing in photography or in orthodontics. Those who are aware about my Facebook page and YouTube also must be knowing that I market a lot my wildlife photography. Then photographing a radiograph may be inconsequential in today's era because most of us are taking radiographs in a digitized manner. But still, I want to stress that if you do not have X-ray viewer, then you can use your laptop or your mobile phone as a X-ray viewer. It's a good tip. You can just use that rather than holding it like this. If you want to, I don't think that template is necessary. for me to teach you. Uh, Tip number 18, 19, and 20 has to be finished in 1 minute. So tip number 18, especially if you are in Mumbai or any coastal area where the humidity is more, keep your photographic equipment in a thermocol box with silica gels. They act as an adsorbent, not absorbent, adsorbent. They adsorb. And uh, they avoid any fungus accumulation over your glasses. Tip number 19. This is the most important and for which I am here. Tip number 19. Enroll for my online course. If this 18 tips, these 18 tips have created some enthusiasm, then enroll my for online course on Udemy, which is Learning Clinical Photography in Dentistry. And let me take this opportunity to tell you that nearly 500 clinicians from across the globe. Specifically, this is a screenshot I took yesterday. 42 countries and in 13 different languages, it has been translated. So please enroll it. If you want a discount coupon, because now I think it is 2000 or something like that, but it can be available at a very discounted rate of 389. I already prepared one discount coupon. If someone wants, please take it. It gives me a revenue also. So this is the that link, but I'll share you later. And tip number 20. If you are bored with wires, pliers, orthodontics, go to my Facebook page. See some incredible wildlife images from India and Africa. And if you still want something to see a movable thing in jungle, then subscribe to my YouTube channel, Matri Vyas Clinical and Wildlife Photography. And sometimes, if your resources, time, and inclination permits, join me for African safari. That's all. Thank you.
Thank you, sir. That was a wonderful and a crispy presentation. I must say, every picture is worth 1,000 words. So whenever we think about Vyas sir, we see a roaring tiger picture every time. Thank you, sir.
Thank you. Thank you so much. Hello. Hello. Thank you so much, sir, for such an inspiring and a brilliant presentation. I'm sure we're going to do all the tips, including 18, 19, and 20 that you have mentioned. I would now request the chairperson to kindly felicitate Dr. Matri Vyas sir with a plaque and a certificate of appreciation. Yes, yes. Just 1 minute.
I have a request to all the PG students. Just give us 10-15 minutes. We'll be talking to you about the basics in research and research methodology. Please, PG students, don't leave the hall. I am here to talk to you for 20 minutes because my topic is accelerated orthodontics. I'll be talking on the concept of accelerated orthodontics. It is a research-related topic. See, present day what has happened is with so many PG students coming into orthodontics, it is very difficult for the PG guides to give you a proper dissertation topic. I am here to tell you that this is one of the area where most of the research can be undertaken by the postgraduates. So give us 10-15 minutes, maybe I'll have 2 to 3 take homes for you. Please bear with us.
Thank you, sir. I would now request the chairperson to kindly introduce the next speaker for the session, Dr. Rajan K. Mahindra, sir. Thank you.
Our next speaker is Dr. Rajan K. Mahindra, sir. He's a professor, head of the Department of Orthodontics from Government Dental College and Hospital, Aurangabad. He did his BDS and MDS from Government Dental College and Hospital, Aurangabad, and he has a teaching experience of more than 32 years. Welcome, sir. Over to you.
Yeah, my point of view. See, at the onset, I am thankful to the organizers for giving me a chance to share my views in front of all of you. Secondly, a great thanks to Dr. Ambekar, my friend from Latur. See, I'll start with the basic. That is, what made me choose this topic for discussion? Accelerated orthodontics. See, friends, I'll tell you, with increasing number of PG students nowadays in orthodontics, it's very difficult for the PG guides to give you appropriate thesis topic. And I feel that this branch has immense potential for doing research in the coming years. For the simple reason that this is a branch which is dealing with the basics of tooth movement. This is a branch which is dealing with the biology of tooth movement. And this branch has got 8 to 10 avenues by which you can bring about faster tooth movements. You can fasten your treatment in a shorter time by using 8 to 10 modalities. Now, friends, if you review the literature, this has been brought to text since 2000. 2000, 2010, 2003, 2015, and recently 2020. But in the recent past, it has been seen that there is lack of interest amongst the Indian people doing research towards accelerated orthodontics. Before I go into my slides, I'll tell you one more thing, that you have a take-home here. That is, I am trying to promote, I am trying to tell you, I am trying to educate to you that there are at least 3 to 4 methods by which we can accelerate tooth movements. Like, for example, number one, I'll tell you micro osteoperforations. This is going to stay. I'll tell you this is going to stay for maybe next 10, 20 years. Second method I'll tell you is lasers do have a big application in fastening your treatment. And thirdly, we have been dealing with piezo-session. That is, an instrument called as piezotome can help you in faster orthodontic treatments. So what happens is, I'll tell you, when we are into your second or third year, approaching exams in MDS, few cases you will not be able to finish before your exams. So that is a period that if you can, you are well versed with these techniques, and if you can practice these techniques of accelerated orthodontics, maybe it might help you in your clinical practice. I'm not sure how much this can be practiced into day-to-day clinical practice, but for an institute, for a student, for a postgraduate, I think this is very, very important. So this is a college from where I belong, I come. This is Government Dental College and Hospital, Aurangabad. It's based in Maharashtra. Not working? This is the picture showing my department. We are 5 years old into post-graduation. We started PG just 5 years back. The topic will be covered under these two heads. That is, number one, we will be discussing more of theoretical aspects of tooth movement. And in the second part, I will be sharing with you our experience about accelerated orthodontics. One of my PG student has done a research, that is a dissertation, using lasers and using corticotomy. So out of our personal experience, I will be telling you few take-homes for you. That is what you can do and what you should do. So synopsis, we will be discussing under the heads of introduction, factors affecting tooth movement, biology of tooth movement. And in second half, I will be discussing about the study that we had undertaken in our own department. Introduction, I'll start with the basics, that is basics related to the biology of tooth movement. It is said, orthodontic tooth movement has been defined by Prophet as a result of a biological response to an interference in the physiologic equilibrium in the dentofacial complex by an externally applied force. The average orthodontic treatment time for adults is considerably longer than for adolescent patients, ranging from 18.7 to 31 months. This is one of the major disadvantages of orthodontic treatment. This is one of the major disadvantages of orthodontic treatment, that it takes a long time. So most of the studies are basically designed towards reducing the treatment time in orthodontics. Just for your basic knowledge, factors affecting duration of orthodontic tooth movement, we usually depend on characteristics of surrounding bone, physiologic activity, and the force application. These are besides the doctor factor, the patient factor, and the biology. Now, when we go into the finer aspects of biology of tooth movement, Burstone had suggested 3 phases of tooth movement. That is, the phases of tooth movement are divided into 3. Number 1, we have the initial phase where there is rapid movement after application of force. It happens between 24 hours to 2 days, followed by the second lag phase, that is little or no movement for next 20 to 30 days, followed by post lag phase, that is gradual or sudden increase in tooth movement. Again, for the interest of PG students, theories of tooth movement, this is very important. You should be well versed with these theories. That is, the orthodontic force applied on the tooth structure results in a tooth movement by deposition and resorption of alveolar bone called as remodeling. There are 3 possible theories that have been formulated. The pressure tension theory, which says the histological research by Oppenheim and Schwarz hypothesized that a tooth moves in a periodontal space by creating a tension and pressure and resorption. Furthermore, when we go into the details of this pressure and tension theory, as suggested by Sandstone and Oppenheim, we have 2 sides. That is, we have the tension side where there is bone deposition because of osteoblasts. There is bone, blood flow is increased and there is oxygen level increased. And on the other side, that is pressure side, there is bone resorption, there are osteoclasts, blood flow is decreased and the oxygen level is decreased. And lastly, the prostaglandins and cytokines released, metabolic changes, that is second messengers are activated, enzyme level is changed, and there is increased CMP levels, and the cellular differentiation begins approximately after 2 days or when the tooth movement begins. The other 2 theories that were suggested by Farrar, that is in 1888, that is bone bending theory, which states that applied orthodontic force bends bone, tooth, and the solid structures of periodontal ligament. Since the bone is more elastic than the other structures, it bends effortlessly, and the process of tooth movement gets accelerated. The third theory that a postgraduate student should know is something called as biologic electricity theory. This was suggested by Bassett and Becker in 1962. It says that whenever the alveolar bone flexes or bends, it releases electric signals, and to some extent, it is responsible for tooth movement. It was thought to be piezoelectric signals. This suggests that the piezoelectric response due to bone bending might function as cellular first messenger. These are the few things that postgraduate students should remember when it is something related to biology of tooth movement. That is, role of chemical mediators. In this, the first and the foremost is the role of cytokines. Cytokines are extracellular signaling proteins directly involved in bone remodeling and inflammatory process during OTM. Prominent cytokines that show demonstrated effects on bone remodeling are 1L, IB, 1L6, TNB alpha, and GCF. These cytokines have been shown to stimulate bone resorption and induce osteoclast proliferation. Furthermore, explaining the role of cytokines, there was a theory suggested by Alicani, which says that biphasic theory of tooth movement, the molecular and cellular events during orthodontic tooth movement. We have 2 phases, that is, you have the catabolic phase, where osteoclast-driven bone resorption determines the rate of tooth movement, and you have the anabolic phase, where osteoblast-driven bone reformation re-establishes and maintains alveolar bone integrity of the new occlusion. Cytokines play an important role in initiating the catabolic phase. Interaction between osteoclasts and osteoblasts regulates the anabolic phase. Therefore, to increase the rate of tooth movement, so why this is being discussed here is, therefore, to increase the rate of tooth movement, acceleration techniques must focus on producing higher cytokine activity and enhancing osteoclast and osteoblast interactions to expand the boundary of tooth movement. Second factor in this chemical regulation is chemokines. As the blood flow reduces on the pressure side due to compression of the periodontal ligament, some of the cells undergo apoptosis while others die, resulting in necrosis. These cell deaths also include some osteocytes and osteoblasts in the adjacent alveolar bone. The causes This causes acute inflammatory response with the release of chemokines, which are small proteins that could attract other inflammation and precursor cells into the extravascular space from the vasculature. This is another issue that is important in case of the chemical regulators, that is RANKL, RANKL and OPG system. This was suggested by Drugrain et al. In 2003. These three factors control the related ligand downstream regulator of osteoclast formation and activation. RANKL, that is receptor activator nuclear factor, NF-kB ligand. RANK, it's a receptor activator nuclear factor. It binds to the RANKL. And osteoprogesterone, decoy receptor competing with the RANK. I request all the PG students to go into the details of this. At the end of my lecture, I will be giving you few references. I will be quoting few references from maybe seminars in orthodontics and other references. It is a humble request to all the PG students, especially first year PG students, when you are reading for the basic sciences. See that you go into the basics of bone physiology, bone mechanism, composition of bone, etc. So I'll give you references that will be a take home for you. Next, in the category of contributors of this in chemicals is the role of neurotransmitters in tooth movement. Dental and paradental tissues are innervated by neurons originating from trigeminal ganglion. These neurons contain many neuropeptides like substance, vasoactive intestinal polypeptide and calcitonin. These neurotransmitters are released when force is applied, and they create a state of acute inflammation that releases the signaling factors like cytokines and other mediators. This is another very important phenomena in the basics related to biology of tooth movement, that is orthodontitis. The inflammation behind the tooth movement. The inflammation behind the tooth movement. Just try to understand this and you can go into the details of reading this particular phenomena. Orthodontitis is the inflammation that involves the periodontal ligament, bone, cementum, and many times the dentine. It is a biologic process that is behind every tooth movement, and it might lead to minor to severe manifestations of root resorption. The inflammation is physiologically or normally responsible for bone as well as cemental remodeling. However, for yet unknown reasons, there might be a failure in the coupling process which let the resorption continue beyond the borders of the cementum and dentine. Unfortunately, among the three tissues involved in orthodontitis, the periodontal ligament and the bone both are fully regenerated, while the root is not. This is the area where there are likely to be complications as regards root resorption. Finally, we conclude with a biological basis which says that there is mechanical loading and underloading. Recent studies have now suggested that tooth movement may be due to alterations in the mechanical loading state of alveolar bone osteocytes on the side in which the tooth is moving. There may be an underloading state causing osteocytes to release rankle, which increases bone resorption. It is now evident that the traditional idea that OTM solely occurs by necrosis and hyalinization of the periodontal ligament is misconception. We have finished with the part 1. We'll go into the part 2. That is the area which is of clinical concern to the PG students. That is the area of accelerated orthodontics. I'll tell you, a lot of research has been done since last 20-25 years. But then somewhere we have lost the ground. Somewhere I request more of our PG students to follow these topics for research, so that we go into the details of the biology of tooth movement, understand the macro, micro, and the molecular basis of orthodontic tooth movement. And subsequently, once we know the basics, we can go into the different methodologies, different treatment modalities which can hasten or accelerate your tooth movements. So under the accelerated orthodontics history, surgically assisted orthodontic tooth movement has been used since 1800s. In 1893, Cunningham suggested luxation of the immediate method in the treatment of irregular teeth at the International Dental Congress in Chicago. Corticotomy facilitated tooth movement was first described by L.C. Bryan in 1893, published in a text by Guilford. Cole suggested a technique called as Bony block technique, and Wilcock suggested corticotomy surgery with alveolar grafting, which is known as AO or PAO or Wilcodontics. This is again a very interesting technique which has been tried by different people in Indian conditions, and it has been found that it is not very, very easily acceptable. For the simple reason that it involves a surgery, which is not very comfortable and convenient to the patient. Now, why do you need to accelerate or need to accelerate the tooth movement? Prolonged treatment duration is one of the main concerns of patients undergoing fixed orthodontic treatment. This extended treatment time has several drawbacks like increased predisposition to root resorption, dental caries, gingival recession, etc. And therefore, a need arises to accelerate the rate of tooth movement, and that is what is our area of concern. Now, before we go into the discussion of the procedures of accelerated orthodontics, try to understand this phenomena that is called as regionally accelerated phenomena. This was suggested by Frost in 1983. What does this phenomena say? It says that the iatrogenic injury concept of the inflammatory cascade and its role in wound healing led to the development of regionally accelerated phenomena, that is RAP, RAP. It is a local response for noxious stimulus where tissue forms faster than normal regeneration process. The decreased mineral density allows for easier orthodontic tooth movement during remodeling and healing. RAP typically peaks till 1 to 2 months and it lasts about 4 months post-surgery. 4 months post-surgery. Different methods to accelerate tooth movement. We have basically two methods. That is number one, stimulating the artificial pathway to increase rate of tooth movement, whereby we have application of chemical agents and physical stimulation. And second is stimulating the natural pathway to increase rate of tooth movement, whereby you have a procedure called as corticotomy, piezocision, and micro-osteoperforations. This is the area which I was talking to you, that right side, stimulating the natural pathway. This is the area where we can try, we can do, and we can pursue our research under the Indian conditions. See, doing research in Indian conditions is not easy. We are ill-equipped, maybe on equipment side, maybe on research side, maybe on publication side, maybe on support from the literature. So this is an area where I request all you PG students to dedicate more of your time during your post-graduation and pursue research related to stimulating the natural pathways to increase rate of tooth movement. This is again a chart which has been taken from the literature, from the text, which tells you that there are basically three methods of accelerating tooth movements. That is, you have surgical method, you have drugs, and you have device-assisted therapy. Under the first category, you have two procedures called as osteotomy and micro-osteoperforations. Drugs we will not recommend because the people have not found very good results using drugs. Maybe the third category, that is device-assisted therapy, people have found good application of low-level lasers. Now, laser machine is available in most of the institutes. I feel that this is the area where most of the PG students can dedicate and try using lasers to accelerate tooth movement. In the bottom section, we have said that micro-osteoperforation, piezocision, device-assisted methods are the least discomforting among all the surgical procedures, and this will make them more commonly used procedures in future. See, you go to any Google search, you will find that lots of literature is there about different methods related to accelerating tooth movements. But my experience, I'll tell you that these are the three methods on which you can work on. So there is no point in going after the things which have been tried, found to be less clinically applicable, found to be more troublesome to the patient. See, what happens is, when you're selecting any technique, it should be weighed up against the risk to the benefits. And the patient's choice also should be considered. You see the concern, you see the comfort, you see the choice of the patient also. If you are to sit in the patient's position, you will always feel that as far as possible, it should be non-traumatic, it should be non-surgical, it should be non-invasive. So that is the reason I am telling you that there are three very good measures which can help you in day-to-day acceleration of tooth movements. Review of literature. This again, I'll tell you, a very good study was undertaken by our PG students in GDC Nagpur. It has got a AGO publication, that is, it was a study done by Doshi, and she had tried lasers. She had tried lasers. Other studies that have been reported in foreign literature has been done by Shoreb by using a corticotomy. Mani Alikani, he tried micro osteoperforations. Hugh Cow tried photobiomodulation. A few people in Thailand, they have tried interceptal bone reduction. Antonio tried vibration, and Sharaway tried piezocation. Besides this, I'll tell you that we have done one study using corticotomy. We have compared corticotomy with the laser use. And one of our PG students in GDC Nagpur, he has done photobiomodulation. That has not been printed, probably it has not been published. So you can use these studies as the reference studies. These studies which have been done in Indian conditions will help you better. It will help you better in deciding the method, the choice of method, the procedure that is to be followed, the statistical test that you should follow, what test will give you significant results, etc., etc. So this is where I have requested PG students to just hold back and just take home something from this particular lecture. This is the research that was conducted by us in Government Dental College and Hospital, Aurangabad, whereby one of my PG, she did a comparison between the effect of low-level laser therapy and periodontally accelerated osteogenic orthodontics, that is PEO, on the rate of orthodontic tooth movement using digital caliper and bone density using cone beam computed tomography. It was a split bout technique. In the upper arch, we tried both these techniques, one on the left, one on the right. Aims and objectives of this study were to analyze and compare the rate of orthodontic tooth movement after low-level laser therapy and periodontally accelerated osteogenic orthodontics, PEO. The objectives were to comparison of the rate of tooth movement following low-level laser therapy and periodontally accelerated osteogenic orthodontics. What was done in low-level laser therapy? I'll just give you the outline of the procedure that was done. That is, a Zolar photon plus soft tissue diode laser was used. The parameters were set at wavelength of 800 nm, continuous wave mode output of 0.25 MW, and an exposure time of 10 seconds was used. A total number of 10 irradiations, 5 on buccal side and 5 on the palatal side, on the buccal side. Irradiation doses on the cervical third of the root, that is 1 mesial and 1 distal. Irradiation doses on the apical third of the root, that is 1 mesial and 1 distal, and 1 on the middle third, that is center of the root. On the palatal side, the irradiations were done similarly. The tip of the laser was held in contact mode with the tissue during application. As regards the second procedure that we tried, that is PUO, that is periodontally accelerated osteogenic orthodontics, in that we had to do a surgery whereby we used the number 15 blade was used. Full thickness mucocostal flap, mucoperiosteal flap was elevated using a mucoperiosteal elevator. Using a number 6 round burr in low speed handpiece under copious irrigation, corticotomy perforations were made distal to the canine. The depth of the holes were approximately the width of the buccal cortical bone. Decalcified freeze-dried bone allograft was placed at the perforation sites. The flap was then repositioned and sutured with a 5-0 non-resorbable suture, and a periodontal dressing was given. This is what is the surgery that was performed. Stepwise, number 1, 2, 3, 4, 5, 6. Data collection was recorded and measured at T0, that is after completion of alignment and leveling, and T1 on completion of canine retraction. On the models, the mesiobuccal cusp of the first molar and the canine cusp tip were taken as the reference points. The distances were measured with a digital vernier caliper, precise, with a 0.02 mm accuracy. The rate of tooth movement was calculated as the amount of tooth movement divided by the time taken for complete canine retraction. Finer details of this study, if anybody is interested, I'll give you the contact number and email of my PG student. You can be in touch with her and she can guide you for doing these procedures. This was the thing we did during data collection using a vernier caliper. This was again the same thing. The results. In this split mouth study, we have performed PO on one maxillary quadrant and a laser on the contralateral side. Results indicate that both the PO and LTT groups increases the rate of tooth movement when compared to the conventional sliding mechanics. However, the result is non-significant when both the groups are compared to each other. That is what I mean to say is that the acceleration was there, but in between these two methods, there was negligible change. But definitely, the patient will always prefer use of lasers compared to the surgical procedure that will involve pre-surgical preparations, post-surgical management, sutures, etc., preference was given more to the lasers. Under the discussion side, the tooth movement by conventional method is 1 mm per month. PO and laser method used in this encouraged rapid tooth movement, reducing the treatment time. The alveolar bone density was reduced, decreasing the bone resistance to tooth movement. The bone density was restored after a few months. Rapid tooth movement is caused by the phenomena caused regionally accelerated phenomena. The two main features of RAP in bone healing includes decreased regional bone density and accelerated bone turnover, which are believed to facilitate orthodontic tooth movement. Furthermore, Wilco showed radiographic evidence of an osteoporosis state in an alveolar bone treated with corticotomy, a characteristic seen in RAP. Venkat described PU and LT as invasive and non-invasive procedures, respectively, involving RAP. And Yasi concluded that the laser increases Rankel L and macrophage colony stimulating factor, increasing osteoclastogenesis and accelerating orthodontic tooth movement. In conclusion, unlike periodontally accelerated osteogenic orthodontic, low-level laser therapy has the advantage of being a non-invasive treatment modality which serves the same purpose of accelerating orthodontic tooth movement. Among all non-invasive interventions, laser is more effective than micro-osteoperforation, is more effective than vibrations, is more effective than photobiomodulation. So these are the 4 techniques that I have been requesting you that you can try in your own clinics. It's not necessary that you undertake this as a research topic. Maybe you can undertake this as a small study. You can try in few cases. You have few cases, on one side you're not getting proper retraction. Space closure is not taking place. So this is the area where you can use this. And this technique of accelerated orthodontics you can use for all different types of tooth movements. You can go for space closure, you can go for vertical placement of teeth, correction of deep bite, correction of cross bites, everything can be done using these techniques. Lastly, take home for you students is accelerated orthodontics present status that is evidence based. Recently, a product named Excellent using soft pulse technology is used to reduce treatment time by 30 to 40%. This equipment, this instrument is available in the market. You can have access to this and you can try this. Secondly, the use of minute direct electric current for accelerated orthodontic tooth movement was only applied experimentally and no clinical application has been reported. Electric current applied in canines for 5 hours per day. Thirdly, laser therapy produces non-invasive stimulation. The effect of laser on accelerating orthodontic tooth movement is still controversial, both experimentally and clinically. More experiments are needed to differentiate the energy, wavelength, and optimum duration of usage. LED device with face mask targets the root of the tooth undergoing retraction. Distraction osteogenesis has also been tried in accelerated orthodontics. And lastly, surgically assisted accelerated orthodontic tooth movement is currently the most effective technique experimentally and clinically in accelerating orthodontic tooth movements. These techniques include rapid canine retraction through distraction of the parietal ligament or dentroalveolus, selective alveolar decortication, corticism, piezocision, and piezopuncture. Micro-osteoperforations, you have a device called as Propel. You must have seen this in the social media. This is again a device which is very much easy to handle. It is self-explanatory, very easy to handle. So micro-osteoperforations device called Propel, introduced by Propel Orthodontics, is used to create perforations of varying depths. This process is called as alveocentesis, means puncturing bone. In association with this, friends, I'll tell you that in our department, we are trying a modified way of micro-osteoperforations using a mini implant, micro implant. We are using the micro implant for creating perforations in the bone distal to the canine. And similar type of results can be seen. I am planning to give one dissertation topic to my next first year PG student, whereby we are planning to compare different methods of micro osteoperforation. One probably we'll use it with the Propel, maybe other we'll use it with the micro implants. And lastly, piezocision technique, that is flapless surgery, is less invasive than corticotomy, and it is with instrument called piezotome. Injections of PRP and local injections usually not indicated. These were tried in older times. Nowadays, it has been seen that not to be very, it is not applicable, or it is not acceptable by most of the patients. So this is another area where I feel most of the research can take place. That is gene therapy and tooth movement. The first attempt for gene therapy in orthodontic treatment aimed to reduce osteoclast activity and inhibit tooth movement. In the end, in the concluding sentence, I'll tell you that genomic regulation of orthodontic tooth movement is fascinating and interesting subject gaining importance. This is the area where lots of research can take place in the coming days. So in summary, I conclude by saying that a 3D perspective is essential for appropriate case selection and understanding of events. Theories of biology of tooth movement need to be revisited. Indirect techniques like micro osteoperforations are better than direct techniques, and the direct techniques there is a lack of extensive scientific evidence. It implies that there is still a scope for doing research in these areas. See, there were 5 to 6 presentations on this particular topic of accelerated orthodontics in the present conference. The reason is these are practical things. These are research related things. These are things which can be undertaken by most of the students at most of the institute level, and you can see your own results. But only thing is that you do it in a proper manner, do it under the standardized manner so that you get the desired results. These are some of the references I told you. You can take a picture of it. That is, this is the first articles. They appeared in seminars in orthodontics in 2000. Then you have seminars in orthodontics of December 2012. Followed it up with September 2015. These are few of the articles which you must read if you want to pursue a study or a research in this particular direction of accelerated orthodontics. These are the furthermore articles that have appeared in all the international journals. So I conclude with this, with my last slide, which says that there is no limit to what you can do, except the limit you place on your own thinking. So you, as a postgraduate student, I request you to think big, think out of the book, think something extraordinary, and take a few clinical topics which are of clinical interest to you, to the profession, and to the society at large. But only request is when you're selecting any method of accelerating orthodontics, see that you weigh the risk against the benefits. See that you take patient into confidence so that patient should be informed as to what you're going to do, and choose a method which is most acceptable to the patient biologically, physically, and otherwise. With these words, I thank you for patient listening. I requested you to be here for the simple reason that my take home to the PG students is, see friends, few people will tell you that this is the end of the road for accelerated orthodontics. I'll tell you it's never the end of the road. This is the beginning in the Indian conditions that we should pursue, we should do, we should see, and we should try to find the results to our convenience. See, whatever we have been referring is all foreign literature. Very few people in India have been doing genuine work on these topics. Probably I have one of my friend, Pradeep Raghav, who is doing immense work in the north, in Meerut. So yesterday I was talking to him, I told him, say, we need to do it in a more judicious manner. We need to do research in a more appropriate manner. And we need to encourage the students to take up more studies which are related to clinical, which are more related to in vivo, which are more related to fastening of the treatment, which are more related to getting better results in shorter times. So this is where I need that you need to think big. And with this, I thank you. And I thank all the organizers and the chairman for giving me an opportunity to express my words. Probably next year, I'm planning to come again with our experiences with osteoperforations. We have been trying one market-related instrument along with our own indigenous instrument which can help in fastening or getting accelerated orthodontics. So thank you, and
Thank you, sir, for this wonderful insight. I think this must have accelerated the idea of using accelerated orthodontics to finish the case in a stipulated time period for all these PG students. So I think that is the most important take-home message for them. Thank you, sir.
Thank you.
Thank you, sir. Now I would request our chairperson to kindly felicitate our speaker. I would request our chairperson to kindly introduce our next speaker, Dr. Abhijit Misar.
The next speaker for this session is Dr. Abhijit Misar, sir. He has done his BDS in 1992 and MDS in 1995 from Government Dental College and Hospital, Mumbai. He is presently working as a professor, PG and PhD guide in Yashwantrao Savan Dental College, Ahmednagar. And he is a passionate clinician and academician. Welcome, sir.
लगा नहीं काम
Right, sure. Well, good afternoon, everyone. Thank you so much, Dr. Anand, for my introduction. This is the worst slot you can have. The last lecture of the conference. Why worst, I'm telling you. I'm saying this is the worst because most of the life members are busy for the last moment purchasing. So you can hardly see any life members. I have to really look for the life members. And thank you so much. I'm seeing Mandwa sir here. I'm seeing Singh sir here, who was the chairperson for my presentation in Nagpur conference. I'm seeing my batchmate who has come from UK, and the great, my dear friend, Dr. Shailesh, president, ex-president of our iOS. So many people. And now the best part. Why this is the best slot? Because only the people who are really interested in listening to whatever is of their interest will be there in the audience. So ज्याला आम्ही मराठीत म्हणतो की गर्दी नाही पण दर्दी आहे. So those people are there. Maybe a few people are compelled to be here because अरे अपने सर का presentation है तो हमको जाना पड़ेगा. But still, I am happy even if one student is sitting there, I am very happy to present always. Thank you so much, COC, for giving us lovely moments till yesterday, till now, making us meet our friends after the long gap of 3 years, and making us dance, enjoy, and dance to the level that we are keeping the part of our bodies on the table and dancing to the tunes of what? Savali. So thank you so much, COC. Thank you so much, COC, again for the lovely scientific deliberations where we got to see, got to know, got to learn from stalwarts and the upcoming teachers. Thank you so much. So, as usual, I dedicate this presentation to my respected teachers, Dr. Vijay Jaide sir, Dr. Vijay Jaide sir, and Dr. K.K. Mistry sir. Now, Dronacharya had Ekalavya and Arjuna. But here, two Dronacharyas are having one Arjuna and one Ekalavya. Dr. K.K. Mistry is my official guide under whom I was registered as a PG student. And Dr. Jaide sir, Dr. Jaide sir, from whom I have taken many courses and I have learned orthodontics under him. Both of them have inculcated the human values in my life. So I bow my head to my teachers and start with the presentation. Thank you. Well, expressions are an integral part of our life. And you can see lovely, beautiful expressions, which nowadays in the virtual reality, two different words, but the virtual reality, the emotions are replaced by emojis. But still, that doesn't tell us that emotions are not important. So, the case is like this, where your video is absolutely positive. Absolute positive video. And the cephalogrammatic readings are, yes, SNA 81 and SNB 73 degrees. And our expressions are, yes. So simple, lovely. Need not to call anyone. My treatment plan is ready. And now the case is like this. Is this a positive video? No, not at all. And the cephalogram reads SNA 88 degrees, SNB 80, तो mandible normal है. This is the expression. Oh God, headgear, extra oral anchorage देना पड़ेगा मुझे इसको. अरे बाप रे, God, please save me. What a headache. But this is not a headache. You need not to use this if you understand this. Now, this expression comes because we have some fear in the mind. And this fear of headgear is there because we ourselves are not convinced that it works. So if you understand the things and if you are convinced the results of headgears, you will surely start giving the headgears, delivering the headgears and delivering the results also. So if you do not know the way where you are going, then probably you are going to end up somewhere else than your destination. So if you know the way, you can start going the way. So let's start going the way. Now I have got many things to tell you. So I am not going to cover the diagnosis of vertical maxillary excess cases or the growth patterns and all those things. Let me tell you, most of the cases that I am going to show you, I'm going to present you, are vertical maxillary excess cases where you can see the gummy smile and where the patients have worn headgears for about a duration of 9 to 10 months or maybe 12 months. Dr. Vyas, if he's here, he can find out that the real time is what I'm talking about. So if you want to diagnose, these are a few things which you can find out. A very good book by Witzik and Spall. Then a book called Dental Facial Deformities by Profit will give you good analysis. Then Boston's analysis, Ricketts analysis, and McNamara's analysis. All these analysis will lead to a proper diagnosis of VME cases. But I would prefer this composite analysis, which is given in a book, Clinical Orthodontics, by our very own Dr. Ashok Karat. This composite analysis is very good to come to the conclusion of maxillary protrusion. Now, I'm directly jumping to the classification of headgears. Everyone knows this classification: vertical pull, combination pull, and low pull headgear. So I'm not going to waste my time on this. The high pull headgear looks like this. The components I'm going to speak about later. The combination pull headgear looks like this. And the low pull headgear looks like this. We have learned the classification again. This is only a diagrammatic representation of this classification. I'm going to explain this figure later in my presentations. So these are the components of headgear assembly. This one is the head strap, which goes on the head, maybe occipital part, parietal part, you get the head straps, and then you have got face bows. Now this face bow is inner bow, outer bow type of a face bow, and you have got force modules, lighter ones and the heavy ones. And this is the most important part of the headgear assembly, that is molar tubes. Now this is a molar tube which will be fixed on the molar bands, which will be welded on the molar bands. The molar bands will be cemented. Maybe it will be reinforced with the transpalatal arches. And this type of molar tube will be incorporated into the occlusal splints. Most of the cases that I'm going to present are treated with occlusal splints. So this is your important part of your assembly. Then face bows are of different type. They can be classified, or you can say these are the different types of face bows that you have. The first I already told you, inner and outer type of the bow, where you have got inner bow which is inserted in the molar tubes, and the outer bow will be actually attached to the force modules. There's another type of face bow which is called a J-hook type, which is more used for the individual canine retractions also. And you have got different types of face bows: short, medium, long. You have got a face bow which is in the bent in the outer bow is bent in the upward direction, outer bow is bent in the downward direction. And the third type is you have got asymmetric type of face bow. Now this inner and outer bow type of the face bow is there. The inner bow is 0.045 inch or 0.051 inch, and the outer bow diameter is 0.72 inches. The outer bow is always thicker so that the assembly is very rigid. And now we come to the concepts. Now I'm going to tell you some tips and tricks. I have not numbered them like Dr. Vyas did, but the tips are very important. This is a question which your examiner asks: the center of resistance of maxilla. And you have got 4 different types of definitions of the center of resistance, but this is a classic article by Stanley Brown in Angle Orthodontics 1999, where he says you can use a blunt instrument like an amalgam plugger, which you put it apical to the distal part of the 6 and rotate it on the cheek, and you feel it from the outside. That is the center of resistance of maxilla. And these are the 4 different ways you can define center of resistance of maxilla. Number 1, this one is by Tuscher. He says the center of resistance of maxilla lies on the posterior-superior aspect of the zygomatico-maxillary suture. Number 2 is definition given by Nanda and Hikari. They say that it is 5 to 10 millimeters below the orbital point on the zygomatic bone. The third one is by Stanley Brown. He says that it is the center of occlusal plane, the orbital plane and the occlusal plane. And this is in relation with the distal aspect of the first molar. This is the most commonly used center of resistance of maxilla. And the fourth one is given by Profit. He says C-res of maxilla is in between the root apices of 4 and 5. The one that we routinely use is 3. Now, every time, these are the references. Every time you cannot just use the amalgam plugger. Nowadays, hardly anyone uses amalgam. So finding an amalgam plugger in the clinic will be difficult. So very simply, this is a clinical tip which I use to determine serous of maxilla. What you do is just 1 centimeter behind the outer canthus of the eye, you drop a perpendicular to the FH plane. And a line parallel to FH plane running from ala to the tragus. So the junction of this is your CRES, clinical determination of center of resistance of maxilla. This is how I do in my clinic. So once you know the CRES of maxilla, you have got one point very important to know. And the second thing, if you understand this concept of LF0, now here O stands for 0, and the long form is zero moment line of force. This is the abbreviation of LF0 is zero moment line of force, where 0, O stands for 0. This concept was given by Contesti and Legan. You have to understand 4 points. Point number 1 is point of origin. Point number 2 is point of application of the force. 3 is the actual force which is applied, or the direction of force which is applied. And 4th is the point of attachment, where the molar tube will lodge your inner bow. That is the point of attachment. So this LF0, you have to join point 1 to the center of resistance of maxilla. Point 1 to the center of resistance of maxilla, from where you are going to pull the elastic. So from this point to the center of resistance of maxilla, you have to draw this. This is the center of resistance of maxilla. So you have to draw a line from here to here. So this is called as LF0, zero moment line of force. For understanding of this concept, you need to understand what do you mean by moment. Moment is nothing but a simple tendency of any object to rotate when some force is applied. If a force is applied here, I'm going to turn like this. If the force is applied here, I'm going to move like this. This is tipping and this is bodily movement. So if your force is applied, orthopedic force is applied on LF0, the maxilla will translate. The maxilla will translate. It will not rotate. The maxilla will not rotate if the force goes through the center of resistance of maxilla. But if the force goes from above the center of resistance of maxilla or below the center of resistance of maxilla, the maxillary occlusal plane is going to cant. It's going to be either like this or like this. So if you understand this LF0, zero moment line of force, then understanding headgear becomes very easy. Now here is the diagram showing you different LF0. In low pull, you have got LF0 like this. This is the point of application of force, and this is your center of resistance of maxilla. So this is your LF0. So in the outer bow, if it is placed here, short outer bow, or medium placed here, or long placed here, the labial, the outer bows will be of different length. But since it is on the same LF0, your maxilla will be translating on LF0. So this is your low pull headgear. In the horizontal pull, again, it is parallel to the occlusal plane. So your mandible, your maxilla is going to go distal. In the high pull, your maxilla is going to be pulled up in the upward and backward direction. Now to decide this upward and backward, how much up and how much back? You have something called as a parallelogram technique. You have to draw a parallelogram, and the diagonal of your parallelogram is going to tell you the actual direction of the movement of your maxilla. And in the vertical, it is but obvious, you will be having more amount of vertical direction than the distal movement of your maxilla. So after knowing these few concepts, the actual thing comes. You have to deliver the face bow and your headgear to your patient. So for that, This is your inner bow, this is your outer bow. You give bends just mesial to the molar tube so that it stops right there. It stops right there. And the distal ends can be slightly put outside or inside so that once you insert in the tube, the headgear becomes fixed there. It gets locked up there so that you do not have that fear in the mind that what if it slips and disturb the cheek. So once you give this bend, you have to bend this so that this outer bow passes from whichever direction you choose, from the center of resistance, from above the center of resistance if you want tipping of the occlusal plane, or from below the center of resistance. So when you want to bend this, you just hold the shoulder joint in a heavy plier and pull it up with your fingertips. You can pull it up. If you hold it firmly here, it gets pulled up very easily. And you get these two ends which are parallel and these two ends which are parallel. The outer bow and inner bow are parallel to each other. So this angulation will be dependent upon which type of outer bow, which place you want to keep it. And then you insert it in the splint. All the cases I'm going to show you will be treated with splints. Now I prefer putting the face bow on the splint like this. This is the way you have seen. The face bow goes out, but I'm going to put the shoulder joint on the splint itself. You can make it here. Because all the cases treated are showing gummy smile. So I am going to correct my gummy smile with the help of this. So I am putting it like this. So after you are wearing this, it looks like this. Once you have done with these things, you have to check the symmetry and the pressure. Yeah, this is through the center of resistance which we have marked. From the bird's eye view, topographic view, check the distance of outer bow to the cheekbone, malar prominences, and then you have to check the force or pressure. This is dynamometer or Dontrix gauge, where the marks are 1, 2, 3, 4 ounces. After the fourth ounce, there's a double line so that you can understand this is 4, 8, 12, and 16. So minimum force that we are going to use on both the sides, total, is 450 grams to 1000 grams. So it is individually 250 grams on one side, 250 grams on one side, to 500 grams. I need to rush fast. Then you actually do the force measurement like this. You ask the patient to hold the front side like this. The face bow shoulder joint will be held like this. And then you hold it very properly here, the head strap, and then pull it here. Just to show you, I have accentuated the reading. This is the point where the hole is going to attach. The force will be there. So this is 16 ounces force, but ideally you're not supposed to give that much amount of force. It will be half the amount, and later on you can increase the force. So this is how you check it. You always mark the center of resistance on the patient's face, and then it will be very easy. So once we understand all these know-hows, then your patient can start using this, and if your patient uses it, the results will be on the way. Look at this. The lips are very much incompetent, and when he smiles, there is almost 12 millimeters of display of gingiva. So after the use of about a year of splint with headgear, you can see the lips are completely competent and the gumminess of the smile is completely gone. I had treated him way back in 2007. When I saw him in 2019, he's still maintaining that much amount of correction. The next case, this case I have taken from a very good initiative of our Indian Orthodontic Society, a book published. The title is Treatment Protocols for Practitioners. Dr. Sadashiv Shetty sir's case with his permission. Look at the gumminess here and look at the changes here. This case was treated with a splint and headgear. This is the case again, same incompetent lips. Now the lip seal, you can make out the change. And you can see the lower incisors are not thin, lower incisors are completely visible. So look at the way your bite is going to open. lower incisors completely hidden. Now they are completely open. Same here. You can see how the bite opens beautifully. Look at this. Hardly any visibility of the lower incisors. Here it is completely opened up. Now this is possible. All the results are possible if and only if your patient uses your headgears. Otherwise, there is no point in showing a photograph of a lovely thali and not to give it to him. Photograph will not work. You have to actually give him a single vada pav, or the time will be of much help. So how to make your patient use this? That is the main problem. हम पेशेंट को देते हैं लेकिन पेशेंट यूज करता नहीं है, पेशेंट कॉम्प्लाइंट ही नहीं है. This is not the way. If you make your patients understand why you have to use it and how you are going to use it, your patients will surely wear this. And trust me, they do wear this, because unless and until they wear, you will not be able to see the results. I have used the word trust. I didn't use the word believe, because there is L-I-E, lie in believe. Trust me, there's no lie. So how to educate your patients? The main important thing is you have to make them understand what the problem is. And if they understand what is the problem, especially the parents, the children are ready to use. But ये photograph देख के parents ही बोलते हैं, अरे बाप रे, इतना सब use करना है, 14 hours, 16 hours, नहीं सर हमारा बच्चा नहीं करेगा. This is because parents ही बच्चे के सामने बोलते हैं कि नहीं करेगा, तो बच्चा तो अपने आप पीछे ही जाने वाला है. So make the parents also understand that you have to do this so that you can avoid surgery later on. अगर आप ऐसा बोलते हो सर्जरी, सब लोग डर जाते हैं. बट यहाँ पे डराना मैं समझता हूँ अच्छा है, because you are really going to avoid surgeries. So how to make your patients understand? You can tell them that if your jaw is growing down and front, obviously your teeth are going to be in the jaws. So if jaws come forward, your teeth are going to come forward. And you can give a simple example of a bus. If you are sitting in a bus and the bus moves, obviously you are going to move. So this is the bus, the jaws, and this is you, the teeth. So if the bus moves, your teeth are going to move. So you stop the bus so that your teeth will remain there. Rest of the things will keep on growing so that your face is going to look balanced. You can tell them like this. Or you can tell them your friends will laugh at you, but it is only you who are going to look like this. And another thing is, if the student or the boy goes to the class with the face bow or with the chin cup, I tell them that for first 5-6 days your friends are going to laugh at you. But on next Monday, if you go without your headgears, everyone is going to ask you, अरे वो किधर गया तेरा? इसका मतलब they are used to it now. So if you use it in the school also, it is better. The maximum time you are supposed to use is 14 hours, 16 hours. But if you use it for all the 24 hours, it's best. The splint needs to be there in the mouth for all the 24 hours, including meals, but headgears, face bows should be from 14 hours to 16 hours to 20 hours. Recent studies say that if you use it only for about 9.5 to 10 hours during the night time, this also gives you good results. Then you can tell them that, I'm sorry, but I cannot wear it for you. Nor your parents can use it for you. अगर आपके लिए पहन के अगर आपका करेक्शन होता है तो आपके मम्मी डैडी ये भी करने के लिए तैयार रहेंगे. But it cannot be done. So you will have to do this. अगर आपको भूख लगी है तो खाना भी आप ही को खाना पड़ेगा. मम्मी डैडी ने पेट भर के खाना खाया, नूडल्स, पनीर चिली, तो आपका पेट नहीं भरने वाला, आप ही को खाना है. So I cannot wear it for you. And you can increase the wearing time sequentially. You can call all the headgear patients on the same day and compare the changes. My palpitations are not changed. You can give small gifts to the kids who are using it properly. They can keep the records of all the things, like I have worn it for 12 hours today. than 16 hours yesterday. They can keep the records and they can show the records. Once you are satisfied, you can give them small gift. एक simple सा rubber भी eraser भी चलता है उनके लिए, but they are happy. माझ्या डॉक्टर काकांनी दिले मला. So they are very happy. So once your patient is well educated and understood what the results are going to be, the cooperation can be of this level. This boy did not like hair raising here and a depression here. So what he did, he shaved off. This is the type of cooperation I get from my headgear patients. And obviously the results must be there. You can see the change. Incompetent lips, where the lip competency is perfectly done, is very happy. The bite is completely properly opened. You can see all the lower incisors very properly. I know this is the third day of our conference. May not be because of my presentation or maybe because of my presentation on a very subject which is sidelined for years together. You might be exhausted, and you are feeling sleepy also. But this can be an eye opener. I'm just going to show you, if your patients are well educated, how little time they take to wear the headgears. He's Hemant. He is going to show us how to wear headgear in 12 seconds. Inner bow in the tubes, splint in the mouth, head straps, force modules, done. 12 seconds. And he's smiling. He's happily doing it. Then you can have Shubham. 13 seconds. Splint in the mouth, straps on the head, force modules, done. Hardly 13 seconds, hardly. And they're smiling. All my patients are smiling. I'm not asking them to smile. I have trained them. She's Nishita. Inner bows in the tubes, splint in the mouth, straps on, forces, done. Sorry. Now this is Kalyani. She has developed her own style of wearing headgear. Oh. See now. The force module is to be put in the face, outer bow. The strap goes on. Now look what she does. Take out the force module, put it in the hole, and then the force module will be stuck in the head strap. They develop their own styles. Harshada. So all of them are taking not more than 13 or 14 seconds. And they're happily wearing it. She's Vaishnavi. Inner bows in the molar tubes, splint in the mouth, 13 seconds. I have got 24 seconds. This is Pranav. Now I'll finish off here because this is the 6th second. Now he is going to demonstrate wearing it and taking it also. Another 3 minutes, chairperson sir. not more than 3 rather. And look at his sister. She's so observant. He's my friend's son. And he is doing it not out of compulsion. He is doing it because he knows that this is the same case which I had shown in the earlier slides. So your patients will happily smile even with the headgear on. So I request you all, I wish that you all gear up for the headgears. Thanks a ton to the COC of IOC who has invited me here, and special thanks to this inseparable jodi of ex-president and president-elect who has empowered an ordinary member with their support to be a guest speaker here. Thank you so much. There. Thank you so much.
Thank you, sir. That was a wonderful presentation. And you made it very simple to understand. And you made to convince us that headgears are not a headache. So
Yes.
thank you for that, sir.
Thank you.
Thank you so much, Nisar sir. Now I would request our chairperson to kindly felicitate our speaker. I would now request Dr. Nandini Kamath ma'am to kindly felicitate as chairperson, Dr. Anand Ambekar sir. I would like to thank all the delegates on behalf of Scientific Committee 56th IOC Pune. The scientific session ends here. We have a valedictory program at 4 p.m. where all the results will be declared. Kindly be seated. Thank you.
Good afternoon, everyone. We all have gathered here for the valedictory function of the 56th Indian Orthodontic Conference, Pune. We've had enlightening last 5 days with meticulous pre-conference courses and prolific lectures and deliberations. We have now come to the culmination of a wonderful conference, which has enjoyed an overwhelming response from delegates all over the country. We now request the organizing secretary of the 56th Indian Orthodontic Conference, Dr. Jayesh Rahalkar sir, to escort the office bearers onto the dais. The president of the Indian Orthodontic Society, Dr. Sri Krishna Chalasani. The vice president of the Indian Orthodontic Society, Dr. Sarabjit Singh. Honorary Secretary of the Indian Orthodontic Society, Dr. Sri Devi Padmanabhan. President-elect of the Indian Orthodontic Society, Dr. Balwinder Singh Thakkar. Immediate past President of the Indian Orthodontic Society, Dr. Silju Matthew. Joint Secretary of the Indian Orthodontic Society, Dr. Nyana Shanamugam. Treasurer of the Indian Orthodontic Society, Dr. Sanjay Lab.
We now invite the chairman of the Indian Orthodontic, 56th Indian Orthodontic Conference. Please come up on stage. We invite the Honorary Secretary of the Indian Orthodontic Society, Dr. Sridevi Padmanabhan, to adorn the jewels of the office on the President of the Indian Orthodontic Society, Dr. Sri Krishna Chalasani. Thank you, Madam. We now call upon the organizing chairman of the 56th Indian Orthodontic Conference, Dr. Shailesh Deshmukh, to share a few words about the conference.
Good evening, everyone. Thank you so much for all your support. Dignitaries on the dais, the iOS head office office bearers, thank you for all your cooperation and your support, because these were challenging times because of the rainy season. Thank you all the delegates, dignitaries, the EC members for supporting us, cooperating with us. My team has put in a lot of hard work. If, as I said in my welcome address, if there have been any, we have missed out on anything, my COC on their behalf and from the Pune Orthodontic Study Group, basically, and conference organizing committee, we would like to, please pardon us if you feel something has gone wrong, but we have tried our best. I hope all of you have enjoyed the scientific, whatever we had a great team of scientific deliberations, rather, what are speakers, which were handpicked, selected properly, and I think the scientific sessions went off well, though there were some logistical issues on the first day because of the rains. There was a torrential downpour. We were keeping our fingers crossed that this would not happen, but it just happened. But I think after that, everything went on quite smoothly. So I hope you have learned a lot in this conference of what to do and what not to do, whom to listen to and whom not to listen to. So thank you all. But yes, my team, they have been, I cannot name everyone. Their names will be, we will be felicitating all the organizing committee also. So their names will be spelled out. But thank you, team. Thank you very much. Now, on behalf of the conference organizing committee of the 56th Indian Orthodox, we would like to felicitate the dignitaries on the dais, the iOS office bearers. First, President Sri Krishna Chalsani. Huh? Oh, okay. Yeah. Honorary Secretary, Madam, the Chief Executive Officer of the Indian Orthodontic Society, Professor Dr. Sri Devi Padmanabhan. President-elect, Dr. Balwinder Singh Thakkar. He was my vice president. So, special bond. Most, yes, no, no, sir. The Joint Secretary of the Indian Orthodontic Society, a silent but an extremely hard worker, a very humble person, and he's loved by everyone, Dr. Nyana Shanmugam. And Treasurer Dr. Sanjay Lab, his achievements have been for the past, how many years? 3 years now as treasurer. I know it was a humongous task, and you have got iOS out of troubled waters, and you have won an election also. Hats off to your stamina. Congratulations.
We request the Honorary Secretary of the Indian Orthodontic Society, Dr. Sridevi Padmanabhan, to announce the prizes for the competitive papers, posters, and table clinics.
Before I announce the prizes, I would like to take this opportunity to thank the organizing committee of the 56th IOC, led by my dear friends, Dr. Shailesh and Dr. Jayesh, the scientific committee, Dr. Ajit Kalia, Dr. Gauri Madam, and all of you for the wonderful time that we had here in Pune. And to all the iOS members here, I would also like to take this opportunity to say thank you for all the help, the support, and the affection that I've had throughout my tenure as Honorary Secretary of the Indian Orthodontic Society. And it's now my pleasure to announce the prizes. For the competitive paper research category, Dr. Kumar Amit. The first prize goes to Dr. Kumar Amit. We don't have those details here yet. And we don't, we'll put it up on the website very soon. The second prize goes to Dr. Deepak P. And the third prize goes to Dr. Swati Sharma. Clinical category, Dr. Abhishek Ghosh gets the first prize. Dr. Sarvaraj Kohli gets the second prize. That was a very dramatic entrance. And the third prize goes to Dr. Shiv Agarwal. Clinical innovations category, there is just one prize and it goes to Dr. Sharwari Vichare. Competitive poster research category, the first prize goes to Dr. Shantini Priya A. Second prize goes to Dr. Bhagyalakshmi A. And the third prize goes to Dr. Badrinath Srinivasan. Clinical category, there is just one prize and it goes to Dr. Vinny Arora. In the general category, there is one prize and it goes to Dr. Rajat Mitra. Table clinic, clinical category, there is one prize and it goes to Dr. Vasu Patel. And in the research category, the table clinic prize goes to Dr. Parameshwaran TM. Thank you. Once we get these finalized results, it will be handed over to the new secretary to put up on the iOS Facebook page. Not my problem anymore.
We now request the organizing secretary of the 56th Indian Orthodontic Conference, Dr. Jayesh Rahalkar, to announce the e-poster and reels for public awareness by student prizes.
Thank you very much. One announcement, the prizes which are declared for the scientific category will be handed over and distributed at the inauguration ceremony of the next conference. Now, at Meerut, that is 57th IOC to be held at Meerut. This year, with special permission from the head office, the COC requested them that as students can't present any scientific posters or any paper presentation in the conference, we requested them that if we can have a category of public awareness. And yeah, and last 2 days we are talking about, in fact, in inauguration also, the chief guest mentioned about public awareness. The president also mentioned about public awareness. So we thought, why not to make our postgraduate students who have excellent brains to do something about public awareness. So we decided that this time we'll have e-poster and reels competition for the postgraduate students so that their participation also can be boosted up by a little bit of enthusiasm with the pat on their back. So we decided to have e-poster in 3 categories and reels. It was orthodontics by orthodontist only, orthodontist, your smile architect, and about unsupervised aligners. And the reels didn't had any particular thing. So reels were, we basically decided to have it on 3 categories, but in reels we got less numbers. So we merged everything. And so I'm announcing the winners. In the competitive reels category, the third prize goes, if that particular person is here, please come because these certificates will be distributed here. Mr. Vaibhav TD. I request the president and secretary to please, I request the president, sir, to give the prize. The second prize goes to Rama Raji Shankar Narayanan. not there. The first prize in the competitive, I mean, in the reels category goes to Rishika Agarwal. Yes, someone on her behalf can please. Ah, yeah, yes. Okay. So I request Dr. Vinit. I think he's the actor in the film. And we request the iOS that we'll be handing over these reels, looking at the content legality. If you can post it on the Insta page of iOS. Now coming to the e-posters on the topic by orthodontics by orthodontist only. The third prize goes to Dr. Stella Kapoor. Is she around? Second prize goes to Sinera Sheikh. Please come. Dr. Ajay Kubawan. And the first prize goes to Akshata Joshi. From the category for orthodontist, your smile architect, the third prize goes to Manasvi Kashyapa. She there? Second prize goes to Shrikant Sharma. Alright. And the first prize goes to Garima Sharma. And the third category about unsupervised aligners. The third prize goes to Guru Prasanna Sahu. Okay. Second prize goes to Variya Mridul. And the first prize goes to Surekha. Thank you very much. Those who are not here can collect the certificates of the prizes from the COC whenever it is possible. Thank you.
Thank you so much, sir. Thank you, ma'am. We now request the President, Indian Orthodontic Society, Dr. Sri Krishna Chalasani, and Honorary Secretary, Indian Orthodontic Society, Dr. Sri Devi Padmanabhan, to kindly hand over the plaques to the COC office bearers.
Okay. As Dr. Shailesh Deshmukh sir said, um conducting the conference of this tune wouldn't have been possible with the enormous efforts put in by the conference organizing committee. So I request the president and the secretary to acknowledge their work and felicitate them. I start with the scientific committee because as the scientific content is the main backbone of any conference. So I request the conveners of Scientific Committee, Dr. Ajit Kalia and Dr. Gauri Vichare. I request Dr. Ajit Kalia and Dr. Gauri Vichare, both the conveners of Scientific Committee. I request all of you to put in a big hand for them. Excellent work. The meetings in front of the house and the clinic of JW Marriott. The pre-conference venue was JW Marriott in front of Dr. Vichare Madam's clinic. That is how the address was put up. So thank you, Ajit. Thank you, Vichare Madam, for enormous efforts. I request the next, the scientific co-convener, Dr. Salil Nene. He had been the whole and soul of the competitive section areas. I think Dr. Ajit has distributed and Vichare Madam had distributed the work. So he was taking care of the whole competitive thing. Thank you very much. Pre and post conference conference courses conveners, Dr. Rajaganesh Gautam. Now he has an additional responsibility as vice chairman of IBO also. Dr. Salil and Dr. Rajaganesh were two timing between IBO and iOS, by the way. Dr. Sonali Deshmukh. Between her hectic duties of heading the department, clicking excellent pictures of birds, thank you, Dr. Sonali, for all your help. Dr. Sheetal Potnis. Between the college clinic duties and inventing newer implants. Now, one by one, I will call the members of scientific committee. Dr. Vineet Swami. Dr. Anand Sabne. He also has a new profession of mastering the ceremony also. Dr. Juhi Joshi. I would like to acknowledge Dr. Shilpa Farande, who's not here, for helping in scientific committee as well as in the spouse committee. Unfortunately, because of a sad incident, he couldn't be there with us on the last 3 days of the conference, but till midnight on the previous day she was work. So please put in a big round of applause for Dr. Shilpa Farande. Dr. Shilpa Jamenis. Like Dr. Anand, apart from a scientific person, she is a professional master of ceremony. Dr. Naseem. The smiling face of the scientific committee. Now the fat man of the scientific committee, Dr. Sanket Agarkar. Fat and the smart with the salt and pepper look. Okay. Another feather in his cap. In POSG, we have one more diplomate of Indian Board of Orthodontics. Soon we all POSG will be IBO diplomates. Dr. Mrunali Trambake. You get a call of Mrunali. You think, okay, this probably some certificate needs to go in that particular room. Dr. Meenakshi Gavankar. When I used to get a call from Meenakshi, I have to think of a chairperson. Dr. Achal Agarwal. The commando in all the scientific halls. For a conference to the tune of around beyond 2,200 registration, the registration committee has to be very strong and very nicely headed by a very strong worker of iOS and our POSG. Put your hands together for Dr. Anand Tripathi. After the meeting, whenever Anand used to come and meet, I used to had an idea, okay, now he's going to come out with another idea of increasing the registration. Dr. Apurva Sahu. Is Apurva there? He's also our umbrella man. He's the person responsible for making this umbrella. About the umbrella, the color of the umbrella was the blue of the iOS logo. Dr. Ravindra Manerikar, sir. Is here. Dr. Anand Sondankar. Yes. Dr. Anand was the strong security at the registration area. We thought there could be some theft, so he said, sir, you don't worry, I'm there. Thank you, Anand. Dr. Amit Kavedia. He's not there. Dr. Amit is not. He's not there. The trade has been a fantastic part of this conference, and the trade committee headed by none other than Dr. Ashwit Hegde. Put your hands together for Ashwit. Ashwit and his team has done stupendous job. The traders had been really happy. With all the arrangements, our treasurer used to be envious of Ashwit. He used to have more amount of funds than the treasurer at times. Thank you, Ashwit. Stupendous job. And he was supported by his team, Dr. Avinash Bahamuni, Dr. Vasu Patil, Then after Dr. Ashwit sir's work is done, the follow-up phone call peoples and the recovery people, Dr. Savan Punmia, Dr. Tabish contractor, there, Dr. Avdhut Kaduskar, now we have to cut the, sir, President sir is not feeling well. So what we will do, I'll do all the committees I will call together. I request all of you to come together. So So I will call their names, please. The inauguration ceremony events, venue, and whatever the infrastructural support we got from Bharati Vidyapit Management, Medical College, Dental College, Engineering College, and the all the campus was coordinated by this particular team. I request Dr. Veera Bhosle, Madam, and with lot of contribution of her own efforts, using her contacts, also contributing in the spouse program, Dr. Madhura Kurd. Dr. Harshal Patil and Dr. Sukumar Lipare. There are few people, like, in police, the people work in buddies. So these people work in buddy system. Dr. Siddharth Chinde, not here. I'll be calling the committees together. I request the Transport, Tours and Travels Committee, Dr. Dhaval Oswal, Dr. Anand Sondankar. Are they there? Dr. Kunal? Okay. Okay. Dr. Anand Bansali. They're traveling. Okay. From the Souvenir Committee, Dr. Bhushan, Dr. Siddharth, Dr. Okay, they are also. Dr. Ravina. Please come. From audiovisuals, Are the committee members here? Audio visual, I think, okay. Cultural, Dr. Nilima Kakade. Nice, okay. Dr. Ajay Niturkar. Dr. Abhidnya and Dr. Rutuja, are you there? Okay. From the students' welfare, I request the whole committee to please come up. Dr. Varsha Mirani, Dr. Nimay Devji, Dr. Charvi Devji, Dr. Sonal Sahasrabuddhe, Dr. Nikita, Dr. Ashita, and Dr. Jayashri. Actually, this is a secretariat team which is also helping myself and Dr. Shailesh for all the committee work. But as an added thing, we had given them. Accommodation. From the accommodation committee, Dr. Kunal Mehta, Dr. Amol Farande is there. Dr. Gaurang Patil, Dr. Santosh Bharadwaj. From the secretariat committee, apart from these people, Dr. Kinjal Vadera, Dr. Yash Shah. Dr. Kinjal, please. The flyers which used to come, they used to be texted by Dr. Kinjal at the scare of the chairman. IBO activities, Dr. Renu Bhatkar. Everyone liked the gifts and the mementos. So for the bags and the umbrellas and other thing, I request Dr. Anagha Kakade. Anagha Kanade, is she there? Dr. Anagha Kanade, please come. She's the jute girl. We know that this type of tune of conferences are not possible with the Kuber Maharaj. So I request Treasurer Dr. Milind Darda. Milind के लिए okay बोलो. Whenever we used to feel that we are lacking funds, conduct a meeting with Ashwit and Milind, things used to get sorted out. So the COC used to feel one meeting, they say their funds are less, one meeting say, okay, go ahead, spend. It's because of in between meetings with these two people. Treasurer committee? Yes. It is by Dr. Darda. The cookies and the tea was sponsored in the just before the trade area because of Dr. Milind's brother, Dr. Rahul Darda. Treasurer committee, Anand Prashant Gupta, are you there? Okay. I would really like to thank my joint organizing secretaries, Dr. Srirang Joshi, not there, and the man who took care of printing and publicity, website and social media, and the app. And he was there as a commando whenever I need anything. He was there to be there. Is Dr. Gaurav Gupta.
Dr. Jayesh, sorry for interrupting. This man needs a special round of applause from my voice side also. For Smile Care, innovative idea.
The topics of reels and e-poster was designed by, were thought by Dr. Gaurav, and he said if the reels are made nicely with proper legalities concerned that there is no conflict of interest and other thing, I will request the head office of iOS to use them on the Insta page. So I request Dr. Balvinder sir to take care, and we can every month we can use these reels on the Insta page, and that will be added thing for the public awareness. And any team is not good unless you have a Dhoni. You know whom I'm talking about. Unless the leader of the team puts in a big dose of booster, the team doesn't work. So I call the leader of the team, Dr. Shailesh Deshmukh, our organizing chairman.
शैलेश देशमुख सर के लिए ओके बोलो.
Okay.
Yes, something.
I think this conference is possible just because of the two important pillars what we have is Dr. Jay sir and Dr. Shailesh Deshmukh sir. And a big round of applause for both of them. I think I we what has been there is that most of sometime it happens that when you have a top two leaders and if they have everything in their hand, you don't get so much of freedom to get work. But the beauty about both of them is that they made sure that every team they give a good chance to them so that they can explore different kind of things and then they allow them to expand. So every team actually worked themselves, created out with new ideas and came up with them and then approved those ideas. I think it required a great leadership and so we are very thankful that both of them have given us that openness to work. And
Okay.
I think whatever the success of the conference can be measured in different way. But what we find is that our Pune orthodontic study group, which was definitely a cohesive group, became a very strong bonded group in this conference. So thank you so much, IOS, for giving this opportunity.
We now invite the President of the Indian Orthodontic Society, Dr. Sri Krishna Chalasani, to say a few words about the conference.
What I have to say, a few words means. Will you permit me for an hour? Okay, I think you are permitting me. I won't take much time. When the conference bidded and you have taken over, itself you have won. How there are two genuine people standing in front of the IOS who have come from your side represented. Those are, see the, if you observe, they are on the dais left and right side. So coincidence. The pillars, Shailesh and Jayesh. And if no building will stand on two pillars, right? The remaining pillars are comprised by all of you, all of you. Of course, Milind might say, I will take one pillar. No pillar. You have to share the load. And this conference, lot of expectations people have walked in, really. Because after 3 years, see, there will be minor, small things in our house also. Any function happens. Small things like water, somebody didn't get, this thing that didn't get clogged. But it is the good heart where somebody welcomes you, that warmness when you feel small things doesn't come into picture. Off the record, the chief guest was talking to me, the hall, I think small, 2,000 people, how they fit. I told him on the dais itself, simultaneously, the live telecast being done in other halls also. And many people are even there outside everything. I was explaining the whole thing. I told him it is not people sitting here, it is the people who have come with the love and affection to be there, like our Indian tradition, what says is. And if I go on talking, no, right from so many people, like I can't end up. Second row, no, Nasim, or you say anybody. I mean, like I don't want to lift anyone name, Sonali or anybody like that. So many. Again, I don't want to mention about that small child of Gaurav. I mean to say, I call him as child. Say Raj Ganesh or Anand, two Anands are there if I'm not wrong. Right? One is on this side, one is on the other side. I can see. A lot of people. And Ajit always never comes front. Ajit and Gauri ma'am. A lot of people. What to say? Really, the love you have shown is something like all of us really is overwhelming. And coming to the 21-22 EC members, would you please stand up once if you are in the audience? They have done from their side, each one has, if I go on talking like 35 people, I have to talk, 25, minimum 25. They have done so much work from behind the scene, like we take the credit sitting on the table, head table. But for our credit, the main reasons are there. For example, this gentleman, when the COVID was there, we conducted 200 webinars, 200 above, before IOS started something. And that man quietly sits. I mean, sometimes I might crack some jokes, don't take it personally. He has done fantastic Ajadika Amrit Mahotsav. This man, he never wants any name. That man, of course, next year is taking some name as vice president. And Patna, he has done wonderful program. Sarvaraj takes care of every person personally. Gaurav, sorry, I won't talk about you again. Ah, Uday, he is going to be one of the pillar for the upcoming conference, 2025. Raj Ganesh, from my view and this side, everything. Backside, Vijayata. And there comes the cute Ankit. Sorry, light is not visible much. And anybody? Divya, not to be missed. Great job. He has done wonderful job with his so many animation slides, everything. And there, quietly somebody walked few years back into IOIC as almost highest host. Somebody gained Dr. Padmapriya. She never wants to come in front. Many times I called her. Come front when you are doing work, you need recognition. No, sir. I want back seat. Now also she is sitting in the blast row. Appreciative. And coming to first time, after some time we have taken external members into our committee. Please be seated. External members we have taken. From Army, Dr. Mohit Sharma. Are you around? I want to recognize. This year, from Army personnel also involved. I personally went to R&R Delhi. Great work they are doing. They never come front to display their work. Please visit. Dr. Jain sir is there. He personally takes care of us. Need not be to be a office bearer or anybody. Dr. Mohit, are you there? And another member who has attended almost 450 external member in MBP, Dr. Prasad. Are you around? Mandava. Come here, please. Some time back, we had little bit tough time in selecting the best teachers also. Apart from that, this gentleman was present for almost 400 above seminars. Most of them awake, some might be sleeping. That is a different matter. I recognize you. And everybody is important. Don't think that this thing, but little bit soft corner I have is two persons, Ajadika and Smile Rally. May I ask you both to come here? His name is Dr. Sukhdeep Singh Kalan. He is Gaurav. And coming to head table, are who supported me throughout the year or before that also. If I start from my left side, the cash man. We used to have literally fights. You used to say, no, you can't spend money, 10 rupees also. No? I want to fight with him. I want to spend 10 rupees for the members. He wants to say, I want to save money, 10 rupees for the members only. I used to tell that is for members we have to spend. Both are healthy arguments. And coming to Dr. Balvinder Singh Tucker, for all of you, Balubai for me. No words. And Dr. Jnana Shanmugam. Like you see, before I say something, you are clapping. That means you know about him, this man. Sometimes the even sun hides behind the clouds for some time. Like that, when Madam means Dr. Sridevi Padmanabhan, she is telling me not to tell, so that means I have to tell. She went to UK, that sun clouds, if you think, Madam, sun, Dr. Jnana, PG opportunity, PG convention time, he got an opportunity to excel. He showed his talent. Great job, Dr. Jnana. Actually, he never comes front. He's like a brother to everybody, a good man. And my vice president, our team vice president, my vice president, Dr. Sarabjit Singh, you all know. First his laugh enters the hall, then he comes. And he used to tell, night 12 o'clock you give a job, morning 6:30 he tells, he messages, come on, the work is ready, now you do it. You told me no, now you run. Fantastic man we had, great team. And did I miss anybody? Yes. No, that how can I miss? Past President, Dr. Silju Matthew, you all know, a nice man, matured in all the aspects, and very sweet, never hurts anybody. He was like a brother to me for throughout. And coming to Dr. Sridevi Padmanabhan, see, that's what whole year she was doing. You saw it, no? I I told her also. Sure. Actually, I told. At home and outside also, we can't get beaten. On a jovial note. So she was soft and sometimes outside. At home means my wife, and outside means she beats. Now coming to her, I always used to tell my senior and all, I used to lie to people. She was my junior in undergraduate days. And very supportive in IOS. She proved to the society what a woman can do. Thank you for being with me, Dr. Sridevi. And thanks to everybody for giving me a chance to sit here and serve you to the best of my capacities. Any flaws anywhere in this 1 year, I will take responsibility on my head. Right? Thank you. Jai IOS, Jai Hind.
Please be seated. I apologize for missing to acknowledge one person, the empanelment of our travel partner, Anand Tours and Travels, Mr. Akshay Dhoka. So, Akshay is there or anyone from, yeah. His representative, I request blank. I request our president to just quickly acknowledge his. Thank you, sir.
We now invite the Honorary Secretary of the Indian Orthodontic Society, Dr. Sridevi Padmanabhan, to initiate the proceedings of installation of the new president of the Indian Orthodontic Society.
I've often heard seniors like Dr. Girish Karandikar say that the Indian Orthodontic Society is a continuous process. The members, those who play certain roles, hold certain posts, are just a transient wave in the overall great process of the Indian Orthodontic Society. So we are entering our 56th year, and may I now request President Dr. Sri Krishna Chalsani to install the new incoming president, Dr. Balwinder Singh Thakur, both very dear friends of mine, by adorning him with the jewels of the office. One minute, 1 minute, 1 minute. I would like to be in this picture. Yes. Can I also say 2 lines? It is also with extreme pleasure that I now hand over my roles and responsibilities to my treasurer, Dr. Sanjay Lab, who will take over as the new honorary secretary of the Indian Orthodontic Society. I now invite the new president, Dr. Balwinder Santakar, to invite his team.
Thank you so much, ma'am. Thank you, everybody from Team POSG. Uh, before I invite my EC members, a few words about how the journey started. It was Dr. Shailesh Deshmukh in one of the mid-year conventions when he just discussed about that you can fight for or you can contest for presidential elections. And it was quite a big thing for me, but because all of his push and determination from me and my friends, we could do it. And I thank you so much, one and all, from the committee from across India who made me win the elections. So to officially start the talk, respected teachers, colleagues, and my dear friends, thank you one and all to make me the captain of the ship. Pune and Puneri hospitality was very, very close to my heart. I had only heard this phrase, what goes around comes around. When we were hosting Jaipur conference in 2017, I used to get too many calls from Dr. Shailesh Deshmukh because he was about to take over in Jaipur as a president. So इन्होंने मेरे से बहुत सेवा कराई थी और आज मैं यहाँ पे आपके सामने इनसे सेवा करवाने के लिए आया हूँ. Just on the lighter side, as goes the famous Hindi proverb, Sankalp mein Shrishti hai. I wish and pray that whatever responsibilities are bestowed upon me would be done to the best of the interest of the Indian Orthodontic Society. I'm a clinician. I have left academics 6 years back. The day I was elected for the presidential elections, I was through with the presidential elections. We immediately appointed 2 more orthodontists to work with us for me to give enough time to the society works. In my calendar of events, I have tried to cover pan-India, what all can be done in the different corners of the country. I wish to push the study groups to do maximum activities, for which I have tied up with different companies for their support. And not all the members are able to travel from annual conferences. So that was the reason, like somebody from Northeast may not be able to come to Pune, but we'll try to push the study groups to work and we'll provide all the aid, financial aid as well for the same. I wish to take the public awareness to the next level. It is said that खुद को करो बुलंद इतना कि खुदा भी तुम बंदे से खुद पूछे कि तेरी रजा क्या है. So my intention for more and more support about public awareness is only that we do not ask for anybody. We are a self-sustaining society and we wish to go forward with the same. I wish to safeguard the interests of the society by all means, for which we may have to cross some hurdles, but with all the energetic team of elected EC members, we shall be able to manage all. I'm deeply thankful to my past president, Dr. Sri Krishna Chalasani, my dear brother, the person in need, and Dr. Silju, who's not here, the man with a virtue, Dr. Pradeep Jain, Dr. Girish Karandikar, people with justified solution to all the problems. I really thank you for. A pushing force for me was our vice president, Dr. Chalsani very well said, Dr. Sarabjit Singh, who used to push me for everything that we need to finish up in time. I have my heartfelt thanks to Honorary Secretary, Dr. Sri Devi Madam, and Joint Secretary Dr. Gyana Shanmugam for unfolding many issues and let us know that what hard work actually means. Thank you, ma'am. Thank you, sir. We would keep bothering you indeed. Our dynamic EC has always worked as a family, and that bond shall remain cherished forever. There is no better feeling to get coronated in front of your gurus. So my dear guru, Dr. Kiluska sir, is right in front of me. With all my heart, I bow to him that I would do justice to whatever you have taught to me, sir. Thank you so much for being here, sir. Lastly, many thanks to my family, my wife, Dr. Jaspreet, who has flown all the way from Jaipur just for the coronation ceremony. Dr. Jaspreet Sandhu, all the way from Amritsar. Dr. Nishant, he's an oral surgeon from Jaipur. Dr. Shiva, Dr. Geeta from Jaipur, and all my friends who've come from far and near for this ceremony. Thank you so much. Now I wish to invite and introduce the team, the newly team of elected EC members and the principal office bearers. I would call them by name. I would request to be there. I would request them to be here. the President-elect, Dr. Jayesh Rahalkar. Immediate past President, Dr. Shri Krishna Chalsani. Vice President, Dr. Shailesh Shinama. Honorary Secretary, Dr. Sanjay Lab. Honorary Joint Secretary, Dr. Amit Bharadwaj. Honorary Treasurer, Dr. Munish Reddy. Editor, JIOS, Dr. Vignesh. Editor, JCO IOS, Dr. Sarvaraj Kohli. Editor, iOS Times, Dr. Santosh Ramegowda. This was the team of principal office bearers, starting with the executive committee members, Dr. Jaskirat Singh. Big round of applause, Dr. Uday Kumar. Yes. I apologize, my the ex-officio, Madam Secretary, please join the gang. Dr. Sridevi Padmanabhan, ma'am. Dr. Siddharth Shetty, who's not here right now. Dr. Padma Priya, to take the front seat. Dr. Vijayata Yadav. Dr. Gautam Reddy. Dr. Prateek Chandra. Dr. Ajay Kantilal Kubawat. Guys, you need to keep clapping hard, otherwise I cannot see people who are coming. So if you keep clapping, they get energies to come fast. Dr. Virag Bhatia. Dr. Reggie Abraham. Dr. Sukhdeep Singh Kalo. Dr. Eddington. Dr. Deen Dayalan. Dr. Yudhishthir Palla. Dr. Vijay Adit. Dr. Preetam Mohanty. Dr. Amesh Kumar Golwara. Dr. Anand Tripathi. ये पुणे वाले सिर्फ पुणे वालों के लिए बोलते हैं, मैं देखता हूँ. अच्छा. Dr. Shishir Singh. Dr. Swapna Jayantpuri. Dr. Jitendra Bhagchandani. Dr. Shantanu Khatri. Dr. Vipul Kumar Sharma. Dr. Sheetal Patni. And Dr. Amir Sheikh. अब बताओ बाहर कहाँ ज्यादा इधर बाहर ज्यादा है, इधर बाहर ज्यादा है. So this is the executive committee for the year 22-23. Guys, we'll have a group photograph. I'm sure the photographer would be bugged कि मैं कहाँ जाऊँ, पीछे जाके लूँ, कहाँ से लूँ, but हम कुछ नहीं कर सकते भाई, हम ऐसे ही हैं. IBO chairman Dr. Ashwin Matthews. He sent his message. Okay. Fair enough. So we'll ask the POBs to sit behind. Yeah, right. Fair enough. One photo, please stay back. 1 minute. पहले एक सामने करेंगे फिर. Please stay back. Then we'll go back. Request all the POBs to take the chair, sir. Welcome, sir. Sir. Welcome, sir. Officially welcome all. Sir, please, sir, welcome. Chairs are less, so some would stand, some would stand. So we'll have a photograph. Yeah, we'll have a photograph. Guys, all the EC members, please, 1 second. भाइयों, इस कुर्सी के लिए तुम 2-2 महीने लड़े हो यार. पीछे आ जाओ. If need be, otherwise. नहीं हो जाए. बैठ क्यों? I would get.
Secretary. Left side.
No. Is there?
No. President-elect on that side. On that side, immediate past president. Welcome. Immediate past president. You have three.
This year, we have made an artwork for this year to work. That will be there with the logo of Indian Orthodontic Society. So all the activities, the calendar activities of Indian Orthodontic Society would have this artwork mascot along. So guys, I would request all the principal office bearers to have one each. There is a meaning to this, and this is nowhere a tampering of Indian Orthodontic Society logo. This means I, and which has joined hands, being friends with everybody. At the center, we have the world. So I travel the world for the society. S is for society. Fostering smiles globally is the theme for the year. A big round of applause. I would request all the POBs to keep it straight. And here I means all the EC members, all the principal office bearers, everybody from the EC team. Now, the executive committee was going to be held at 6 o'clock at the boardroom where we had the EC meeting last afternoon. So we would request, you would do the vote of thanks, right? Yeah. Photograph. We'll have a group photograph. 1 second, we sit down. Yeah. Thank you. Thank you.
Now I invite the organizing secretary of the 56th Indian Orthodontic Society, Dr. Jayesh Rahalkar, sir, to propose the vote of thanks.
Respected President, Secretary, Honorary Past Secretary, Vice President, Past President, Joint Secretary, Treasurer, it's my pleasure to give the vote of thanks for this valedictory function and in a nutshell to the conference. I have already spoken about my COC. I would like to thank the iOS head office, the principal office bearers and the executive committee members for giving full support to this particular conference. The Pune Orthodontic Study Group and the members of Pune Orthodontic Study Group who comprise of the conference organizing committee putting their heart in. I would like to thank the management of Bharati Vidyapeeth deemed university for giving all the personnel as well as the infrastructural support for conducting the conference of this particular magnitude. I would like to thank the teaching, non-teaching, technical staff for the excellent work which has been done. I would also like to thank the student members of all the dental colleges which are UG as well as PG students who have supported this. I would like to thank the audiovisual staff led by Prabodh. I would also like to thank the event management team, the Vama events, for doing a wonderful job. Now, as a token of appreciation from COC, I request President Dr. Balvinder Thakkar sir to present a small memento to the team of Vama. So, may I request Swapnil and representatives to please come and receive the memento on behalf of conference organizing committee. Swapnil, Roshan, Prabodh. Come, Swapnil. Take us. ठीक है. Prabodh from audiovisual team. For excellent audiovisual communication and the streaming, and Roshan Mohile for the infrastructural and the trade and the food area, what you have seen. I would like to just acknowledge here, I don't know whether they are here, the caterer, Mr. Ravi Sharora, for doing an excellent gastronomical services to the members. And I thank all the delegates, the guests, students for supporting this particular conference in excellent numbers. And I would like to end my vote of thanks saying, एहसान मेरे दिल पे तुम्हारा है दोस्तों, ये दिल तुम्हारे प्यार का मारा है दोस्तों. Thank you very much.
आपके शब्दों में मैं ऐड करता हूँ कि मैं पल दो पल का शायर हूँ, पल दो पल मेरी कहानी है, पल दो पल मेरी हस्ती है, पल दो पल मेरी जवानी है. मुझसे पहले कितने शायर आए और आकर चले गए, कुछ नगमे गाकर चले गए, कुछ आहें भर के चले गए. वो भी एक पल का किस्सा था, मैं भी एक पल का किस्सा हूँ, कल तुमसे जुदा हो जाऊंगा जो आज तुम्हारा हिस्सा हूँ. तो इन शब्दों के साथ इतने अच्छे कॉन्फ्रेंस को हम खत्म करते हैं. वी फिनिश, वी एंड दिस सच ए superb hospitality, superb and super hospitality from the Pune people. Although this is not customary for me to talk anything, it was sir's, but I took the liberty of your sir. So, and I feel that nobody wants to go away from here. And we also want to be here, but anyway, we have to go for the issue, sir. So,
Now I request everyone to please rise for the national anthem. We all will be singing together.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय जय हे जय 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 हे भारत माता की
जय iOS. iOS के लिए ओके बोलो. ओके.